Hello, hello. Hello. Hello, check hello. Hello. Hello, check. Clear. Mic 1 check clear. Hello. 1, 2, 3 mic testing check clear. Hello. Check, check. Hello. Hello, check. Hello. Hello. Ah. ఆ ప్యాకెట్ ఇచ్చే కంప్యూటర్ check hello. Hollow, check hollow. 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 Hello, check. Hello, hello. Hello, check. Hello.
A very good morning to everyone. I, Dr. Mamta, Deputy Managing Director, Ramesh Hospitals, welcome you all to the CME that brings all stakeholders associated with the management of the heart, the most vital organ in the operating rooms together. We all know theater is an area of surprises and every second being important for the life of the patient. Managing hemodynamic challenges and the unexpected cardiac events, and every second becomes a challenge. In today's CME, we shall share practical experiences, discuss evidence-based strategies to deliver safer care, and I'm sure the speakers and the panelists will bring a lot of insights to the table, and we're looking forward to a great session. Thank you all.
Thank you, ma'am. A very warm welcome to session 1, Preoperative Assessment and Risk Optimization. This session sets the tone for the day, focusing on one of the most critical aspects of perioperative care, that is anticipating risk, preventing complications, and optimizing outcomes. For this session, now I welcome our respected chairpersons of the panel, Dr. Deepthi V, Senior Pediatric Surgeon and Academic Dean, AIIMS Mangalgiri, Dr. Rajesh Y, Senior Pediatric Surgeon, Guntur, Dr. Jyoti Prakash, Pediatric Cardiologist, Ramesh Hospitals, Dr. Anusha K, Pediatric Cardiologist, Ramesh Hospitals, Dr. Bharat Siddharth, Cardiac Surgeon, Ramesh Hospitals, Now, it's my pleasure to introduce the first speaker of the session, Dr. Srinath Reddy. He is the Director and Senior Pediatric Cardiologist at SWIMS, Tirupati. To his credit, he has 3,000 plus cardiac interventions and has played a pivotal role in developing 3 pediatric cardiac centers in Andhra Pradesh. His key areas of interest include pediatric heart failure and heart transplantation. He'll be speaking on pediatric heart in OR, myths, mistakes, and must know. Now I request Dr. Srinath Reddy to take over.
Good morning, everyone. I thank Ramesh Hospitals, Ramesh sir, and all the team for inviting me and giving me an opportunity to talk in this CME. So I'm a pediatric cardiologist. So I've been asked to talk on what about the pediatric heart and what all we need to take care of that pediatric heart. The learning objectives of my talk would be understanding pediatric cardiac physiology, the fundamentals, distinguishing between innocent murmurs and a pathological murmur, what are the applying screening strategies for safe clearance of asymptomatic children into the OR, recognizing myths in congenital heart disease management and apply evidence-based practices, implement prevention strategies for hypovolemia, hyperkalemia, and hypothermia, apply appropriate endocarditis prophylaxis, and enhance perioperative communication and teamwork. So this is a wide group of audience. So you could be a cardiologist, a pediatrician, a surgeon, or an anesthetist, right? All of us are here. But our roles differ based on what we are. For a cardiologist, it could be risk stratification, physiological assessment, monitoring. For a pediatrician, we have to screen, detect, family education, give them appropriate what to expect to the family. As a surgeon, we need to anticipate complications in a pediatric child, management of blood products, coordination within the team, and as an anesthetist giving anesthesia to these pediatric patients, we need to know the physiology, airway, what is different in a pediatrician for a pediatric population, the hemodynamics and monitoring. We can say there are 2 distinct populations of children who are coming into the OR. One is the normal child and the other one is a child with congenital heart disease. Okay, let's see these 2 groups, how do they differ? Basically, when we talk of children into the OR, they differ from the adults. As we know, the cardiac output is the product of heart rate and stroke volume. In adults, the cardiac output is stroke volume dependent, whereas in children, it is actually heart rate dependent. So if your heart rate in a child in the OR decreases, that means the cardiac output is significantly low, okay? So bradycardia in children can cause cardiac arrest. Be careful. The neonatal or the pediatric myocardium is different, or it is very immature compared to the adults. They have a fewer contractile elements, so they have reduced force of generation. They have a flatter Starling curve. Okay, so if you give more stroke volume, the cardiac output is not going to improve, unlike the adults. The sympathetic innervation is not complete. They are RV afterload sensitive, and they have a higher metabolic rate, so their cardiac reserve is lower in smaller children. The RV characteristics are also significantly different. They are thin-walled RV. It has a limited contractile reserve, highly sensitive to afterload. So any change in pulmonary vascular resistance, like hypoxia, will increase the PVR, hypothermia will increase PVR, and hypercarbia. We need to be very careful. Always, a child is not a small adult. Okay, you can't put the same formulas of an adult into a small child. A 7 kg child versus a 70 kg is completely different. We can't put the same thing. So there are a lot of physiological changes, and that's why this topic is here. In the normal children, we do see on our OP practice, or as a pediatrician or an anesthetist, we auscultate, we hear murmurs. So what is an innocent or a safe murmur? If you look at the data, sometimes we hear about 60 to 70% of children, a normal child can have a murmur. So all murmurs are not dangerous. Okay, so just because a child has a murmur, just don't think that he has a congenital heart disease. An innocent murmur is a soft blowing, soft quality early or mid systolic murmur. There is not associated with any clicks. The second heart sound split is normal. The child is asymptomatic and normal pulses. So this, in the innocent murmurs, we don't need to evaluate further. What are the pathological murmurs which we need to evaluate? Anything which is loud, okay, harsh, holosystolic or pansystolic, any diastolic murmur, we need to be careful. Any thrill, we have to be careful. Abnormal split second heart sound, we need to be careful. Okay, the child is symptomatic associated with a murmur, be careful. Okay, look at the pulses, lower limb pulses, is there a difference? Any weak lower limb pulses, need to be careful. Any hepatomegaly, suggestive of right heart failure, be careful. So these are the red flag signs, especially when a child whom we take before a surgery. Child who is having decreased effort intolerance, okay, compared to the peers. To the sibling, the child is getting easily fatigued, you look after it. Any history of syncope or pre-syncope, especially on exertion, not at rest, and exertion is a red flag. Okay, exertional dyspnea, I already told. Failure to thrive. Family history of sudden cardiac death. Okay, this is a red flag sign before we take this child into the OR. Any signs of heart failure is also a red flag sign. The second group of children is the group with congenital heart disease. In this, there are a lot of myths and before we take these children for surgery. So a cyanotic heart disease, a lot of them, or a lot of anesthetists or pediatricians or the cardiologists are very scared to take them into the OR. Okay, but if we maintain the preoperative saturation, or if we ensure the saturation is maintained, okay, then those children we can safely do any, like a hernia surgery or any phimosis, any risk. Any emergency needs to be done, we need to do. But what we need to remember is, whatever the baseline saturation, for example, a tetralogy has a baseline saturation of 80-85%, we ensure that that saturation is maintained. We need not aim at 9500, which is not possible. Okay, so we also look like, suppose ventricular septal defect is there. If we give too much of oxygen, that will increase the left to right shunt. So it indeed can worsen the child. And not all cyanotics need prostaglandin infusion. Okay, that's a myth. So only it's the duct-dependent circulation lesions which need a prostaglandin infusion. If you are in doubt, you can confirm with a cardiologist. Induction agents, yeah, we should be very careful, especially those which reduce the systemic vascular resistance, SVR. Okay, so the safer one would be something which can improve your keep your systemic vascular resistance at bay. So ketamine most of the times keeps up this thing, but whereas if you use isolated midazolam or when we use propofol, it can cause significant fall in pulmonary it can significantly cause fall in systemic vascular resistance. Another very common mistake which we miss is anticipating hypovolemia. In children, they are very, very sensitive to hypovolemia. Okay, one of the leading cause of cardiac arrest is hypovolemia. So the prevention strategy would be anticipate the losses, be prepared to have packed cells, FFPs before any incision. Okay, if the child is having borderline, he is borderline anemic. Okay, don't think like an adult. Child are very sensitive, so keep backup blood transfusion. Always monitor blood pressure, heart rate, and saturation, and urine output. Other two mistakes which we commonly make in the OR is not noticing hyperkalemia and hypothermia. Hyperkalemia, yes, because the reserves, the children reserves are so low. Okay, any massive transfusion, as you know, a packed blood cell, if you keep a PRBC transfusion, delayed transfusion or older transfusion beyond 72 or 96 hours, the amount of potassium in that bag is going to be significantly higher. Okay, it rises almost 1 milliequivalent per liter every day. So a normal serum potassium, if you say 3.5 to 5.5, bag stored bag which has more than 96 hours which is stored, a old PRBC, if you transfuse, the potassium in that blood is almost 8 to 9 milliequivalents, and it continues to rise. So be very careful, especially in children, when we are transfusing packed blood cells which are of older age, more than 7 or 10 days. So always be transfuse fresh PRBC whenever is possible. Hypothermia, very common in neonates and children. Okay, the pediatric surgeons and all of us anesthetists, we all are very careful, but as that needs to be red flagged into us. Okay, it can occur to 60 to 90% of children when we are in the OR. So how do we prevent? Okay, it can be reduced. Hypothermia events can be reduced to less than 10% by ensuring that we have a proper pre-warm the OR, making appropriate temperatures 22 to 24 degrees Celsius. Okay, we can keep warmer blankets. Okay, avoiding minimal skin exposure, and ensuring not as soon as you finish the surgery, even in the post-op, post-op ICU, we should continue warming and keeping these children away. NPO guidelines, it's not like adult, all of, we write midnight, NPO from midnight or like that, okay. In children, we have to be little liberal, okay. There are various guidelines where we need not have 6 hours NPO, okay, especially neonates and small children, okay. We can give clear fluids for up to 2 hours, okay, some water, and also breast milk is acceptable for up to 3 to 4 hours, okay. And definitely, as in adults, we don't give formula feeds or solids for up to 6 hours. Liberal NPO guidelines is very, very critical, especially in children like with cyanotic congenital heart disease. If you keep them nil per mouth and they get hypovolemic, they can end up in a cyanotic spell. Even pre-cardiac surgery, okay, we have to be very, very liberal in giving, keeping these children with NPO, okay. So for a congenital, if you are taking up a congenital heart disease patient, what we need is, number one is definitely a skilled personnel for monitoring. Continuous ECG monitoring is recommended in the operation theater. ECG monitoring along with SpO2. If you are ventilating, EtCO2 monitoring is very important, because as you know, if PCO2 increases, it can increase the pulmonary vascular resistance and worsen the underlying cardiac cause. Maintain the core temperature of a child. Never allow hypothermia in the OR. Okay, if possible, if it is a major cardiac surgery or a major cardiac surgery, definitely we put arterial lines, but a major long surgery, pediatric surgery also, better to have an arterial line and ensure we maintain the potassium, hematocrit, glucose in the OR. Another main question is, do all children require infective endocarditis prophylaxis? Because this is one of the most common reasons when a pediatrician or anesthetist or a surgeon think of, okay. So the current guidelines is that infective endocarditis prophylaxis is recommended only for very, very limited number of children. The reason behind it is that the amount of microbia within the mouth, and the simple thing like a general daily brushing causes significant microorganisms, okay, into the bloodstream. that itself is a very, it's a normal thing. So for infective endocarditis prophylaxis, we need only for 4 high-risk conditions which needs infective endocarditis prophylaxis. That is, those who have previous history of endocarditis, a child with unrepaired congenital cyanotic heart disease needs endocarditis prophylaxis, any patient who have a prosthetic valves, even in adults, okay, any patient who have a prosthetic valves need a infective endocarditis prophylaxis, and also the complex cyanotic lesions, okay, unrepaired complex single ventricle. These are the only 4 high-risk category which needs infective endocarditis prophylaxis. And we all know the dosing. We should know for both penicillin sensitive and penicillin allergic patients. And it's a single dose. So not to give too much of infective endocarditis prophylaxis, otherwise we'll be ending up in having microbial resistance. We also, when we take care of children, we also need to understand the balance between the pulmonary vascular resistance and systemic vascular resistance. And as we know, the pulmonary vascular resistance is 1/10 of the systemic vascular resistance. So the goal for a congenital heart disease patient is to maintain the balance, the ratio, what was present before we take the patient into the OR. Continue to have the same oxygen saturation, ensure the CO2 is not too high. And if you do that, the PVR-SVR ratio will be maintained. This we know, if increasing FiO2 will decrease the pulmonary vascular resistance, so it will increase the left to right shunt, so we need to balance. Increasing PCO2 or hypercarbia will cause increased pulmonary vascular resistance, so you will have a right to left shunt. And again, increasing temperature, okay, will cause fall in PVR and the vice versa. So as a preoperative assessment, the key questions is, in a child with congenital heart disease, is the cardiac diagnosis a simple or a complex? Whether the child underwent a cardiac surgery before, what is the current hemodynamic status? Is he hemodynamically stable? Is the child is he on any ACE inhibitors, diuretics, digoxin, which can worsen the cardiac or the surgical outcome? And is there any history of recent infections? Okay, any viral infection, or is there any fever? These are the key questions which we take before we take a child to the surgery. Communication is very important because it's a teamwork. The communication between anesthetist, pediatrician, okay, surgeon is very important. So before surgery and during and after surgery is very important in these children. So the cardiologists, pediatricians, surgeons, and anesthetists, they have different roles, and they, based on what is their role, they need to communicate and ensure that the child is coming out. For any successful surgery, it's a teamwork. So it's always better to have a checklist. Okay, we have a preoperative checklist. In a preoperative, you know the diagnosis, brief the team, check the vitals, establish monitoring, ensure that everything is ready, blood products are ready. In the intra-op, ensure maintain normothermia, avoid any bradycardia, monitor for any arrhythmias, anticipate bed loss. Okay, you are seeing that, ensure that blood is there, monitor that monitoring temperature in a child is very important. And it's not that once the surgery is over, we don't leave them. Post-op also, we need to continue to monitor, ensure vitals are all checked, okay? Labs, potassium, blood gas are very important, and we need to have a clear communication. So communication failure is one of the most common mistakes. So if we have a structured briefing, who, what, when, and where, definitely that communication failure would not happen, and it would help in improved outcomes in these children. Also, inadequate monitoring is one of the important mistakes which we perform, which we do in children post-op. So we have to have a continuous monitoring in these children. Also know who are at risk of, children are at risk of hypoglycemia. So because they have limited glycogen stores, and if you have a prolonged surgery or we have a prolonged NPO period, okay, prolonged cyanotic babies, all this can worsen the cardiac output. Hypoglycemia can worsen cardiac output. So we need to have a prevention strategy. As I told you, we have a liberal NPO, IV fluids, pre-induction checkup, and post-operative monitoring. If you have an active URTI, do you operate on these patients? Okay, definitely they are at a higher risk. Based on the severity, if the child has a fever of more than 38 degrees Celsius, better to postpone the surgery. Mild URI, but the child is afebrile, we can take up based on the risk. Okay, if the child is having residual cough, it's always better to wait, especially in pediatric cardiac. When we take a child into the OR and they put the patient on cardiopulmonary bypass, they can react to the cardiopulmonary bypass and they can have worse outcomes. Okay, so it's better to delay the surgery if they are having viral infection. So a few case examples. A child with innocent murmur, 8-year-old child with innocent murmur, whether we take the patient for surgery or not, what would be the next follow-up? The decision would be to proceed, basically because as I told you, 30 to 70% of these children murmurs can be innocent. A 5-year-old child with repaired tetralogy of Fallot, child wants to have a dental extraction. Do we need an endocarditis prophylaxis? No, it's already a repaired tetralogy. Okay, you don't need an endocarditis prophylaxis. Okay, so you just continue home medications, routine anesthesia, and all that. A child with unrepaired tetralogy, unrepaired transposition of great arteries. Okay, he's very blue, but he has a hernia. He has an obstructed hernia. He comes to us. What do we do? So, as in the OR, the key decisions would be we have to operate because it's an emergency, but ensure the saturation maintains the baseline saturation. Okay, give him endocarditis prophylaxis. Ensure we involve the cardiology team also, and in these patients we have to avoid dehydration and increase anything which increases afterload, because the RV is the systemic ventricle, so we have to be very careful and also avoid hypothermia in these patients. Any child who is having a complex heart disease with residual lesions, suppose a 6-year-old child with hypoplastic left heart, but there are some issues like small residual issues. He has got repaired, but there are some mild residual issues like aortic regurgitation. For that patient, yes, does he need endocarditis prophylaxis? Yeah, because there are some valvular regurgitations. It's a cyanotic patient, complex lesion. So endocarditis prophylaxis is indicated. In these patients, again, hypovolemia, we have to avoid hypovolemia, ensure we monitor the central venous pressure and coordinate with the cardiac team. So another case scenario, a 3-year-old child, there is no cardiac history presenting for any ear surgery. On the day of surgery, child develops fever and cough. Mom says just a cold, what should we do? Should we proceed, or should we postpone, or should we consult a surgical anesthesia team and evaluate urgency? What do you think? The probable answer is, yeah, because there is significant fever, cough, cold, probably we need to better to wait, okay, because there is a risk of airway reactivity and with these patients, and risk is higher. A 5-year-old child, another scenario where 5-year-old child with repaired VSD presenting for same dental cleaning. Should we give endocarditis prophylaxis? Answer is no, it's more than 6 months, so they are at low risk not to give endocarditis prophylaxis. A 9-year-old child with ASD, asymptomatic and normal exercise tolerance. There is a soft ejection systolic murmur. No other findings. He has come for an elective surgery. What do you do? Do you need a further evaluation? Probably ASD is a lower risk, and with a normal ECG, you can safely take up for the surgery. So, to summarize, as a cardiologist, risk stratification is very important. Okay, identify who is at high risk, who is at low risk, assess the anatomy, assess the hemodynamic stability for a surgery. Okay, always the key principles would be, the adult principles don't apply in pediatrics. Okay, so pediatrics, as I said, we have a different risk profile. Like we have to ensure that we have to avoid hypovolemia, hyperkalemia, hypothermia, hypoxia, and all that. And don't think of the coronaries, especially in children. As a pediatrician, we have to empower ourselves to clear safely. Okay, we should not overjump and think all murmurs are pathological. So most 30 to 70% of the murmurs in children are innocent. Okay, we need to document them and ensure that the red flags in these children are not missed as a pediatrician. As a surgeon, yeah, preparation before incision is very important. Okay, if you are anticipating any blood loss, ensure that we have appropriate blood products ready, okay, in a bedside. Ensure that we plan the surgery, okay, in these children. I've also already discussed about endocarditis prophylaxis. We need to be very careful. Preoperative assessment, we have to have a proper checklist, and perioperative guidelines are all well given by a lot of this thing. So the key takeaways from my talk is, in children, the physiology is different. Okay, children are heart rate dependent to maintain the cardiac output, whereas not like an adults where they are stroke volume dependent. Not all murmurs are pathological in children. Okay, most of the murmurs in children, the soft murmurs, are physiological. So you just document and you can clear for surgery. Hypovolemia, be careful. It is one of the most common cause of cardiac arrest. So anticipate and ensure we are prepared. Hypothermia also can kill the child in the OR, okay, or in the post-operative. Be very careful. By planning safe OT practices in these children, definitely we can avoid hypothermia, and multimodal prevention strategies are indicated. Not all children require endocarditis prophylaxis. As I told you, only 4 groups of children require endocarditis prophylaxis. We need to have a clear communication, structured team briefing before each surgery, and especially collaboration between all the subspecialties or specialties is necessary, especially when we are dealing with a child in the OR. Thank you.
Session is open for discussion.
That was a fantastic presentation, Srinath Garu. So for audience sake, I am asking one question. A post-VSD case has, like, it might be a VSD surgical or VSD device, but after 1 year, the patient had with some tympanostomy or something. Both cases have residual VSDs. Which one do you recommend in endocarditis prophylaxis?
Yeah, VSD device is like an implant inside the heart. So yes, if any implant in the heart, we discuss that we need to have a prophylaxis, especially if there are residual. If there's no residual, there's no need of any endocarditis prophylaxis.
Yeah. VSD patch?
VSD patch, if it is a own pericardium, patient-owned pericardium, there's no need. But if at all it is a foreign, suppose some people use a Savage patch. So in that cases, it's better to give. It's a single dose of amoxicillin, so that should be fine. For genitourinary surgeries, nowadays there is no indication for endocarditis prophylaxis.
So pediatric surgical conditions with congenital heart disease is very challenging.
Yes.
And many pediatric surgeons or pediatric surgical centers don't have the luxury of having a pediatric cardiologist to do echo. So we used to face a lot of problems because of that. So in newborn conditions, neonatal congenital emergencies, pediatric surgical emergencies, we don't have an option or luxury. So what we used to do is follow some universal precautions like hypothermia, fluid management, antibiotic prophylaxis, and only in the second stage. So for example, if we get anorectal anomaly, usually there are rectal associated anomalies. Next, esophageal atresia, diaphragmatic hernia. All these conditions, they have associated cardiac issues. Yes. There is pulmonary hypertension, right heart hypertrophy, left heart hypoplasia, and we need to manage fluids. Yes. And again in rectal associated anomalies, esophageal atresia, anorectal anomaly. Newborn period, we can't do anything. So we only can do hypothermia, avoid hypothermia, avoid hypovolemia, not to overhydrate, just operate that newborn emergency, and then postpone the second surgery only after the cardiac surgery. So that is what we used to take your help and guidance, and now Jyoti Prakash is guiding us in Guntur Ramesh Hospital. So anyway, I know it's very challenging, and it's sometimes we lose the patients even in newborn period, in spite of our efforts to avoid all these things, because not many centers are doing neonatal cardiac surgeries. They are postponing.
Yes.
Okay. Thank you, Ramesh Hospital, for giving us this opportunity. It's a very interesting talk.
Just one question with regard to inotropes. Any specific preference you would say in children who require? We know they are fluid dependent, and bolus, we are very liberal in normal children, 20 mg per kg, and we go up to 3 boluses in those who have hypotension. But with the background of cardiac problem also, are there any guidelines with regard to fluid bolus and inotropes that we would select?
Ma'am, that's what fluid bolus, we can't be very liberal sometimes in patients with congenital heart disease. Basically, as I said, also told you that the hypovolemia, even they are sensitive, but overcorrection also is not good. So we need to ensure that the heart rate is better. That will give us a better outcome. So something would be which are safer, which would not increase systemic vascular resistance, but would maintain the heart rate. I would be safer to go with dobutamine. And the next would be adrenaline, dobutamine and adrenaline. We don't want to increase the systemic vascular resistance significantly. Only in those cases where we know it is a septic shock, the child is having a lot of this thing, and we anticipate a lot of blood loss, we go for vasoconstrictors like noradrenaline or vasopressin. Otherwise, dobutamine is preferred, ma'am.
Hello, I am Dr. Durga. Adding to the fasting guidelines, so Indian Journal of Anesthesia 2020 issue 7 says that water can be given up to 1 hour prior to surgery to the children.
Yes.
And other clear fluids can be given up to 2 hours.
Yes, sir.
The recent recommendations for the post-operative early feeding, not the usual what we do in the feeding, so 3 hours, 4 hours, not like that. Whenever the child is active and crying, the child can be fed with whatever the baby takes in the early hours. So that is the early feeding on the post-operative period.
Yes, sir. We have to be very liberal with clear fluids also. As you said, 1 to 2 hours, and depends on the anesthetist. But in our center, especially cyanotics, we prevent prolonged impure times.
Yes, hypothermia is a silent killer.
Yes, sir.
And especially in the neonatal surgeries, where if you have not taken any precautions, that you lose the pulse oximetry, will not show anything because of the peripheral vasoconstriction, and you are traveling in an uncharted sea. So that is a very important parameter to be looked after in the operative time when the surgery is prolonged.
True.
Thank you.
Thank you, sir.
As neonatologists, we prefer the bedside surgeries, sir. As well, recently we did PDA ligation. Our team has done PDA ligation successfully in bedside only, in NICU only they did. That's why we can prevent hypothermia risk and shifting the baby and all those
extreme
things.
Premature, less than 1 kg,
Yes,
yeah,
sir.
it's always better if you can do a bedside PDA ligation.
Yes, sir.
Thank you.
Thank you once, sir. Thank you, sir.
Thank you. Thank you, Dr. Srinath, for an insightful session, and thank you all the chairpersons of the panel for an interactive session. Now we move to the next lecture. For the next session, I invite our esteemed chairperson of the panel, Dr. Mahesh V, Professor Anesthesia and Critical Care, KMC Manipal, Dr. Bhimeshwar, Principal and HOD Anesthesia, Pinamneni Siddhartha Medical College, also past President of Indian Society of Anesthesiology, Dr. H.M. Krishna, HOD Anesthesia, AIMS Mangalgiri, Dr. Shivashankar, HOD Surgery, General Surgery, NRI Medical College, Dr. Ravi Babu, Senior Lab Surgeon, Guntur, Dr. Swarnakant, General Surgery, Aster Ramesh Hospitals, Dr. Bhaskar Naidu, Senior Cardiologist, Aster Ramesh Hospitals, Dr. Fani Rajkumar, Surgical Oncology, Aster Ramesh Hospitals. It's now my pleasure to introduce our next speaker, Dr. T.V.S. Gopal. May I request the esteemed chairpersons to kindly take over their seat on the dais. It is now my pleasure to introduce our next speaker, Dr. T.V.S. Gopal, Clinical Director, Anesthesia and Surgical Intensive Care and Acute Pain Management at CARE Hospitals, Hyderabad. Sir has 17 years of experience in anesthesia and critical care, also a founding and managing director of Exxon Anesthesia Associates Limited. May I request Dr. T.V.S. Gopal, sir, to kindly take the podium and deliver his lecture.
respected chairpersons, esteemed members of the faculty, also esteemed members of the organizing committee, and dear delegates. A very good morning to all of you. This is a topic that is dear to Dr. Mahesh's heart. This is a huge and confusing topic, but yet it is very vital for all of us. And in the time that is allotted to me, I'll try my best to present to you a bird's eye view covering all the salient points. To begin with, certain vital statistics. Across the world, approximately 31.5 million non-cardiac surgeries are performed each year, and 10% of these are performed in the US alone, and of these, 42% are inpatient, whereas 58% are outpatient surgeries. Now, it is interesting to note that in the last 20 years, the overall perioperative morbidity and mortality in these patients from cardiovascular complications has dipped only very marginally from 3.1% to 2.6%. 45% of patients presenting for non-cardiac surgeries have 2 or more cardiovascular risk factors, and in 24.3% of patients, there is a cardiovascular disease that is secondary to accelerated atherosclerosis. And the cost of preoperative testing in the US alone amounts to $18 billion per annum. Now, prior to last year, we were guided by this guideline that was issued by the American College of Cardiology and the American Heart Association in 2014. Now, as per this guideline, there was an emphasis on estimating the functional capacity of the patient, risk stratification, and selective non-invasive testing with the aim of uncovering silent myocardial ischemia such that we do not have any surprises in the perioperative period. And late last year, we came up with this guideline. Now, as you can see, the inputs are much more broader. Besides the AHA and the American College of Cardiology, you also have the American College of Surgeons, the American Society of Nuclear Cardiologists, the Heart Rhythm Society, the Society of Cardiovascular Anesthetists, and so on. Now, as per this guideline, which is in vogue today, there has been a paradigm shift from emphasis on routine preoperative ischemia testing, because today there is data which has emerged to state that uncovering myocardial ischemia in the preoperative period has not actually significantly altered the anesthetic plan or the incidence of postoperative cardiovascular complications or the rates of myocardial infarction. So there has been a shift from an impetus on risk stratification to identifying the risk factors and optimizing these risk factors when time and opportunity present themselves. Now, all of you know about the recommendations and the strength of the evidence. Now, the strength of recommendation can go from class 1 to class 3. And evidence can go from level A, which is the strongest level of evidence, down to level C, which is based on expert opinion. Now, when we look at surgeries, we classify them as urgent surgeries, emergency surgeries, time-selective surgeries, and elective surgeries. Emergency surgeries typically are performed within 2 hours of the patient presenting to the hospital. This is because there is a danger of the patient losing the life or limb in case of a delay. Urgent surgeries, on the other hand, can be performed between 2 to 24 hours after presentation to the emergency. So there is some time for preoperative evaluation and possible stabilization of the patient prior to wheeling into the theater complex. Time-sensitive surgeries are those that can be delayed for about 3 months from the time of presentation with an effort to pre-optimize the patient's cardiac status. Elective surgeries can be delayed indefinitely without affecting surgical outcomes. Low-risk surgeries are those where combined surgical and patient characteristics predict a low risk of major adverse cardiac events of less than 1%. When it exceeds 1%, this is an elevated risk surgery. Now, there is something also called a surgery-specific risk. Now, low-risk surgeries include cataract, cosmetic, and plastic surgeries. Those surgeries where risk is between 1 and 3% would include most orthopedic surgeries, ENT surgeries, and genitourinary surgeries. Those with a slightly more enhanced risk of between 3 and 5% would be general abdominal and intraperitoneal surgeries, as also neurosurgeries. And these surgeries that are to follow have the highest risk. Suprainguinal and peripheral vascular surgeries account for a complication rate of 7.7%, thoracic surgery is 6.5%, and transplant surgeries is 6.2%. This was a meta-analysis that was published in 2014, looking at about 55,000 liver transplant recipients. And about 40.2% of all mortality that occurred in these recipients within 30 days of surgery were attributed to cardiovascular complications alone. Now, when we take a patient with surgical pathology into the theater, intraoperatively, as anesthetists, we know that we face several physiological challenges. There are hemodynamic perturbations, there is sympathetic activation with subsequent release of catecholamines, there is cytokine production and hypercoagulability, which is quite typical of the perioperative period. Now, all of these can combine to give us ischemic myocardial injury, which is either secondary to an acute plaque rupture or mismatch between oxygen supply and demand. You can also have fatal arrhythmias and acute decompensated heart failure. Now, there are certain broad contraindications to non-cardiac surgery, which include patients with recent acute coronary syndromes, acute decompensated heart failure, tachy or bradyarrhythmias requiring medical attention or presenting with significant hypotension, or a symptomatic severe aortic stenosis with a mean gradient that exceeds 40 millimeters of mercury, wherein the luminal diameter of the aortic valve is typically less than 1 square centimeter. Now, when this patient presents to the anesthetist for a surgical evaluation, we do what we call the pre-anesthetic checkup. And that begins with both a comprehensive history to rule out or confirm the presence of ischemic heart disease, a coronary stent, heart failure, arrhythmias, valvular heart disease, systemic or pulmonary hypertension, chronic kidney disease, and diabetes, amongst other systemic comorbidities. And when we talk about physical examination, we focus exclusively on murmurs. Dr. Srinath spoke about those. We focus on diastolic murmurs or systolic murmurs that are exceeding a grade of 3/6. We also have to listen for gallop rhythms, which is an S3 or an S4. Sometimes S3 and S4 fuse to give us a summation gallop, jugular venous distension, basal lung crepitations, pedal or generalized edema, or resting oxygen saturation that is close to or below 90%. Functional capacity is an independent predictor of preoperative morbidity and also perioperative morbidity. Therefore, it is important for the anesthetist to evaluate the functional capacity of each patient. If the patient can independently perform their daily activities or chores, that is equivalent to 4 METs. A MET is a metabolic equivalent of task, for the sake of juniors in this audience. You can also resort to the more complex Duke Activity Status Index. Now, based on functional capacity, the patients are divided into dependent, partially dependent, or totally independent. So, poorer the functional capacity, more the problems in the perioperative period. Since I'm pushing 63 years of age, if anyone tells me that old age begins at 65, I will vehemently disagree. Age is just a number. I think it is the presence or absence of frailty that makes the difference. I mean, there are so many frailty scores that one can resort to, but all we need to look at is the patient's physical build, gait, speed of ambulation, and balance. And that gives us a certain indication on whether the patient is frail or not. Assessing frailty is important because data is emerging today to support the utility of both nutritional rehabilitation and exercise in improving outcomes in these patients following non-cardiac surgery. Frailty is typically associated with age above 75 years. In these subset of patients, there is a decreased sympathetic response to stress, also reduced vascular compliance, impaired baroreceptor reflexes. There is cardiac diastolic dysfunction in most of these patients. Symptomatic aortic stenosis becomes more and more prevalent with advancing age, and these patients are also prone to non-cardiac complications such as perioperative infections, respiratory failure, or perioperative acute kidney injury. Now, after having assessed the patient in terms of history and physical examination and assessment for functional capacity and frailty, we look towards risk stratification, because risk stratification helps the anesthetist quantify perioperative risk. And the American Society of Anesthesiologists Physical Status Classification is an excellent index. And as per a particular meta-analysis, it has been revealed that the possibility of perioperative cardiovascular complications is less than 0.1% in ASA grade 1 patients, going to as high as 18% in ASA grade 4 patients. And these, as we know, are the sickest category. Now we move on to the other risk stratification indices, the oldest being the Goldman Index of Cardiac Risk, which was unveiled to us in 1977. Though there are so many indices, at this point of time, there is no evidence to support one index over the other in terms of superior predictive discrimination. We tend to follow the revised cardiac risk index, which is based on 6 criteria: ischemic heart disease, cerebrovascular disease, history of heart failure, insulin therapy for diabetes, serum creatinine wherein the level exceeds 2 milligrams per deciliter, or a planned high-risk procedure. Now, for all of these criteria, 1 point is assigned. The patient with the lowest risk is one who does not have a single of these 6 criteria. And when the patient has 3 or more criteria, they carry the highest risk for perioperative complications following a non-cardiac surgery. A 12-lead ECG is useful, especially in a patient who has arrhythmias, or when we uncover a pathological Q wave, ST segment depressions, left ventricular hypertrophy, a QTC prolongation, or a bundle branch block. It does not have any benefit in asymptomatic patients undergoing low-risk surgical procedures. A routine preoperative resting 12-lead ECG is not recommended to improve outcomes. But for asymptomatic patients undergoing elevated risk surgeries with known cardiovascular disease, a preoperative 12-lead ECG may be considered to establish a baseline and guide perioperative management. Now, two-dimensional echocardiogram is also useful in those patients with known or symptoms suggestive of following, which is heart failure, valvular heart disease, known left ventricular systolic or diastolic dysfunction, known congenital cardiac disease, or those with pulmonary hypertension. In asymptomatic and clinically stable patients undergoing non-cardiac surgery, there is no benefit in routinely evaluating preoperative LV function in the resting state. As far as 1996, that was so many years ago, the AHA-ACC perioperative assessment for non-cardiac surgery guidelines clearly indicated that routine preoperative stress testing was not warranted. In spite of that directive, this particular study showed that approximately 50% of patients with no cardiac risk factors undergoing total hip or total knee arthroplasties had preoperative stress testing. So this is a complete non-adherence to the prevailing guideline. As for this current guideline is concerned, there is only a class 2B recommendation for stress testing in elevated risk patients with poor or unknown functional status. A CT angio is performed quite often. In fact, I get one every 5 years. And this is useful only in those patients where we wish to uncover significant high-risk coronary anatomy. That is, more than a 50% occlusion of the left main coronary artery or more than 70% occlusion of the 3 main coronary branches. But in patients who are at low risk for perioperative cardiovascular events, having a good functional capacity with stable symptoms, it is probably not advised. It has a very high negative predictive value in the sense that if the CT angio is normal, then we can take it for sure that the patient's coronary anatomy is okay. But if the patient does have a lesion, it is likely that a CT angio overestimates the risk, and then we will also have to follow up on these patients with the traditional invasive angiogram. Now, biomarkers have come in and made a presence in this particular guideline. Now, we have brain natriuretic peptide or an alteration of BNP, which is called N-terminal pro-BNP. These are peptides that are released by the cardiac myocytes in response to atrial stress. And you also have cardiac troponins, which are an indicator of myocardial injury. Now, in patients with known cardiovascular disease or age above 65 or age above 45 with symptoms suggestive of cardiovascular disease undergoing high-risk non-cardiac surgeries, it is reasonable to measure both BNP as well as cardiac troponin in the preoperative period. And there is a new term now in the new guideline, which is myocardial injury after non-cardiac surgery. That is, if we compare the preoperative ECG to the immediate postoperative ECG, there are fresh changes in the ECG. And in this patient population, it has been advised that we do a surveillance with cardiac troponins once every 24 hours for the first 48 hours. Coronary stents, we all know, we delay a non-cardiac surgery for 2 weeks following a balloon angioplasty, for 30 days following the placement of a bare metal stent, and 12 months following a drug-eluting stent in situ. But today, data is emerging to state that maybe 4 to 6 months' time is enough after placement of a drug-eluting stent. Now, with this background information, let us look at the algorithm. A patient with cardiovascular risk factors is scheduled for non-cardiac surgery. And it is an emergency surgery. So there's absolutely no time. So we proceed with surgery after having counseled the patient and the family. But if this patient is not presenting for an emergency surgery, then we do a thorough perioperative risk assessment. So during pre-op evaluation, we look at the history, the physical examination, we assess for functional capacity and frailty. We look at the type of surgery, whether it's a low risk, intermediate risk, or a high risk surgery, and then we use a verified risk calculator. We typically use the revised cardiac risk index to be able to stratify the extent of perioperative risk. Now, if the patient has a low calculated risk, we proceed with surgery. But if the patient has an elevated cardiac risk, it is advised that we do a 12-lead ECG. In most instances, the patient's 12-lead ECG is already done. And the next question we need to ask is there a poor functional status or frailty? If no, we proceed with surgery. If yes, then we need to ask ourselves whether a further testing will impact decision making. If the answer is no, we proceed with surgery having explained the risks and benefits to the patient and the family, or when time is available, we optimize risk factors, or if the patient's family is unwilling, we offer them non-surgical alternatives. And finally, if the patient is very high risk, then we will have to offer a 2D echo and also consider a cardiac stress testing. So with this, I'll just present and wrap up with 3 surgical case scenarios. This is a 58-year-old male weighing 92 kilos with history of hypertension and diabetes since 10 years, with bilateral knee joint arthritis with restricted physical activity, posted for right total knee replacement. I mean, this is a daily bread and butter scenario. We evaluated the patient, we said we can go ahead with surgery, but the cardiologist was involved by the orthopedic surgeon. They performed a 2-dimensional echocardiogram and we went ahead. Now, this is a 62-year-old female weighing 122 kilos with a BMI of 44.3, hypertension and diabetes for 26 years, poor blood sugar control quite lately. Patient was diagnosed with obstructive sleep apnea, is on domiciliary BiPAP. Room air saturation was only 84% when we evaluated the patient. So this being a bariatric surgery, there was no requirement to rush through. We referred the patient to a cardiologist. A 2-dimensional echocardiogram was done. The mean PA pressures were bordering around 40 millimeters of mercury. This patient was placed for 6 weeks on a combination of ambrisentan, which is an endothelin antagonist, and also tadalafil, which is a phosphodiesterase inhibitor. And when she came back to us, the echo was repeated. The PA pressures had come down, the peak pressures had come down, the systolic pressures had come down to less than 25, and the room air sats had gone up to 92, and we were able to do the surgery. Now, in this case, it was a 40-year-old male, chronic smoker. He had an abnormal ECG on routine evaluation, investigated with CT angio, followed with a routine traditional angio. A drug-eluting stent was placed to overcome a lesion in the ostial LAD 4 months ago on dual antiplatelet therapy, and this patient presented with an acute abdomen. So there was no time to consider anything. We explained the risk to the family, we spoke to the surgeon, we put in an arterial line for monitoring. We did a crash induction on this patient because this was an acute abdomen. We did a laparoscopy, and a very inflamed appendix that was about to burst was taken off. Local peritoneal toilet was done, a drain was placed. The patient did well and got discharged after 2 days. So thank you very much for your attention, and apologies for just about crossing the time limit. Thank you.
Thank you, sir. Now I request, if time permits, we can go ahead with some discussion.
Hello. A small scenario which I require your opinion, sir. A 50-year-old female who underwent aortic valve replacement in 2008 now presented with cerebrovascular accident, which is of minor grade, to the neurology department. At the same time, after admission, they found a large hematoma in the abdominal wall, which is of 17 into 10 centimeter size. So, in this scenario, how to tackle is a problem for us. As a surgeon, we found is a big hematoma. I have to evacuate hematoma, otherwise, either she may go into sepsis, or the large hematomas, they end up in fibrinolysis and Dick syndrome. So to give anesthesia, her lungs are very wet. So what is the outcome? Simply I did under local anesthesia only. I evacuated the hematomas and I kept a drain. Now she is doing the same old. That means she is accepting foods and see a little bit. In this type of cases, they are not routine. At times they will occur. Have you got any experience with this type of cases?
Unfortunately, I do, sir. I was as a tertiary referral institute with a strong presence of cardiology. So patients do come to us because they believe more that the cardiologist can take care of them than the anesthetists. So if we have to give general anesthesia to these patients are likely to be on anticoagulants, more likely to be on azenocumarol or warfarin. We have to assess the prothrombin time and the INR, and time permitting, we have to correct that by giving vitamin K and FFPs to this patient. Try and bring the INR as quickly as possible down to 1.5 or thereabouts. And if it is an anterior wall hematoma, sir, I would believe that you have time on your hands. If it were a retroperitoneal hematoma, then maybe you would have to move in very quickly. And today, thanks to ultrasound, thanks to the ability to perform ultrasound-guided tap blocks and so on, we will be able to pull off these surgeries without resorting to GA alone. But then bleeding risk is an ever-present danger, and we must be mindful of that.
So we had all these specialties in NRI. This happened in NRI, and we made INR to come back to, she's on warfarin. So we made the INR to come to somewhere around below 2. Now once again we have to start anticoagulants immediately. Otherwise, chance of embolizations are more common, fibrillations are more common as per the cardiologist. My request is, anyone of has got, not only you sir, any one of our colleagues have got they got experience of these type of cases. I want to know what is the outcome, whether the patient succumbed or what is the patient recovered. That is the answer which I want.
Sir, this is a patient who was operated for aortic stenosis. So
I had to wall replacement, sir. It was done, I think 2008, something like that.
So assuming there is no residual stenosis or a new regurgitation, we should not be bothered about the patient's cardiac status. I think that is answerable. Now the patient having wet lungs indicates some sort of borderline heart failure, which we can also deal with in the perioperative period. So I think doing surgery under balanced anesthesia, general anesthesia, is a good option, and outcomes are reasonably well guaranteed. They should do well.
Okay, sir. Suppose if I leave it like that without intervening, 17 centimeters hematomas like that, fearing the cardiac condition, what is the outcome? I don't know. I want to know. The infection, if it prevails, sepsis occurs. That is the worst scenario.
I mean, today, sir, we have different levels of hospital efficiencies. So if we are in a center that cannot handle, I think the sooner we shift this patient to a higher center, that would be better, rather than just sitting tight and not doing anything at all.
Problem is, tertiary center here in this coastal area is, ours is in the recent surrounding districts is NRI with all specialties. So we have to shift her to only Hyderabad, what I say. So the travel she may not withstand, what I feel. She is on SOB. Okay.
I just want to add another dimension to this, in the sense that when you talk about aortic valve replacement, aortic valve is a high velocity area. That is, you have a left ventricular pressure which goes to 150 or 160, and then the aortic pressures. So you don't have to worry too much about giving anticoagulants in this patient. Even if you just give ecospirin, that is enough for the next few days. Nothing will happen to the valve. It's not the same story when you talk about mitral valve. So one of the things I would have done, like Dr. Gopal said, that yes, definitely a regional block is the best option. And if you are giving GA, I think I would not go back to warfarin in the first few days. Maybe I'll give ecospirin and then restart the anticoagulants with Clexane or something like that.
Okay, sir.
Yeah.
Can I add two things I would like to add here? One is I would like to evaluate what is the cause of weight loss. That's one thing. Secondly, when you are talking about the aortic wall, as Dr. Suresh has just mentioned, you need not to give warfarin. You need not. It's only the initial 6 months that is when it is needed. Or some people, they give it only for 3 months, maximum 6 months, and thereafter they switch on to ecospirin. So I don't see it is if the patient was taking warfarin for such a long time, that was not correct.
Maybe, sir, because I am a surgeon. Just I have attended the emergencies. That's happened.
I mean, you see, this is the perspective of from the cardiac surgeons and cardiac anesthesia side, that you do not need to give that much of anticoagulation after aortic wall replacement. You have not mentioned whether it is bioprosthetic or mechanical. Bioprosthetic, it is still less. Mechanical, it is more, but bioprosthetic, it is still less, or you don't need to give anything.
Okay, thank you very much.
This patient, I think he told is a history of a CVA also. Then you should think of anticoagulation more seriously than depending on aspirin. Because it becomes high risk again.
Sir, that's a nice presentation, sir. Sir, have you ever felt that projecting these risk scores, whatever RCRA, Goldman Sachs, have you ever felt that these will fit to our Indian patients, or we need to have our way of risk scoring? And you nicely elaborated and laid a good platform for the cardiologist to have a debate about what is it. What is the extent of preoperative cardiac evaluation? By some of the cases, the ECG can be alone enough, and sometimes echo is not necessary in all cases. There is a lot of young anesthetists are also there. Have you ever come across, yes, this case I could have done thorough evaluation? Have you ever felt in that way?
No, that's a question we ask ourselves day in, day out, sir. In terms of whether the RCRI can be modified by the Indian Society of Anesthetists, that is something I leave to the luminaries sitting there to answer. The Indian Society of Anesthetists, the Indian Society of Cardiothoracic Anesthetists, they should be taking a call on this. But there have been instances where we believe that an ECG was adequate and a thorough pre-anesthetic evaluation was adequate. For example, a patient is coming for total knee replacement. My plan would be to give a spinal and do ultrasound-guided IPAC and adductor canal blocks for post-op analgesia. Now, I don't see how a 2D echo or a dobutamine stress echo in this patient would alter my anesthetic plan. But then that is something I cannot stop surgeons from referring the patient on their own to the cardiologist. So this is something we need to be aware of and accept that this is part and parcel of our practice.
Thank you, sir, for an enriching presentation and with your clinical anecdotes and valuable take-home messages. I request you to stay back, sir, on the podium, on the stage, and please, sir, Dr. TVS Gopal, sir, please join as chairperson for the current session. Now we move to I request all the panel members also to stay back. Now we move to the next lecture of this session.
The next session is anesthesia strategies for high-risk cardiac patients. It's my pleasure to invite Dr. P.S.N. Raju sir, a senior anesthesiologist, Apollo Hospital, Chennai. He is highly experienced anesthesiologist with over 40 years of practice in cardiac anesthesia, critical care and perioperative medicine. He is also an active member of professional medical bodies include the Tamil Nadu Medical Council and the Indian Association of Cardiothoracic Anesthesiologists and ISA. We warmly welcoming you, sir.
A very good morning to all of you. It's a great pleasure to be in Vijayawada for me. I am a native of Bhimavaram, so it's always great pleasure visiting Vijayawada. I thank Dr. Ramesh Babu, Karthik and their team for inviting us for this interesting seminar. Actually, it is Heart in the OR because usually in all the conferences 1 or 2 lectures are conducted and the whole day has been dedicated to this, which is a very, very important topic in our practice. We always see a lot of cardiac patients coming for non-cardiac surgery. It's a big segment now in the practice. And it's a great pleasure and privilege to have my esteemed colleagues and friends, Dr. Bhimeshwar, Dr. Mahesh on the podium and Dr. Suresh and Nima here and with our Guru, Dr. Tagore there. It's a great pleasure, sir, to be here. And let me go to the topic. And my 2 previous speakers have made my life much easier, especially Dr. Gopal by covering about the pre-op assessment and risk stratification, which is the most important part of this management of these high-risk patients. So I'll be dealing with the introduction and with general principles of anesthesia management because I'm not going to go into the details because this is a mixed crowd of physicians, cardiologists, surgeons and anesthesiologists. So I'm not going to go into the deeper parts of the anesthesia, just the general principles and if the time permits, couple of cases discussion. As already mentioned, there is a number of major surgeries performed worldwide are going up continuously and the 30-day mortality associated with moderate to high risk patients is more than 2 to 5%. And cardiac complications are the most common cause of morbidity and mortality in the surgical patients in the perioperative period. This also increases the length of stay in the hospital and also the cost to the patient. Coming to the pathophysiology, why these patients demand a specialized anesthesia planning or peri-op planning? Because if a patient is having a coronary artery disease, there will be a supply and demand mismatch issues in the perioperative period, which can lead to a major cardiac events. Same way, if we are taking up a heart failure patient for a non-cardiac surgery, we have to manage the preload and afterload because they are sensitive to those, and also we should not be giving anesthetics which reduce the contractility. By doing so, we will be worsening the heart failure. So, same way in the valvular lesions, we have to look at whether the patient is having a stenotic lesion or a regurgitant lesion. Based on that, we have to plan our anesthesia and fluid management. Same way, all these patients coming for non-cardiac surgeries, they are prone to arrhythmias. We may get a fresh onset atrial fibrillation or ventricular tachycardia. So we have to prevent, and if they occur, we have to manage. So this is about the gross principles. So this has already been mentioned because why we are worried about taking a patient for especially a coronary patients for a non-cardiac surgery, because we are worried that MI can occur in the perioperative period. More than the instance on the table, it is for the first 48 to 72 hours, these patients are more prone for developing a major cardiac complication like having a MI. There are a lot of factors in the perioperative period which can precipitate this, especially the inflammatory response, which can lead to hypercoagulable state or plaque rupture. Same way, the neuroendocrine stress response also can increase the heart rate and blood pressure, and then that can increase the oxygen demand, leading to a perioperative myocardial injury. The inflammatory response can lead to hypercoagulable state, thrombosis, and then can lead to decreased oxygen delivery, precipitating a perioperative myocardial infarction. So our perioperative management, especially the coronary patients coming for non-cardiac surgery, has to do to prevent this or reduce the inflammatory response and the neuroendocrine stress response. So perioperative evaluation has been well covered by Dr. Gopal. We have to take a detailed history and we have to estimate the functional capacity. We have to do the detailed physical examination and appropriate investigations like echo, ECG, and the biomarkers have to be done. And if needed, a stress testing has to be done. If the patient is on having a device like a pacemaker or AICD, then we have to interrogate the device and then do the appropriate management of that device. Coming to the risk stratification, various indices are there, and most common and popular indices index what we use commonly is the RCRI, which may not be the best, but I think currently available. It is one of the simpler ways of estimating the risk stratification. So in our center, we tend to use the RCRI commonly, and we all know that the high risk cases are, not all cardiac cases are high risk cases. So the cases with a recent MI, unstable angina, decompensated heart failure, or a patient with a severe AS, or a patient with lower ejection fraction, these are the cases which are high risk conditions. And surgically also, we have to divide the surgeries into low risk, intermediate, and high risk surgeries. This is about the RCRA index. If it is more than 3 risk factors are there, the risk of MACE, that is major adverse cardiac events incidence, is more than 5%. So these are the category of classification into low, intermediate, and high risk surgical risks. So the investigations, the management, everything should be based on the patient condition, that is whether a patient is a high risk patient or a lower risk. The surgery is a high risk surgery or a lower risk surgery or intermediate risk surgery. You can't be doing all the investigations for a cataract surgery even if he is a high risk patient, because the chances of any adverse events are less in low risk surgery. So this is where we have to use our knowledge and the clinical experience to do what type of investigations, and we have to plan our perioperative planning based on the risk of the patient and the type of surgery. So we have to optimize those patients. If we have time, or many of the patients are elective patients, when they come for elective surgeries, we should optimize their conditions so that we can avoid the complications in the perioperative period. Especially many of these patients, they are hypertensive patients, they may have arrhythmias, and electrolyte imbalances are quite common. So we need to control the hypertension, we need to correct the anemia if it is there, and if the patient is having a heart failure, then we have to optimize the condition by using diuretics. If the patients are on beta blockers, we should continue the beta blockers in the perioperative period. If they are on ARBs or AC inhibitors, then we should withhold morning dose. That's about 1 dose. If we withhold, the chance of hypotension is less. Same way, if the patient is already on anticoagulation secondary to atrial fibrillation or secondary to valve replacement, previous placement, or if they are already post PCI, we should manage the anticoagulation part as per the guidelines. So coming to the choice of anesthetic, this is what is the major discussion actually. So none of the major RCTs, any of them have proved whether the GA or the regional anesthesia, there is no difference in the outcomes. So it is sometimes, people have a thinking, and many of the times we also get like when we send for a physician opinion, some of the physicians tend to write patient is fit for spinal anesthesia or fit for regional anesthesia. There is nothing like that, because none of the RCTs have shown any difference in the outcomes between a general anesthesia and a regional anesthesia. So the choice of anesthesia should be with the anesthetist to decide depending on the patient's condition and the capability of the unit, and based on the guidelines. If the patient is on anticoagulants, you have no choice, you have to give GA. So based on, even on the surgical duration, we have to plan this. So both regional and general anesthesia, both of them have their own problems, have their own positive things. Suppose, for example, general anesthesia, it is very safe. If the patient is unstable, actually you have control on the respiratory system. If you intubate and ventilate under general anesthesia, you can reduce the respiratory workload. So it is safer in unstable cardiac physiology patients, but there is a chance of tachycardia and hypotension during administration of the anesthesia, in general anesthesia. Same way, when you come to regional anesthesia, the best benefit is the stress response blunting is better with regional anesthesia, whereas the risk is with the sympathetic blockade, that is with a spinal anesthesia especially, there can be a hypotension. For example, aortic stenosis coming for a inguinal hernia, you give a spinal anesthesia, more chance that the patient can develop hypotension and can have a problem, rather than giving general anesthesia to a particular patient. So our anesthesia management perioperative planning should be based on these factors. Same way, combined techniques. Sometimes we have to use combined technique. We use epidural with general anesthesia, especially if there is upper abdominal surgery like a hepatectomy or a Whipple's procedure in a cardiac patient. We give epidural anesthesia, and also we give general anesthesia. So we give combined with adequate and appropriate monitoring. Same way, like Dr. Gopal has mentioned, these peripheral nerve blocks, especially the ultrasound guided blocks, have become safer and safer, and the expertise is increasing for the anesthesiologist. So we are able to give in very difficult cases where GA may pose additional cardiac risk to the patient. We do tend to give the regional blocks, ultrasound guided blocks. So they are good for not only intraoperative, most of the time for the post-op pain management, these ultrasound guided blocks are very, very good. So as I mentioned already, choice of anesthetic technique and agent. The guideline says in patients undergoing non-cardiac surgery, use of either volatile based anesthetic agent or a TIVA is reasonable for general anesthesia with no apparent difference in the associate MACE. In patients undergoing non-cardiac surgery, neuraxial is feasible. Either neuraxial or general is reasonable with no apparent differences in the outcomes. So there is no difference between regional anesthesia and GA. In GA also there is no difference in outcomes whether you use a TIVA or a volatile anesthesia. For patients who undergo major abdominal surgery, use of epidural analgesia for postoperative pain relief, it decreases the incidence of perioperative cardiac events. For patients with hip fracture waiting for surgical repair, nowadays we give block on arrival. If the patient is in pain, they give in the emergency itself the block to prevent the pain, which can precipitate a cardiac event in a already known cardiac patient. So most important thing is the monitoring. What makes difference is the monitoring. When the technique is not making much difference, what makes a difference is the monitoring. If you monitor the patient appropriately in a better way, you can prevent the events. For example, when compared to a NIBP, if you insert a arterial line, invasive arterial line, then you can get beat-to-beat blood pressure and you can detect the hypotension much earlier than in case of a NIBP. Same way, if you have a central venous catheter, you can administer the vasopressors and then you can prevent the hypotension and low cardiac output. So the cardiac output monitors are now available in all the tertiary care centers, like the flow track monitor, the PICO monitors, and also the non-invasive cardiac output monitors are also available. If you institute a appropriate monitoring, then you can prevent the events. Same way, TEE, all of us cardiac anesthetists, we use TEE. In case of even non-cardiac surgeries, if they are with a very high risk and a major procedure, or if intraoperatively if there is any event or a major thing, you insert a TEE and then you see if there is any fresh regional wall motion abnormality or a fresh MR developing, you can see. This is especially useful in major cases, like even in liver transplants, they tend to use the TE more often. Same way, in all these cases, what is important is ST segment monitoring is very, very important. We should put 5 leads instead of 3 leads for these patients and display 3 leads on the monitor, one covering the anterior wall, one covering the inferior wall, one covering the lateral wall, so that any change during the procedure we can make out, because ECG is quite sensitive. You do get a ECG change in the monitor. Of course, I am not telling about the routine monitors like pulse oximetry, TCO2, every case we use. That's a basic monitoring now. Only about the advanced monitoring, as and when appropriate, we should use. See, this is one of the advanced monitors. We tend to use it quite often now in all major cases like onco surgeries and all surgeries. We have this advanced cardiac output monitor with the dynamic indices. We can use same way. TE is available nowadays and expertise is also available. We can use. I'm not advocating using it in every case, but in an appropriate case, in an appropriate clinical setting, I think we should not hesitate to use a high-end monitoring. So now coming to the hemodynamic goals. Once you establish the monitoring, so each case, depending on what pathology they have, you have to have a hemodynamic goal. For example, if it is a coronary artery disease patient, we should avoid tachycardia and hypotension, and we should have a mean arterial pressure goal within 20% of the baseline. So we should also see that we don't increase the heart rate, because increase in heart rate is the worst thing you can do to a cardiac patient, especially coronary patient. That is what precipitates the perioperative MI. And as far as possible, we should preserve the sinus rhythm. Because the atrial kick is so important that every patient, we should try to maintain them in the sinus rhythm. Or if they lose the sinus rhythm or immediately they get into atrial fibrillation or something, we should make all efforts either by using appropriate medication like amiodarone or even cardioversion. We should convert as early as possible to the normal sinus rhythm. Same way, use of vasopressors with minimal heart rate impact, because when you need, if there is a hypotension, you start dopamine, then what happens is the heart rate increases. That can be jeopardizing the myocardial oxygen demand supply mismatch. So it is better to use agent like phenylephrine as a bolus or an noradrenaline or even vasopressin, which will not increase the heart rate. Same way, titration of the inotropes is also important. So coming to the induction strategies, goal is always to maintain adequate coronary perfusion, avoid tachycardia. So we tend to use in known cardiac patients etomidate, which gives a more stable hemodynamics compared to propofol, and mostly our anesthesia will be balanced anesthesia, but based on the opioids like fentanyl, and now currently remifentanil is also available. We don't use high doses of propofol, especially in severe LV dysfunction, because they can develop hypotension, and we use lignocaine to blunt the laryngoscopy response. And pre-oxygenation is very, very important if they have a limited cardiopulmonary reserve. Coming to maintenance, we mostly use balanced anesthesia techniques using volatile agents and also opioids. We avoid agents causing tachycardia, especially ketamine. And volatile agents are safe, but we avoid deep anesthesia in patients with poor ejection fraction. Same way, TIVA, that is total intravenous anesthesia, is useful for a tight hemodynamic control. Opioids are very much useful for blunting the surgical response. And neuromuscular blockade, we tend to avoid the histamine releasing drugs like atracurium, which can precipitate a hypotension in case there is a histamine release. Now coming to airway and ventilatory management, we should try to avoid sympathetic surges during laryngoscopy. If it is a difficult intubation, we should use video laryngoscopy, and then we should ventilate with lower tidal volumes, maintaining normocapnia, and avoid the high PEEP in case of RV dysfunction. Coming to vasoactive strategies, based on the need, we should use vasopressors like norepinephrine. And if patients with low EF are coming for major surgeries, based on the cardiac output, we should either start them on dobutamine or milrinone. And we should avoid ephedrine because it tends to increase the heart rate. Coming to fluid management, cardiac patients, they don't tolerate either hypovolemia or even overload. So goal-based therapy should be used using dynamic indices like SVV, the stroke volume variation, and pulse pressure variation. Crystalloids are preferred, and we should try to avoid excess of saline. It is better to use vasopressors early rather than rushing fluid in cases of cardiac patients, especially with lower ejection fractions. Arrhythmias, as I mentioned earlier, we should, as much as possible, try to prevent them or correct them immediately, or do the rate control using beta blockers and amiodarone. Special situations, in case severe aortic stenosis, we should maintain adequate preload and increase the afterload. In case of severe MR, we should avoid bradycardia. This is one condition we prefer to have a tachycardia and maintain a forward flow. Coming to postoperative care, it is better to keep them in ICU for in case if there is a major surgery done in a patient with a known cardiac disease. In our unit, we tend to keep them for about 24 to 48 hours in the intensive care unit for better monitoring and early intervention. What happens is if they are in the ward, we tend to miss out on this one. So, and multimodal analgesia is administered, and we plan to do early mobilization and oxygen therapy. So, I will just go through a couple of cases because Karthik has asked me to put at least a couple of cases. I was discussing with my colleagues. I said I have to prepare some case scenarios. One of them suggested, why don't we discuss the cases we have done in the last couple of months. This is a case of acute coronary syndrome with a fracture of femur. On 18th November, this patient got admitted in a nursing home with a fractured femur, posted for PFN next day. But next day morning before the surgery, early morning, she developed left-sided chest pain and shifted to our hospital, and her ECG showed significant changes. And immediately she was administered loading dose of antiplatelets, shifted to cath lab, and coronary angiogram was done. Coronary angiogram showed severe left main with DVD. Echo showed severe LV dysfunction. IABP was inserted, and PCI was done immediately in the cath lab with two stents. One is LMC to LAD and to the circumflex. And but unfortunately, next day the patient developed limb ischemia, and IABP was removed. This is the ECG. You can see the acute changes have settled after the PCI. So he shifted to ward after 3 days from the ICU, but put on loading doses were given of both agents, then put on aspirin 150 milligrams because the patient's relatives were pestering us to do this surgery, and Clexane was started. After the multidisciplinary team meeting and high-risk informed consent were posted for PFN, and facial atta block was put in. Advanced hemodynamic monitoring we have put with BIS monitoring. We have planned for GA because the patient is on the anticoagulants, antiplatelet agents. GA was administered with fentanyl, etomidate, rocuronium, and propofol. Infusion was given and reversed with sugammadex. Extubated and shifted to patient in to ICU in stable condition. But later, after a few hours, she developed hypertension, and they have to start noradrenaline in the postoperative period. So these are the guidelines. We are not supposed to do, but because it's an emergency, even the patient is on antiplatelets, we are taken up. We don't have any choice, and we did it under GA with adequate advanced monitoring. These are the guidelines about the I'll stop with this last case. This is a post DVR, like our chairperson was asking. A double valve replacement was done and the patient came for a emergency decompression craniotomy. Our unit is both neuro and cardiac active unit, so we tend to get this quite often actually. See, anticoagulants are double-edged weapons. We sometimes get with thrombosis, stuck valve or other way also. This is a 58-year-old male patient, underwent CABG with DVR in 2023. 2 years back on acetron 3 milligrams, acosprin, clopilate, presented with acute CVA with cerebellar infarct in the ICU. We did an echo which showed a thrombus bar vegetation on the mitral valve, whereas aortic valve process is probably he has embolized from that thrombus. He was put on anti-edema measures. Initial this one was to manage conservatively because the patient is on antiplatelets and anticoagulants, and put on anti-edema measures. INR was 2.5. Acetron was stopped. Clopilate aspirin also were stopped and started on Clexane. But there was sudden drop in GCS after 2 days after the admission and was intubated immediately, and FFP was administered to control the INR, was taken up for emergency decompression craniotomy. We took a high risk consent. We made the blood products available, both the platelets and the FFP. Monitoring, we have put a arterial line, CVP and advanced hemodynamic monitoring. Anesthesia was administered with fentanyl, midazolam, propofol infusion, and of course etomidate for induction, rocuronium, and we gave mannitol. We have administered PRBCs, FFP and platelets were given. Post-operatively the patient was ventilated. He needed noradrenaline. Tracheostomy was done. Probably the best thing would have been we should have done a TEG, that is thromboelastography, to see the coagulation parameters, but we don't have TEG at our unit. Nowadays the recommendation by the societies is to give the 4-factor prothrombin complex. The octaplex is available. If we administer that, we can bring down the INR very fast. We need not wait, whereas vitamin K will take longer time. FFP also will take. Sometimes the patient may not tolerate the FFP, giving so much of FFP, 6 units, 8 units of FFP. But that is where the role of this 4-factor prothrombin complex, this one is there. That is available commercially as octaplex. But the cost is about, it works almost in the dosage for 2.5 INR we calculated, is working about ₹1,00,000. The patient said they can't afford, so we couldn't give. Probably in this case, TEG and 4-factor PCC would have been a useful addition. Later tracheostomy was done and he was on the ventilator. So I'll stop here. Thank you, and sorry I have exceeded the time. Thank you for your attention.
Session is open for discussion.
I'm a general surgeon. I'm Dr. Ravi Babu. I'm having a question for you.
Yes.
There is one particular patient who is having chronic liver disease, end-stage disease, who needed cardiac liver transplantation. But on evaluation, it was found that on angiogram, it was found that he is having a double vessel disease, left anterior descending and then circumflex. And also in RCA, there is a lesion, but functionally he is okay. He never had any cardiac events. He never had any angina. He is a hypertensive. So to really go for, he is having a very hypoalbuminemic, and then a lot of electrolyte imbalance, like sodium is going down, and then sometimes potassium is going up. So that is in that situation, when he has to go for liver transplantation, whether you feel that should be, because it is a major surgery. If it is not a major surgery, probably you may think about go forward. But in such a major surgery, do you like to think about fixing the cardiac first, or you still take the risk and then go for a liver transplantation?
this type of dilemma occurs quite frequently, sir. That is where I think the role of a multidisciplinary team will be helpful, because these decisions cannot be taken by one specialty, one specialist, or one consultant. So we need to, all of us, like the hepatologist, the transplant surgeon, the cardiologist, the anesthesiologist, all of us have to sit and see whether this can be, which comes first, whether if this patient can wait for some more time for the liver transplant. If he is giving that time since to this one, if he is giving, we can go either for a PCI and then take up later for the liver transplant surgery. If we cannot wait, then by waiting, if we are doing more damage, then we have to take a calculated risk and go ahead and do. Sometimes we may have to perioperatively open up that vessel in case if there is a trouble. So that has to be taken. Even in these cases where antiplatelets cannot be stopped, we may have to advise CABG. But whether this particular patient, we cannot do CABG because it can worsen his liver condition further. So that is where the concept of multidisciplinary team will come in. We have to give our inputs very clearly and then see which is best for the patient. We cannot, it doesn't mean, oh, I can anesthetize that patient. That doesn't arise. We have to see by waiting, are we waiting and doing first cardiac procedure and then taking up, whether that is useful, or like I'll tell small example. One patient of 130 kilos with a severe AS came to us for a hysterectomy with a menorrhagia. So she went to different hospitals also. Everybody said she is very high risk for surgery. Same way, cardiac surgeons are also not ready to take up for her for a AVR, aortic valve replacement, because she carries very high risk. OSA patient with 130 kilos, a short Muslim patient of 5 feet with 134 kilos. It's a nightmare for anybody. So what we advise them, we counsel the family as a multidisciplinary team. We asked her, because that's not an emergency surgery, we asked her to go for a TAVI procedure. She underwent TAVI procedure, and after 3 months, 6 months later, we took her up for a laparoscopic hysterectomy and did. So that is where we have to see whether that particular surgery, some surgeries like this decompression craniotomy, you cannot postpone. This type of things, you don't have any choice. But when there is a time, if there is a time, it is an elective procedure, then we should see what is best for that patient. We cannot decide, it has to be case by case. No guideline also can you give you a total this one. You have to go case by case, you have to take this one, you have to take the patient and relatives into confidence and tell them, if we do this first, these are the problems. If we postpone this one. Sometimes they say, sir, if you postpone, if he dies, what will happen? So these are the questions we have to face. That is where the team approach will be effective.
With your permission, we are running late by about 60 minutes. Can we please close the session?
Thank you, sir. Thank you for that. We'll move to the next session.
Thank you, speakers and the panel members. We move on to the next part of the session. Specialty-based case discussions. I would like to call our chairpersons. It's my privilege to welcome Dr. Jagadish Gudur. He is a senior orthopedic surgeon with over 4 decades of experience. He has served in key leadership roles, Director of Bird Hospitals, Tirupati, and is widely respected for his contributions to the patient care and medical education. We warmly welcome you, sir. The next panel member, Dr. Suresh G. Nair. It's my distinct honor to welcome Senior Consultant, Department of Anesthesiology and Pain Medicine and Critical Care Services from Aster Medcity, Kochi. Sir had 25 years of experience in anesthesiology. We warmly welcome you, sir. Next panel member, it gives great pleasure to introduce Dr. Shabari Girish Garu K, Interventional Cardiologist from Ongole Aster Ramesh Hospitals. I warmly welcome you, sir. Dr. TVS Gopal, sir, from Managing Director, Axon Anesthesia Associate Private Limited, Clinical Director, Department of Anesthesiology, Surgical Intensive Care and Acute Pain Management from Care Hospitals, Hyderabad. Sir had 22 publications and 4 textbooks. It's great pleasure to inviting you, sir. Dr. Malini S., Senior Gynecologist and Obstetrician, Fernandez Hospitals, Hyderabad. I warmly welcoming you, ma'am. It's a great pleasure to calling Dr. Vandana K, Professor and HOD of Obstetrics and Gynecology, Ashram Medical College, Eluru. We warmly welcoming you, ma'am. Dr. Shubit, Consultant Urologist from Master Ramesh Hospitals. We warmly welcoming you, sir. Dr. Ravi Babu, sir, Senior Lab Surgeon from Guntur. I am warmly welcoming you, sir. Dr. Fani Raj Kumar, Senior Oncologist from Ramesh Hospitals, Guntur. We welcoming you, sir. It give me great pleasure to invite Dr. Durga Prasad P, Senior Anesthesiologist from Indian Society of Anesthesia. Sir is retired superintendent from HOD Anesthesia, Siddhartha Medical College, Vijayawada. We welcoming you, sir. Case discussion, first case discussion, intraoperative VT, how to proceed for further. I call Dr. Anup V from Ramesh Hospitals, Senior Cardiologist from Vijayawada.
Good morning, everyone. So, in the previous session, we had presentations about assessment of perioperative cardiac risk in non-cardiac surgeries. So, it's the right time that we present our cases with respect to the same. So, this patient, 63 years old male with hypertension and diabetes mellitus, presented to us with dyspnea on exertion grade 2 and angina on exertion grade 1. So we had a CTCA and the calcium score was 168 and it revealed TVD, triple vessel disease. So the other investigations were normal. ECG was in normal sinus rhythm and echo was normal. So we planned for a cath angio here. So I'll show you a short runs of the cath angio. So which showed a plaquing in LM and then proximal LCX was 80%, OM was 80%. And LAD distal was a long segment 50% and discrete distal was 90 and RCA mid was 90. So here our plan in this case was to stent proximal LCX, OM and RCA. So because into the case we found difficulty negotiating the Oshl LCX, so we ended up doing Oshl LCX stent and POBA to OM and stent to RCA. So this is the one. So where we put 2.5 to 21 sirolimus eluting stent in the RCA and just ballooning to the OM and stent of 3 into 18 sirolimus eluting stent into the Oshl LCX and proximal one. So this case, after 3 months, he was on this aspirin and ticagrelor. So he came to us with altered bowel habits, severe anemia, HB was around some 6-7 and severe generalized weakness. So we planned for the workup. So in the workup, we found that when we did colon after ruling out all the cardiac causes, so there was a sigmoid colon growth. In the PET, it showed primary sigmoid colon malignancy, and on biopsy, it was differentiated adenocarcinoma. So we discussed with our surgeon, oncologist, and we planned for a laparoscopic sigmoidectomy in this case. So my question, I'll stop my discussion. I'll stop my case here. So would like to have a discussion on what is the perioperative cardiac risk in this particular case of non-cardiac surgery, and how do you plan here? Yeah, the colon report showed a sigmoid colon growth, which is not bleeding, and there is this is the PET report, which showed a primary sigmoid colon malignancy and a differentiated adenocarcinoma on biopsy. And there are no meds there.
This
it's
how
a
many
local
months?
growth.
How many months after the angioplasty?
Sir, it's 3 months.
I think I'm a surgeon. In this particular patient, I definitely prefer going for surgery because you cannot stop it. So, going for a laparoscopic sigmoidectomy is important.
Yeah, I'm able to hear.
So laparoscopic sigmoidectomy, but I don't try to do an anastomosis, because if at all patient is not faring well, probably this hypotension and everything, that anastomosis may not, will be not taken up very well. So I don't want to take the risk at that point. But because it is a sigmoid area, if it is a right colon, we need to, operate more extensively. For a sigmoid, I think it is a localized surgery. I prefer to do a laparoscopic sigmoidectomy and do a, colostomy and closing the distal, what we call it as a Hartmann's operation. And then naturally, the anesthesiologists who are well prepared, they can take care during the surgery. And then if anything happens, so cardiologists are there to really tackle that.
So any cardiologists in the group?
At this time of point, can we wait for 2 to 3 months?
No, we can't.
You can't wait. So in this scenario, like actually there are a few trials, TICO trial and all, that short depths also it's fine, like less than 3 months. We can cut down to single antiplatelet, then we can proceed for surgery.
But here, actually, it's defining the coronary substrate, coronary disease is really important. I don't think so that we just placed one single stent in a somewhere in the mid and distal location. We put a stent in ostial location of L6, which is near to LM. So this becomes a high coronary substrate. So how do you want to get into the surgery when there is a high coronary substrate? Like this is a high risk anatomy. So just by going, stopping one of the dual antiplatelets, going on a single antiplatelet, so is going to have a I think the traditional risk factors like RCRS may not capture the amount of perioperative cardiac risk in this case. Unless we plan properly, definitely there is going to be some major event into the case. Maybe perioperatively or in the surgery.
If at all you stop the one anti-platelet?
Yes, sir.
Yeah. By myself, underwent a stent actually. I was on dual platelet, and then within 1 month, I developed acute cholecystitis. They didn't stop anything, and then they operated. So in the same sense, nowadays I don't think with the available instrumentation, I think if we cannot stop the dual antiplatelet, we go forward with the situation like that without stopping it. We don't want to produce more risk on the cardiac side. So I think we can operate safely, probably with some extra care.
I will bring another discussion into this. Nice points added by Ravindra sir. And the way, and you evaluated this patient for anemia and he is losing blood, but your colonoscopy is not showing any active blood in the films. That means your dual antiplates are doing something here and that fellow is bleeding, right? And that is a chronic bleeding which was evaluated. So the different other perspective is the patient, that is not an obstructive growth. The scope has passed beyond. So there was no obstruction. That means it is non-obstructive growth, number one. And you evaluated him for the anemia. So the other aspect is, I will put it in the tumor board discussion. I will ask my medical oncologist, can we because you are saying it is so many red flag signs are there, I will not allow you to operate. So definitely, I will not completely withdraw. I will put it in tumor board and I'll ask my medical oncologist, can you give neoadjuvant chemotherapy in this case? Then my medical oncologist will switch into the literature and data. Operable colon cancer giving neoadjuvant therapy is an upcoming thing. There was no robust evidence. But still, have you ever tried? I tried. Because this is an outlier. Because he's bleeding and less than 3 months old PCA stenting. And there is an evidence to give neoadjuvant chemotherapy in operable colon cancer. The evidence is coming. And here, 2 things will happen. One, your heart will be taken care of once I'm not touching him and there won't be any stress. Second thing, if tumor starts responding, that losing blood will be stopped. The bleeding, what we are concerned, it's not an acute bleed, but there is a chronic bleed. He's losing slowly. That also will be taken care of. Yes, definitely this case will be discussed in the tumor board.
Sir,
Definitely.
if
you
you
are
have
resisting, I will ask my medical oncologist, give a neoadjuvant chemotherapy. By the time he finishes, he or she, it will be around 3 months. That means the post PCA you are almost crossing 6 months, right? Then I will be eligible to touch this patient.
Sir, if you have to touch this case in 3 months, so are you comfortable going on DAPT, dual antiplatelet therapy? Yeah, sir.
As an anesthesiologist, there are two things I would like to, I would like to answer. One is, what is the additional benefit that ticagrelor brings on ecosprin alone? That's one question. Because there's a recent study, very recent study that has been published, which compared the dual antiplatelet therapy versus single antiplatelet on long-term patients, and they found no difference in the outcome. That's one thing. Second thing is, there are new stents that has come into the market where the recommendation is that you can stop it as early as 3 months. I mean, cardiologists are there in the group, but you can stop it as early as 3 months before the after the stents have been, these new stents have been placed. So as an anesthesiologist, I would definitely like to take up this, because sigmoid squamous cell carcinoma, I think there is very good prognosis, am I right? Very good prognosis. So I would like to take him for surgery. Maybe 3 or 4 days you wait for the ticagrelor effect to be over and then take him up for surgery. I would like the audience also, the cardiologists in the group also, to give their opinion.
Here the surgeon's main concern is bleeding. If I do anastomosis, post-operative anastomotic bleeding, that is the only bothersome complication I would anticipate in this case, because there is no obstruction. There is no proximal dilated bowel loop in this case. So the bowel edema will be less. But still my concern, doing a covering stoma, as Sir rightly mentioned about a covering stoma. But my only concern is bleeding. Post-operative anastomotic bleeding, because you cannot stop your dual antiplatelets as early as possible. I need to start because there is a high likelihood stunt thrombosis will be there. That is the only concern here, except that provided take that risk, go ahead.
Sir, as you asked one question about shorter duration of DAPT, yeah, that is there. So, but it depends upon the indication for which we started DAPT. One, for a stable case where we need to place like a single or dual stent somewhere in the mid and distal location of the coronaries, stopping DAPT within 3 months is completely valid, and that is there in guidelines. But when you go with an indication for a STEMI or NSTEMI, when there is an ACS, so the guideline says to continue DAPT for 6 months at least. But even only the cardiologist knows, it's not just placing the stents there. The length of the stent, the complexity of the case, the location of the stent. If the cardiologist thinks that anything is complex placing the stents, we would like to continue the DAPT irrespective of the whatever is said in the guidelines maybe. But even the guidelines say that you have to continue your DAPT if it is a complex case for 1 year. And we take this particular case as complex. Why? Because we placed a stent which is near to LM, and probably we don't want to stop DAPT anytime, like not less than 6 months, definitely.
Yeah, you can complete the case what you have done.
Yeah, please go ahead with the
running
case.
out of time.
Yeah.
So, Anup, yeah.
Sir, so we got some bridging options. I would like to discuss the bridging options. So here it is like you continue aspirin, stop ticagrelor, you continue aspirin and continue ticagrelor going into the surgery, or you continue aspirin and bridge with a low molecular weight heparin, or continue aspirin and bridge with an unfractionated heparin, or continue aspirin and bridge with tirofiban infusion for 3 to 4 days prior to surgery. So if for cardiologist, he thinks about the amount of antiplatelet activity getting into the surgery to prevent any thrombotic complications. But if you see the antiplatelet activity, with aspirin and ticagrelor it is weak, with aspirin and ticagrelor it is strong, with aspirin and with low molecular weight heparin also it is weak antiplatelet activity. There is high thrombotic risk because heparin is not going to protect stents as much as an antiplatelet agent. Same with unfractionated heparin. But if you go with aspirin and with the tirofiban, the antiplatelet activity and the risk of thrombosis is going to be very, very low. So why is this important? You have this the DAPT interruption in less than 3 months, and you're going for some major abdominal and that way cancer surgery, and you got a high-risk coronary anatomy. So this is like a perfect substrate for having a major adverse cardiac event, which can go even up to 35 to 40%. Means that every second or third patient on table, if you don't properly go for proper antiplatelet activity in the body, so definitely is going to develop an event. So how did we approach back? This was done 1 year back. We continued aspirin. We stopped ticagrelor 5 days back, and we went into the procedure giving low molecular weight heparin 2 times a day, 5 days before surgery. So in fact, we went into the surgery with like weakest antiplatelet activity, can I say. So on the day of surgery, a laparoscopic sigmoidectomy was done. It was nearly obstructing tumor. Anastomosis was completely successful. No immediate surgical complications were there. So while surgeon was doing the skin sutures, there was a call from OT that it's BT, and our anesthetist delivers the shock immediately. So after the delivering of the shock, we did ECG. This was the ECG. On surgical table, so this is the ECG of the patient. And the echo done was fairly normal. Patient had VT, 1 episode of unstable VT, shocked. Sir, as a surgeon or anesthetist, how would you proceed? Looking at the ECG, you see in this ECG there are no ST elevations, and echo is also fairly normal. So, do you want to proceed further? You want to take the patient to ICU, or you would like to have a angiogram or cardiologist's opinion? If the cardiologist says that he wants to do angiogram, how comfortable are you in this case to get an angiogram done?
As an anesthesiologist, I would be very uncomfortable taking, because once you go to the cath lab, the cardiologist is going to start some more antiplatelet therapy. They've just undergone a surgery. He's going to bleed like hell after that, especially if there's an anastomosis. Everything is going to bleed a lot. So I would prefer to take him to the OT.
My job is already done. Skin staples already, no? So,
sir, but you have to take call with respect to the bleeding. So how comfortable you'll be? Okay, fine. I'll go with the case.
No, we have to save him. The bleeding is the secondary thing, and it will be consequential.
They have anastomosis?
Yeah, done, sir.
I feel if I am in that situation, I don't anastomose, because anything odd happen to the cardiac side or a bleeding side, the anastomosis may really give way. So I want to be safe at that point.
So actually, the VT appeared when the final skin sutures were being done. In fact, almost the procedure was over. The final skin sutures were being done.
What is the recovery process and then healing process? So we have to definitely consider that. May weak actually, there is a quite a big possibility. Suppose he has not done some colostomy or a ileostomy, covering ileostomy, then it is a really big issue actually.
Okay. No, sir, any surgery, there will be raw areas, and that is going to bleed.
Anup, can you complete the case and then leave
sir.
the discussion open?
Yeah, sir.
Please.
So the cath lab, we came there and we saw the ECG was fairly normal, but the echo was fairly normal, but we know the coronary, it was a high risk coronary anatomy. So we thought that this VT would be definitely due to some thrombosis would have happened to the stent. So we took that, we asked our surgeon, and our surgeon told that, okay, fine, we spoke with our anesthetist. So they told that, okay, fine, if you want to go ahead, you can go. So we did this angiogram. So that's the angiogram. We can see a huge chunk of thrombus sitting between the LM, LAD and LCX. So it's in that important junction. So it's there. So these are the other angiogram things where there is a thrombus, and in fact the RCA stent was patent. So so you can have multiple decisions. You got thrombus, you can remove the thrombus, do thrombosuction, but we planned for a tirofiban infusion. Just we wanted to check with, because this is the antiplatelet agent. So we want to check with this antiplatelet whether the thrombus gets resolved. But luckily, for us the thrombus resolved partially, at least 60 to 70% thrombus was cleared on tirofiban infusion. This was the check shot. We can see much of the thrombus being cleared there. So we were happy. We don't want to take wire and then spread the thrombus. So we shifted the patient to ICU. We had this IV tirofiban infusion for 24 hours. We continued aspirin. We loaded patient with ticagrelor within 24 hours, and we put the patient on heparin infusion after tirofiban infusion after day 1 for 2 to 3 days. We monitored drain and hemoglobin. So in post-op to first 2 to 3 days, the EF dropped to 40% LAD territory. And in the first initial 2 to 3 days, we had drain output of 200 to 300 ml. So HB also dropped. We transfused with PRBCs. And then slowly the patient recovered. The EF improved to 50%, and there was a small rectal hematoma which was squeezed out. So this is the important thing, like 3 hits model in the oncology cardiologist circles, not like in the guidelines. Whenever you withdraw the platelets, that's the first hit, and the second hit is when you're going into a proper surgical cancer surgery. And the third and the biggest hit is like you have a high risk coronary anatomy. So if you have all these 3, definitely are going to have that perioperative cardiac risk unless you don't plan into the surgery properly. So what could have been done differently in this case? If given the case today, probably we, instead of going with a low molecular weight heparin bridging, I would definitely go with a cangrelor bridging. So probably I would stop P2Y2, and then I would start after 1 day of stopping ticagrelor, I would have started IV cangrelor, and then cangrelor would have been continued till 2 hours before the skin incision of surgery. And then after the surgery, within 6 hours, I would like to start aspirin, and 24 hours ticagrelor or clopidogrel, and then it's not necessary to the bridge in post-procedure cangrelor. So these are the guidelines which say bridging with. So what we did right in this case. So the first and most important thing we did right, despite going into the case with a weak antiplatelet activity, what we did right in this case was the rapid recognition of ischemic VT by our anesthetist. So she gave the shock initially looking into this. She was able to recognize it. So or else the patient, it would have been difficult. So the next was our team effort with immediate cath lab activation. And we were not hesitant in starting the antiplatelets within 24 hours. And ultimately the final thing was the entire team which coordinated well to discharge this patient safely. Yeah, thank you.
Yeah, just to conclude, Anup managed this case very well. This patient is very close family friend of ours. So after stenting, when he developed carcinoma and surgery was contemplated, the attendant asked me, so what are the chances, because 3 months you are stopping antiplatelets and all. So I said, we have cath lab ready, and Anup was there. I was in fact away from the place. And that was one reason, anticipation of problem and keeping the cath lab ready in this patient. Number 2, when the ventricular tachycardia happened, the anesthetist, Dr. Radhika, called me when I was in Hyderabad. She said, cardioverted and ECG is normal. But then we had a discussion, I discussed with Anup, any such case where there is a stent in a very, very critical location, ostial LCX, and we stopped the ticagrelor. So any VT is an indication that there is likely to be an ischemic event. So I suggested, and we thought definitely he should be wheeled directly to the cath lab, and then Anup did the rest of the job. So he survived, and then he did very well. So anyhow, for due to paucity of time, we can complete the cases, and then we can have before lunch.
Thank you, Dr. Anup.
Right.
And for second case discussion is biventricular failure for cadaveric kidney transplant by Dr. Loknathan Chakravarti, sir, consultant cardiac anesthesiologist from Ramesh Hospitals, Guntur. We warmly welcoming you, sir.
Good morning, everyone. I'm Dr. Loknathan. Second case for this panel discussion is biventricular failure with severe pulmonary hypertension with a restrictive lung disease. He was posted for a cadaveric renal transplant on an urgent basis. He was a 45-year-old male, came with multiple advanced comorbidities. He had diabetes with end-stage renal disease on maintenance hemodialysis. And 4 years back, he had a coronary artery disease with prior LAD angioplasty and stenting has been done on dual antiplatelets. He also has pectus excavatum with moderate restrictive lung disease, and he is having severe pulmonary hypertension. Pre-op cardiac status, on echo, he is having a akinetic LAD territory with a biventricular dilatation and failure. LV dimensions were 68 and 48 mm with RVS FAC of 25% and a grade 3 diastolic dysfunction. He also has a moderate MR and moderate TR with a global systolic dysfunction, severe PAH with RVSP of 80 mm Hg, almost 70% of the systemic pressure. Pulmonary, he was having pectus excavatum with a restrictive lung mechanics. So he was having reduced FRC with poor compliance, high risk of hypercarbia and hypoxia. So there is a severe PAH. So he was also having a risk of acute RV failure. So preoperative status, patient was having exertional dyspnea with limited functional capacity, optimized with post-dialysis uremic status, and he also having anemia of CKD with 8.6 and normal electrolytes post-dialysis, persistent high PA pressures even after dialysis. So what are the major perioperative risks? I think can discuss with this. Key doubts in managing these patients. I think I'll open this discussion to the panelists. Can this patient safely undergo renal transplant? Can any of the panelists discuss on this?
The first question is this patient a candidate for renal transplant? He's got severe LV as well as RV dysfunction, plus renal failure, diabetic. So,
whether he's a candidate for renal transplant?
For renal transplant is what's my question.
Or he is a candidate for both heart and renal transplant.
So cardiologist, if this patient, you put a new kidney inside him, will that kidney function with severe LV dysfunction?
Yeah, the same thing we discussed with this case a few days ago, whether this patient is really fit. But then just I asked post-operative course and all. See, whatever dialysis and whatever, the patient was doing well for quite some time. So after the procedure, because it's a double insult, and then once you do this, the RV dysfunction, whatever it is, it may not progress or it may at least halt. The most important reason is he was quite young relatively, right? He was around 45 years. That was the main reason to give a chance and then see with the people. Otherwise, the mortality, if it is more than 1 year, we can probably give a good quality life. That is the reason.
Suresh? We did a couple of cases with this almost same scenario with a severe PAH. The first case I was literally worried. I also asked the nephrologist and cardiologist, will he come out? But to my surprise, once the kidney started functioning, the RV pressures will come down. I put a PA catheter in this type of cases, PA catheter in the before induction itself, continue it into the post-operative period. As of course, they will be on the anti-PH medications also like tadalafil and all. We continue that into the post-operative period, but it comes down. If the kidney is functioning well, the PA pressure tends to come down. Even LV function also improves. That's cardio-renal.
Yes. The second question is on table. Once the kidney is placed, you have to give lots of fluids to the patient. And he's already got severe pulmonary hypertension on the verge of RV failure. So, will that tilt the balance during the intraoperative period?
Kidney starts functioning and pouring out adequately rather than having imbalance and then intermittent dialysis where there will be a lot of fluid shifts and all, where the insult will be more on the RV function. If it functions well, pours out a lot of urine immediately, that will definitely reduce. That's what we thought. And age was the only factor. In fact, we had a discussion about this case a few days ago. Was it really? Then age and then, some cases do respond after this. So it happened and patient was leading good quality life and for quite some time.
So another question will be how to manage the RV collapse during induction and intubation, which are triggers of catecholamine release. So that is also one of the concern in this patient. So how to manage the SVR PVR balance? It's a question to anesthetist panel.
Inhaled prostanoids, have you tried to reduce transiently the pulmonary arterial pressure?
How about 100% oxygen, sir?
Yeah, it may help to some extent, but inhaled prostanoids are indicated in such cases to transiently reduce whenever there is an acute insult in PIH.
Theoretically, at least my concern would be that, see, you have RV, severe pulmonary hypertension, you reduce the pulmonary vascular resistance. On the other side, on the left side of the heart, you have a failing heart. You are going to get more transpulmonary flow of blood. How will the LV accept this just before the transplant I'm talking about, during induction? So if you use inhaled nitric oxide or prostanoids, as he mentions, you reduce the pulmonary vascular resistance, there is increased transpulmonary flow of blood. Is the left side going to accept this additional blood flow?
This is an ideal case for the paraoperative transesophageal echocardiogram, where you can clearly see the preload and then the afterload and then dimensions of the vessels. So you have to be very, very cautious, and then closed loop fluid management in such a case would be better.
And what would be the ventilation strategy in this patient? How to ventilate with, provided the dynamics of RV, LV will fare with the positive pressure ventilation, but RV will not fare with the positive pressure ventilation. How to maintain the tidal volume and PEEP, and how to maintain normoxia, and how to prevent hypercarbia.
I think the present strategy would be to use protective lung ventilation, use 6 ml per kg and a little higher PEEP. That, see, the PEEP will not be adversely affecting the pulmonary vascular resistance, because many of these patients will be having a lot of pulmonary congestion or pulmonary vascular, and pulmonary vascular resistance is least when we have the best PEEP. So you have to titrate your PEEP and use protective lung ventilation. That would be my strategy. I don't know how others would like to do. Are the other anesthetists in the group? Raju, Mahesh?
Yeah, I think Suresh, what you said is right. I think the trick is to use the moderately low tidal volume, moderate to low tidal volumes, and ensure that you also accept a little bit of hypercapnia. You don't need to really be too much worried about it. I'm not saying
what will be the target PaCO2?
Pardon?
Target PaCO2?
Yeah, maybe up to about 50-55 shouldn't be a problem in this case to an extent, because what would probably hurt the RV is the high tidal volumes and high peak airway pressures.
So plateau pressures will try to...
Plateau pressures also, yes. Limit to about maximum of 20 centimeters.
25 can accept.
Yeah.
Yes.
Yeah, we can proceed, Dr. Loganathan,
Yes.
so we can have questions.
So based on the discussion, so in this case, what were the physiological priorities were to maintain the RV perfusion? So maintain the MAP of 70 to 75 and avoid increasing in PVR. So we should avoid hypoxia, hypercarbia, acidosis, and also hypothermia. And we should avoid excessive PEEP, and we have to maintain a sinus rhythm to maintain a RV preload. So atrial kick is very important in RV, and heart rate control is also important. For graft and renal perfusion goals, we have to again maintain MAP, and we have to avoid hypotension, long periods of hypotension during reperfusion phase, and dynamic assessment of fluid responsiveness, and we have to prevent acute RV decompensation. So how we manage this? We have placed IV line, arterial line, and a PA line before induction, and we have induced with ketamine, low dose ketamine with a fentanyl of 3 mics per kg to avoid the tachycardia by ketamine. And we add a lung protective ventilation with low tidal volume with moderate PEEP, and we maintain normoxia. We avoided hypercarbia, maintained an PaCO2 of 35 to 40. And we have carefully titrated the volatile agents. And volatile agents, isoflurane was kept at 0.8. And careful titration of anesthetic to balance the biventricular function. Maintain MAP of 75 to 85 and balanced fluid. So we avoided overload and maintained a narrow margin based on the PA pressures and pulmonary capillary wedge pressures. We didn't have TTE, so TE, we had TTE, transthoracic echo. So based on that, we had fluid management. Intraop, we have used a low dose norepinephrine. Post-operatively, there was little lactate rice with a low mixed venous saturation. So we have kept a dobutamine for a day. Post-operative patient extubated after 6 hours, and he was doing well. Discharged after 16 days, and follow-up echo also was showing decreasing TR gradients, that is decline in PA pressures, improving RV function, and LV dimensions after 2 months were 58 and 43 mm. So though there is a improving cardiac function, patient unfortunately expired because of neutropenic fever and sepsis after 2 months of transplant. Thank you. Anything?
Thank you, sir. For third case discussion is perioperative Takotsubo cardiomyopathy by Dr. Ram Manohar sir, consultant cardiologist from Aster Ramesh Hospitals. We welcome you.
Good afternoon, one and all. So I'll be speaking about a couple of cases of Takotsubo syndrome, especially pertaining to the periop period, which looks like an MI but behaves like a mystery. So poetically speaking, when ECG says MI but coronary says no, it's Takotsubo. So I'll speak about both the cases, and then we can have a couple of questions for discussion. So the first case was a young female, 25-year-old female without any risk factors. 3 years before the current presentation, she had a fall for which calcaneal bone as well as spinal fixation was done. And then she was taken up during the current admission, before to our admission, for implant removal in an outside hospital under spinal anesthesia. Patient developed hypotension in the intra-op period, for which she was managed with inotropes. But she later on, immediate post-op period, she complained of chest pain and shortness of breath, and also had hypotension again, for which she was treated with adrenaline, noradrenaline and dopamine, and then shifted to our hospital for further evaluation. At presentation to our hospital, she was hypoxic with hypotension, and she had bilateral crepitations with a wet lung, and troponin and NT-proBNP levels were significantly elevated. The ECG showed significant ST depressions in all the leads, with subtle elevations in one AVL and AVR. X-ray, as shown, has pulmonary edema, and echo, as you can see, has severe LV dysfunction with EF of some 15 to 20% with global hypokinesia. Immediately, we have placed an IABP in view of her shock as well as suspicion that it could be Takotsubo. There was transient improvement initially with pulmonary edema, and the X-ray seemingly improved a bit. But by the time she reached our hospital itself, she had multi-organ dysfunction in the view of AK and decreased urine output. Though there was transient improvement of pulmonary edema after IABP, she had worsening of cardiogenic shock and end-organ failure with oliguria, and the patient succumbed after day 3. There are a couple of questions pertaining to this case which we'll discuss later. So I'll move on to the second case, where again a young female underwent laparoscopic salpingectomy at an outside hospital. She developed class 4 dyspnea immediately after the surgery, for which she was intubated and was referred to our center. Again, she had tachycardia with hypotension and bilateral diffuse crepitations. ECG again showed sinus tachycardia with subtle ST depressions. Echo showed a global hypokinesia with severe LV dysfunction of ejection fraction 25%. Again, similar to the previous case, an IABP was inserted, and she was stabilized with intubation as well as IABP. Coronary, gradually her hypotension started improving, and on day 4 of admission, since it was new onset LV dysfunction, and we wanted to rule out a coronary event, and a coronary angiogram was done which showed normal coronaries. Over the period of total 5 days, her tachycardia settled, hypotension improved, and her LV also started improving. And by the time of day 5, she actually had an ejection fraction of 55%, and she was later discharged home walking. So these were the 2 cases of probably suspected Takotsubo. I would not call them typical cases because they are not postmenopausal females as we typically encounter. They are young females. They had physical trigger, not the emotional trigger, which is traditionally said so. They had global hypokinesia and not apical ballooning. Both of them did not have any elevations. ST elevations are considered a significant thing in Takotsubo, not ST depressions. And there was an initial response to IABP, but unfortunately, since the first case came in a bad shape to our hospital, we couldn't salvage her. So there were, these were the 2 cases where the presentation was not very typical. but the clinical picture and the overall scenario fits into the diagnosis of Takotsubo. Though we know that premenopausal females account for only 10% of the cases, younger patients actually do have an atypical presentation of Takotsubo with a fewer comorbidities, and they also have more likelihood of having a neurological or psychiatric issues, and these patients have a higher rate of in-hospital complications than the typical Takatsubos do. So we all know the triggers and all. I will not, because of the want of time, I'll probably directly skip on to the cases and the questions. So the questions which we wanted to discuss in these cases are whether an early recognition of these cases versus a delayed diagnosis would help these cases. So we all know that the peri-op event is mostly an ACS. Takotsubo is a rare thing, but one should remember that Takotsubo has a similar presentation irrespective of the age. So every unexplained intra-op hypotension should trigger a suspicion of Takotsubo in addition to the usual acute coronary syndromes. Just for the panel members, we just wanted to know how many cases of ICU or OT related unexplained shock later on turned out to be Takatsubos and not ACS or something else. Any experience with the panel?
Yeah.
Once we did a, major procedure in Ramesh Hospital. Of course, she is an elderly lady, around 75, 80 in between. And then we did a, laryngopharyngectomy for that patient because she could not really swallow anything. At the time of surgery, after surgery, she landed in a Takotsubo.
Takotsubo is not an uncommon thing. We see it, I've seen at least 5-6 cases in my life.
Yeah, recently we had one case of a second stage cesarean section who had massive PPH, so intra-op hypotension managed with inotropes. Post-operatively, when we were giving blood transfusion, she had a sudden onset of shortness of breath with aggravation of the hypertension despite being on 2 inotropes. So we were in a dilemma whether it is a transfusion-related reaction or PPCM or something. We did a POCUS, there was global hypokinesia. Cardiologist was called in and he put in a diagnosis of Takotsubo, shifted to the cardiac care. And I don't think an angiogram was done for her, but the cardiac function recovered within 1 week. And as in the second case, she was discharged walking within a week. And within a month, her EF is back to normal.
So just to emphasize the fact that many of us would have encountered cases which are not typical. So Takotsubo probably it's evolving. The entity has been officially recognized only in 1990. So probably we do see a lot of atypical cases which are being missed. So moving on to the second case, one thing which we all know is catecholamines are the cause or the presumed cause of Takotsubo. So are catecholamines worsening the pathophysiology of Takotsubo, or should we really use adrenaline dopamine in these cases? And what do you prefer as the vasopressor of choice in these cases who have shock?
I think one of the important things is that, all anesthetists should know how to do at least look at the echo. And once we diagnose a case of Takotsubo, they call it reverse Takotsubo also is there, where the base doesn't move and the apex moves. So once we make a diagnosis, one of the first things that we do is take off all the inotropes and we use levosimendan or milrinone to offload the patient. That is one of the important things that all of us have to do.
Is there any guidelines to call it as Takotsubo?
Sir, yes, sir. There are multiple diagnostic criteria to say the same, but all of them mandate ruling out any coronary event. Because again, having said this and these all, if you see a peri-op event, it is mostly an acute coronary syndrome. So it mandates that you rule out an acute coronary event by doing a coronary angiogram and rule out that there is no plaque rupture or any thrombus in the coronaries. So having said there are
can't it be a viral cardiomyopathy at that time?
Happening on table is something which is very unusual because they were absolutely normal pre-op.
We will not be damn sure whether it happened on the table or just immediate post-op scenario.
At least both these cases were intra-operative. It would have evolved over time, sir, if it had been a viral myocarditis.
Yeah, there are two aspects of this. One is the definitive diagnostic criterion is cardiac MRI, where you find only edema. There won't be any infarct or fibrosis in Takotsubo, number one. Number two, the catecholamines and all, nowadays, I think Dr. Praveen Kumar will be talking about personalized pain management. Hypothalamus pituitary adrenal axis is increasingly being discussed, wherein the glucocorticoid receptors and the mineralocorticoid receptors, there is imbalance in pathology. And when the patients are very anxious, pain, all these areas, now more focus is being done rather than routine opioids and all. So I think sir will be talking, and it's an interesting aspect. Both the patients, in fact, I took the history even 4 or 5 years ago also. She was very anxious for 3-4 days even before getting admitted. That's what we got the history. And even this lady, the removal, before that she was quite anxious for 3-4 days. She avoided the doctors. That's what the attendants said.
Higher rate of psychiatric or neurological things are seen in these younger atypical patients. So with regard to the vasopressors and all, usually it is said that some cases you might not avoid catecholamines altogether, because if there is refractory shock, you will have to give, but at least have a bedside echo frequently and see whether the patient is developing LVOT obstruction. So if the patient is not, then probably catecholamines in a guarded way is something which we can consider. And if there is significant LVOT obstruction, yes, beta blockers and judicious use of IV fluids is something which can be helpful. And the third thing, in both the cases we have put IABP, so probably sir would be the best person to say. So IABP in cases of Takotsubo, what do you think, sir?
Literature doesn't say much, but extreme sympathetic activity, vasoconstriction, it is not a septic shock. So IABP with severe LV dysfunction, 15-20% would definitely benefit to tide over the crisis. As soon as it improved, I think within 24-48 hours we removed it.
Yes.
In Takotsubo with LVOT obstruction, IABP is contraindicated again.
That's what the same discussion we had when we had this. So see, the patient is admitted in ICU and we frequently do see the echo. So if the patient is developing some sort of LVOT obstruction, definitely we'll consider de-escalating or weaning the IABP. Till that point of time, yes, there is a role of IABP.
In hyperadrenalism, there will be pseudo LVOT obstruction also. So it's very difficult to differentiate.
And the last thing to the anesthetist, so we, just to speak, there was an international registry on Takotsubo which says that emotional triggers are the most common. Traditionally it was thought so, but now more and more physical triggers are found to be the most common cause of Takotsubo. So we all know the matrix where every phase can trigger a Takotsubo, where the pain or anxiety can do so. So my question to the anesthetist would be, what choice of anesthesia do you think is safer? If the patient is already a known case of Takotsubo, or in general to avoid Takotsubo, and any specific techniques or tips or tricks in a case who is already known case of Takotsubo?
Can I say something, Suresh? Dr. Mesh? Dr. Mahesh here. I think a couple of things. One is when we talk about a classical Takotsubo, I think it's basically very centrally mediated. That's a very classical, typical presentation. All those atypical presentations that you're looking at right now, what you presented in a couple of cases, are predominantly probably atypical. I think they're all, in my opinion, I know we can probably group them under Takotsubo, but I think it's predominantly evolving at a stress cardiomyopathy, predominantly, not the classical.
Not the classical ones.
But it is on the myocardial oxygen supply demand issues that are there perioperatively. I think they give a temporary scenario of a cardiomyopathy where the myocardium is completely depressed because of the oxygen supply demand issues. So as an anesthesiologist, it is very important for all of us to understand how do we maintain, even if there is no issue with the coronaries in terms of the myocardial oxygen supply, but I think it's important to maintain that oxygen supply demand, as every anesthesiologist's prerogative have been say, very prime importance. It's a prime responsibility for all anesthesiologists to ensure that we maintain those oxygen supply demand in the perioperative period, especially in high-risk cases like what Madam is talking about. We see very often, it's very difficult for us to differentiate between a postpartum cardiomyopathy syndrome, and we see fair bit of LSAS getting into trouble postoperatively. So I think it's important for us to differentiate. It's not easy to differentiate between a postpartum cardiomyopathy or a stress cardiomyopathy scenarios in LSAS. Again, the same issue in LSAS. Very often, suppose if they're coming out from a difficult labor into an emergency LSCS, they are subjected to multiple durations of multiple hours of tachycardia, and then they are coming into the operating room, and then we probably anesthetize them with general anesthesia because there's a fetal distress or a fetal bradycardia. all that scenarios lead to a stress-induced cardiomyopathy. I think it's important for us to maintain the oxygen supply demand as anesthesiologists.
Can we use preoperative anxiolytics? Maybe most of the guidelines may not recommend, but what is the role of, since it is an emotional, one is the most
Dr.
triggering
Praveen
factor.
Kumar will talk about pain and anxiety.
Yeah. So the anesthesia choice, probably it's not the choice which is important, probably it's the principle and how well you do the anesthesia. So I'll just speak a couple of slides. Why is it important to recognize? Because the management is different. You reduce the catecholamine dose if it is a Takotsubo related shock. Watch out for more frequently watch out for LVOT obstruction, and probably you'll consider IABP. And also you unnecessarily will not thrombolize the patient, because the patients most often present with ST elevations. And if treated in time, they have good prognosis. So the key takeaways are, not every peri-op MI is plaque rupture. So ST changes, troponin rise and shock need not be acute coronary syndrome by default. Stress cardiomyopathy is a real peri-op entity. The trigger is iatrogenic in these scenarios, could be emotional, but also iatrogenic. So smooth anesthesia is something which is very mandatory. And catecholamines in these scenarios are a double-edged sword. And echo obviously beats ECG here, because ECG might mislead us into an ST elevation MI. And shock physiology matters more than the label, because treat the hemodynamics first. Probably the labeling of Takotsubo can be done later, because here mechanical support and reduction of catecholamines are more important, and not escalating the inotropes. And recovery can be dramatic in most of these patients, and the early recognition salvages the myocardium, and delayed diagnosis might lead to a irreversible damage, just like in our first case where the patient already developed multi-organ dysfunction. Thank you.
Thank you, sir. Thank you, panel members, and thank you, speakers. We'll move on to the next session.
Moving on to the second session. Now I invite Moving on to the second session. Now I invite Dr. Shyam Sundar, the lead consultant neurosurgery at Aster Medicity, Kochi. Dr. Major M.V. Bhimeshwar is a senior anesthesiologist and the principal of Dr. Pinnamaneni Siddhartha Institute of Medical Sciences and Research Foundation. Dr. Meghana Kurapati is a senior ophthalmologist at Dr. Agarwal's Eye Hospital, Guntur. Dr. Suresh G. Nair, lead anesthesiologist, Aster Medicity, Kochi. Dr. Shivashankar Rao, HOD, General Surgery, NRI Medical College. Dr. Somanathan, senior cardiologist, Aster Ramesh Hospitals. Dr. Mahesh Vakamudi, senior consultant anesthesiologist, Professor of Anesthesia, Sri Ramachandra Institute of Higher Education and Research, Chennai. Dr. Anup V, cardiologist, Aster Ramesh Hospitals, to chair the session. I request the first session, I request to deliver the session on the first topic, common perioperative errors in fluid, electrolyte and gas management in cardiac patients. It's my pleasure to invite H.M. Krishna as a professor and head of the Department of Anesthesiology, AIMS, Mangalgiri. Dr. Krishna is an experienced academician and clinician specializing in anesthesiology and perioperative care and actively involved in teaching, clinical practice and academic activities. Over to you, sir.
Good afternoon, everybody. Respected chairpersons, senior anesthesiologists, and my dear friends. At the outset, I must thank the Aster Ramesh group of hospitals for inviting me to this academic feast of heart in the OR. And it's such a privilege to stand in front of so many illuminaries from whom we have been learning over decades on so many things. You know, we can fondly recollect that we were students and the teachers were teaching us, and it's really an honor to speak in front of our teachers. We all err, we all make mistakes. And unless we make mistakes and we learn from them and we get better at what we are, science wouldn't progress. We would routinely, mundanely keep doing the same things over and over repetitively in the OT. Only when we do something new, when we think something new, and when we discover that there is a better way of doing, that's when we see a progress in the field of science. So what's the first error that could happen when we have taken up a cardiac patient for a non-cardiac surgery and we are thinking of the errors with respect to fluid management, electrolyte management, and the acid-base management? The choice of fluid. Just because he is a cardiac patient, is there a particular fluid which is better for the heart as compared to a non-cardiac patient, or it wouldn't matter? Now, commonly, the perioperative fluid that we all choose is lactated ringer. So, is lactated ringer good enough for a patient with heart disease undergoing non-cardiac surgery, or should we choose some other fluid? The answer is lactated ringer, just like for any other patient, would be fine. The resuscitative guidelines speak of normal saline or 0.9% sodium chloride as one of the choice of fluids for resuscitation as well. Would that be okay for a cardiac patient? Well, it is still okay, just like Ringer's lactate, but we know that when the volumes exceed beyond, say, 4 liters or 3 liters, when we infuse the normal saline in higher volumes, the problem of hyperchloremic metabolic acidosis creeps in, and that could be detrimental to the cardiac patient. So that's what we are concerned about. Now, a lot of medical representatives come and meet us and then try to explain to us that the balanced buffered salt solutions, the plasma, the light, cabilite, other names are the better ones. They have the acetate, they don't have the lactate, they don't interfere with your measurements of the lactate, and they say they also have some other elements, some other electrolytes in them like the magnesium, and if you keep listening, they'll say there's also gold and silver in that. But then yes, are they better for the cardiac patients? Should we think that they are the choice of the fluid for our cardiac patients undergoing non-cardiac surgery? Well, not really. The main objection that we have with these fluids is that they are still expensive relatively compared to Ringer's lactate. So just because it's a cardiac patient undergoing a non-cardiac surgery, there's no indication to choose any of these fluids for routine fluid management. But if the non-cardiac surgery is of such a type where there is an indication to use such type of fluids, suppose you speak of, say, liver transplant where you're using large amounts of fluids and you have concerns with using Ringer's lactate, then that would be an indication rather than just a cardiac patient or a non-cardiac patient. Now, I don't know how many of you are still fancied with the Isolite P and Isolite M. Just because it's a pediatric case and there's a label of Isolite P, many were thinking that it's a pediatric fluid customized for the pediatric patients. That should be the choice for the pediatric patients. Absolutely no. The pediatricians may use Isolite P, Isolite M, yes, because they see a lot of the kids with dehydration, diarrhea, vomiting, all those things. In the ward setting, it is okay. But in the perioperative setting, these fluids are hypotonic solutions and they have no place anywhere in the perioperative locations, preoperative, intraoperative or postoperative period, because we know that if we use these hypotonic fluids in the perioperative period, there's a risk of severe hyponatremia which can precipitate cerebral edema, seizures, and even death in the pediatric cases. And it's not that it's applicable only to the pediatric patients, even in the adults also. In the post-operative period, if you notice that there's a patient who is being given just 5% dextrose for no reason, with a normal electrolyte balance, normal osmolality, there is no such indication to give the hypotonic fluids in these patients at all. So be cautious, do not use hypotonic fluids in the perioperative period, be it a cardiac patient or a non-cardiac patient. Should we add dextrose routinely to all the patients? This question we encounter especially when we come across the neonatal age group. And I think for quite a number of years, it was quite fashionable to drop dextrose, add it to the burette set and make it into 1% dextrose ringer lactate or 2% dextrose ringer lactate, and then administer it as the maintenance fluid to the neonates. It's not a wrong practice, but when we look into the evidence and the guidelines, the suggestion is that unless it is a preterm neonate who have a relatively low glycogen storage, unless you are not planning to monitor the glucose levels often, like every hourly or every 2 hourly, unless it is a neonate who is on hyperalimentation therapy, like already coming from ICU, there is no role of adding or supplementing dextrose in these patients. Now, the colloids seem to be totally out of picture, as much so that an obituary has been written on them. Whereas if we just moved back by a decade or 2 decades, the textbooks, the journals, the articles, there was so much research on them, one proving to be better than the other and all those things. So is there any role of using these colloids in the cardiac patients coming for non-cardiac surgeries? Well, it's not that they are totally villains, they should be totally banned. Now, if you ask anybody about colloids, first thing that they would say is renal failure, coagulation dysfunction. But they have been used over the decades. If you pay attention to the volume that is being used, the indication for which you are using, and you are cautious that you are not overusing that, it is still okay. Why I am saying it is okay is, instead of giving 3 volumes of crystalloids and ending up in hypervolemia in a cardiac patient, it would make sense to give a 1 volume of colloid if there is an indication. If there is an indication, when I say suppose there is a delay in the blood product arriving to the OT, that's something what I call as an indication. It's not that just infusing 500 ml of a synthetic colloid would result in any of these say renal failure or coagulation dysfunction. Now, the cardiac patients, when they come for non-cardiac surgery, also may require blood or blood products at some point of time. So, in that event, is there a different transfusion trigger? Now, for the non-cardiac patients, there are several guidelines which say that the transfusion trigger could come down to as low as even 7 grams per deciliter. Historically, traditionally, for the cardiac patients, the 10 number was very much obsessed with all of us, because we thought that at 10, there is a perfect balance between the oxygen that is contained by the hemoglobin delivered at the tissue levels, the rheologic properties of the blood and the viscosity of the blood. All these match up to such an extent that the delivery at the level of the tissues would be best. But then this has been questioned again. 10 has become 9, 9 has become 8. But we have realized from the concept of patient blood management that it's not single numbers as transfusion trigger that is important, but it's always the oxygen delivery, oxygen consumption at the tissue level, which has to be seen and which is of importance. Is there a timer? Stop. Okay. Now, we saw that choice of fluid could be Ringer's lactate. There's no specific just because it's a cardiac patient. Now, we can make an error in volume administration. We could be giving more, we could be giving less, and that could really be detrimental to a cardiac patient. Now, to me, to a non-cardiac patient, you give a little more, give 500 ml more, 1 liter more, the vasculature is able to take it without having any problem. But in a cardiac patient, it might not be so. The margin of error would be much lower. Even 100 ml more, 200 ml more could result in pulmonary edema. So overfilling could result in pulmonary edema, and RV strain like in pulmonary artery hypertension. At the same time, hypovolemia, underfilling is also bad because that could result in hypotension, myocardial ischemia. So we very nicely in our classroom say maintain normovolemia. But the whole art of anesthesia is how to maintain normovolemia, and that's what we keep learning, refining, practicing, relearning throughout our lifespan. So the common error that we do is when we are doing a non-cardiac surgery is not to use the dynamic hemodynamic indicators. So they are available in the non-invasive form to such an extent that you could get the measurements through even your pulse oximeter probe. So why not make use of that to guide the fluid administration so that you don't administer excess fluid or you don't administer lesser fluid. Now, one of the mistakes that we make is not understanding the cardiac pathology in a robust way. When we ignore the cardiac pathology while making the volume decisions, we are likely to land up in trouble. We keep hammering our students that know your hemodynamic goals very well for all the cardiac lesions. That's what we say parkour. What should be the preload, what should be the afterload, what should be the rate, what should be the contractility of the heart, what should be the rhythm of the heart. If you know these goals, at least you are not moving blindly in an unterrained, unmonitored area. You know what are your goals at least, and you can tailor your anesthesia, you can tailor your fluid management accordingly. So there has to be clarity in the hemodynamic goals. Make sure that the mean arterial pressure is adequate for coronary perfusion. Ensure that the preload is optimized using stroke volume variation or pulse pressure variation. Once again, don't be too obsessed with the numbers. The problem is when we start monitoring with these, okay, it has to be 14 to 16%. So we keep chasing this 14 to 16% and we tend to lose the whole picture and then mismanage the patients. Avoid tachycardia and hypotension in ischemic patients and adopt the right ventricular protective strategies in pulmonary artery hypertensions with patients, which was actually discussed in quite detail in the case discussions that we had. So do not rely on any single parameter. If it's the CVP, don't just blindly follow the CVP. Look at the urine output also. Look at the blood pressure also. Look at the capillary refill time also. We so underutilize the capillary refill time. Make use of all these parameters which are readily available. When it is single parameter, they tend to be unreliable, but in a combination, they give a better picture and the bigger picture, which is likely to be more realistic. So we all know about the hemodynamic goals. If it is an aortic stenosis, avoid hypotension and tachycardia. So usually in the stenotic lesions, we tend to maintain normovolemia and the lower side of the normovolemia. In the regurgitant lesions, we again maintain the preload in the normal regions only, but on the higher side of the normal. So that's the general dictum that we follow for the valvular heart disease. Aortic regurgitation, avoid bradycardia, maintain forward flow. The impact of fluid errors on valve gradient and regurgitation should be known. You know, you give too much, it could precipitate pulmonary artery hypertension, the pulmonary edema, and stenotic lesions. Once again, if you give more, it's a fixed cardiac output state. It's not going to benefit in any way. Dr. Mahesh sir has already enumerated that the basic fundamentals are very important. We might be speaking of very hi-fi things, but then if our basic understanding is clear, things become much clearer. So if it's an ischemic heart disease patient, our understanding of supply-demand mismatch has to be very robust. Fluid overload may impair diastolic function. Avoid low hematocrit causing reduced oxygen delivery. We all tend to be very conservative with respect to transfusion, but in patients who are dependent on the hemoglobin levels, they might not have the compensatory mechanisms to compensate for the lower hemoglobin values, we should be tending to transfuse much earlier. So the importance of stable hemodynamics cannot be overemphasized. Now, most of these congenital heart disease, the balance between the systemic vascular resistance and the pulmonary vascular resistance is what plays the most important role. So avoiding the sudden changes in the systemic and the pulmonary pressures is important, and the errors in fluid administration could result in alteration of the shunt flow. So what's important in these is maintenance of the normal baseline physiology. So a detailed history, detailed clinical examination helps us to try understand what is the normal physiology of the patient, and then we must try to keep the patient, keep the child in the range of the normal physiology as much as possible. When it comes to the errors in the electrolyte management, sodium is one of the electrolyte. Many of these patients tend to have the chronic hyponatremia. We should not be in a hurry just because the surgery is scheduled to correct this chronic hyponatremia in a very rapid way, because we know that we could have central pontine demyelinalysis setting in, which could be far more dangerous and life-threatening. And always the sodium level must be seen in conjunction with the serum osmolality. Hypernatremia could result from inadequate free water replacement, and use of hypotonic fluids in the intraoperative period should not be done. Now, hypo or hyperkalemia is another common electrolyte imbalance that we come across. Now, overcorrection leading to hyperkalemia could lead to arrhythmias, and just like how I said that sodium must be seen in conjunction with the serum osmolality, similarly the potassium levels must be seen in conjunction with the acid-base disturbances. If there is an acidosis, you need to address that as well. So one of the common errors that is done is to failure to replace potassium in chronic diuretic users. Always keep a watch on the ECG also when there are potassium abnormalities. Now, calcium becomes a much more important electrolyte in cardiac disease patient because hypocalcemia can worsen the myocardial contractility. So the emphasis should be on correcting the ionized calcium rather than the total calcium. Magnesium deficiency, we don't often measure the serum magnesium. That could also result in the arrhythmias, and hence we'll have to be cautious about both the calcium and the magnesium levels in cardiac patients coming for non-cardiac surgeries. Especially in patients with pulmonary artery hypertension, we need to be very cautious about the arterial blood gas management in the perioperative period. So failure to detect metabolic acidosis just by giving excessive of the normal saline, what I told in the beginning. Sometimes we make incorrect ventilatory adjustments just to keep the target numbers. See, the target numbers would vary from one patient to another patient. In one patient, maintaining the CO2 level at a higher normal level would be best for him, whereas in another patient, maintaining it at a lower normal level would be best. So it's not that there is a fixed values of ABG and then you adjust your ventilator accordingly to get those, because these patients could be having the chronic disorders of the blood gas, and as a result of that they could be having chronic compensation. Now with your over-enthusiastic ventilatory adjustments, you could actually abolish these compensations that the patient has been having. So keep a watch on the lactate trend, that's also important. So in pulmonary artery hypertension, maintain the PaCO to avoid hypercapnia. Even mild respiratory alkalosis may be good. Avoid hypoxia. In one of the discussions it was said that even 100% oxygen would be used along with the pulmonary vasodilators. avoid acidosis at any cost and prevent hypercarbia, as we know that it increases the pulmonary vascular resistance. Now, the cardiac patients are highly sensitive to fluid and electrolyte errors. So, the margin of error that we have in these patients would be less as compared to non-cardiac patient, and hence we have to be careful. Hence, we have to have a goal-directed therapy. We should have an individualized therapy as what is required for this particular patient. For that, we need to have a robust understanding of the cardiac pathology that the patient is having. Only then we can tailor manage the anesthesia for the specific cardiac pathology that the patient has. Thank you.
Thank you, sir. And the session is open for discussion.
Thank you, sir, Krishna sir. It's a very, very lucid presentation, helpful for everyone, and very nice. You completed in time also. So, because we are running late, can we go to the next speaker, please, Dr.
Yes, sir.
Mahesh?
Yes, sir.
Yeah.
Now I request,
Thank you, sir. Thank you, sir.
and I request H.M. Krishna sir to stay back for the second upcoming session as a chairperson. I request Dr. Mahesh Wakamudi to deliver a speech on advanced hemodynamic monitoring and inotrope strategies in cardiac failure, heart failure, and septic shock. He is widely recognized for his. Dr. Mahesh Wakamudi is a senior consultant, anesthesiologist, professor of anesthesia, and pro-vice chancellor, Sri Ramachandra Institute of Higher Education and Research, Chennai.
I was actually happy looking at the timer off, I think, but I'm unlucky. I think Krishna is lucky that he didn't get the timer on for majority of time was stopped. And anyway, even otherwise, I wouldn't be comfortable standing between you and lunch for a very long time. I'll try and be brief and hope I won't skip my time. And at the outset, I would like to thank Dr. Ramesh. I vividly remember about probably 17, 18 years ago, 20 years ago, we did a hemodynamic monitoring workshop, which is a half day long at your place, sir. I mean, it was a splendid time we had at that time. And also thank Dr. Karthik and Dr. Ramesh sir for inviting me, giving me an opportunity to be here at Vijayawada. It's always great homecoming for me whenever I have opportunity to visit Vijayawada and Guntur. I'm an alumnus from Guntur Medical College. Coming back to the topic today, I just changed it a little bit because the crowd here, I understand, is very mixed. We have plenty of surgeons, we have physicians, we have cardiologists, we have a lot of young anesthesiologists and also very senior expert anesthesiologists. Very, very dear colleagues of mine are here, Nima sir, Suresh, Raju. All of us have been together in ACTA for a very long time. I was expected to talk a little bit on cardiogenic shock. The cardiogenic shock, whenever we talk about cardiogenic shock, as anesthesiologists or cardiac anesthesiologists and coming from very strong backgrounds of cardiac critical care, we do recognize that these patients actually come from different types of settings. Somebody can be coming from a failed PCI, somebody can be coming from a very acute coronary syndrome. So the kind of complex scenarios are in the various stages of the shocks that they present carries a very high mortality rate for these patients if you don't actually attend to them in the right time. Whenever we talk about cardiogenic shock, we actually talk about stratifying them. The commonest stratification that we actually use is the Society for Cardiovascular Angiography and Intervention classifications, which are classified as at risk, beginning, which are the probably two easy parts where we can actually catch these cardiogenic shocks. In that scenarios, you're probably able to rescue them much easierly, rescuing them is much easier than actually looking at last two classes where is it talk about deteriorating in extremes, because you need a much higher competent setups to actually take care of these patients. The common management of the cardiogenic shocks are actually into four major categories. It is initial hemodynamic stabilization, then use the medical therapy, optimal use of medical therapy like inotropes and vasopressors, and then you actually look at the next stage, which is mechanical circulatory support in terms of the IABP Impella or ECMO, And then, of course, the root cause, addressing the root cause of the cardiogenic shocks and revascularization options like PCI, CABG. When you talk about the management algorithms of the cardiogenic shock, the common algorithm that is actually used worldwide is what is called the ROSE protocol. The R stands for the recognize or rescue, O for optimization, S for stabilization, and D for exit or de-escalation, E for exit or de-escalation. When you talk about the management algorithm, it's important to understand that you also need to look at the phenotyping classifications of the cardiogenic shock, because you have basically three broad phenotypes in cardiogenic shock. One is a non-congestive cardiogenic shock. Second is the cardiorenal. Third is the cardiometabolic. As you go down on these classes, the risk of the cardiogenic shock increases. Though the mortality rates could also be higher in non-congestive cardiogenic shocks, it is not that they're very safe or the mortalities are better, but in a given setting in non-congestive cardiogenic shocks also mortality could be higher, but definitely mortality is higher in cardiorenal and cardiometabolic shocks. Cardiometabolic definitely very often demands, with multi-organ dysfunction syndrome, very often demands a mechanical circulatory support in that area. One important point to remember when you look at managing cardiogenic shock is the last two phases, which we often actually forget to implement these strategies in the management of the cardiogenic shock. That's why I'm emphasizing on this. It is about stabilization phase and exit phase, or a de-escalation phase. This is a very important aspect to understand. I'll talk about it a little bit later into my talk. The classical management of again, if you look at a little bit more details into the management of hemodynamic management of the cardiogenic shock, it is predominantly classified either into biventricular cardiogenic shock or a univentricular cardiogenic shock or a right ventricular predominant cardiogenic shock. The left side of the algorithm is actually predominantly concentrating on the biventricular cardiogenic shock, whereas the other side of the algorithm is actually on the right ventricular cardiogenic shock, which is slightly different from the management for the biventricular or a left ventricular predominant cardiogenic shocks. I don't want to, it's a very standard protocol, because today my aim of actually talking about these things here is to give you a new concept about managing perioperatively hemodynamic management of the shock. These algorithms are always there in most of your textbooks, most teachings, classically they teach these things. So I do not want to concentrate much on this because of the paucity of the time. What I'm planning to talk today is about a new concept. It is called the protective hemodynamics. Some of the anesthesiologists sitting here, I'm sure all of you would have heard of protective lung strategies. Well, a protective hemodynamics is a new concept that is coming up in management of cardiogenic shock or septic shock, where we talk about a similar line as a protective lung strategy. We'd also talk about protective hemodynamics. So what does this probably protective hemodynamics actually mean? It's basically out of a 5-step approach, which is called a clear approach. We will see what is that each of these 5 steps are basically. And the protective hemodynamics is about do not chase targets which are probably superfluous. That's where you actually push the patient into a harmful status at the end of a few hours or few days of resuscitations. So this is very important for us to understand, because it's important for all of us to understand that we come from if you look at the old Shoemaker's concepts in terms of resuscitations, they talked about hyper oxygen deliveries to a lot of these patients, which is actually shown in shock trials that it is counterproductive. The first point here is about customize your target. The first C in clear approach, it is customizing your target. So what are your targets? Your blood pressure targets, if vasopressor doses increase, you should actually look at, if you look at your moderating your blood pressure targets. Avoid so that you can avoid use of excessive vasopressors. The limits of autoregulation are extremely different. When we talk about autoregulations in body, we talk about a mean arterial pressure targets. Mean arterial pressure targets, we normally typically talk about a target between 60 to 75 mean arterial pressures, but we also need to understand that the different organs has the different
autoregulatory limits in our body. So we may have to probably do not look at, ideally looking at always about 75 mean arterial pressure and above. We can also look at, in a given patient, if you are able to achieve a good flow between even 50 or 55 mean arterial pressure, and then patient is actually, in all other parameters, the patient is maintaining well, you can limit your vasopressor usage. This is extremely important for us to remember. As I said, accept low arterial blood pressure targets, and it can be advantageous in a number of surgical settings too in the perioperative period. It can probably decrease your, especially in situations like vascular surgery and neurosurgery, it can actually decrease the radius of intraoperative bleeding, and thereby preventing you to get into a vicious cycle. Hypotensive resuscitation may offer a survival benefit over conventional resuscitation for patients with hemorrhagic injury, which is an important point. When I talk about it, when I say about a little bit lower blood pressure targets, some of us might think and talk about, like, most of the literature evidences show the higher the mean arterial pressures in resuscitation, the better are the survivals. But let me caution you, if you go back and look at these studies, most of these studies are observational studies, they're not randomized controlled trials. So there are no RCTs that are actually done to prove that these higher mean arterial pressure targets are always the most important thing to actually improve this resuscitation or improve the survival rates. So you also need to look at maintain the intraoperative systolic pressures within the 10% of the preoperative baseline, and you also can actually personalize these targets to the individual patient. One of the theories that are actually coming up strongly is to start measuring the sleep mean arterial pressures the day before the surgery. If you can actually look at it, most of the times the mean arterial pressures are at least 10 to 15% lower than the awake state, and that mean arterial pressures probably could be enough for these patients when you actually start resuscitating these patients, so that you can limit your vasopressor usage. This is what I said, talk about this, the clear approach. The C is customize your targets. The second one, L, is limit your catecholamines. So minimizing catecholamines is also important for you to understand. So we always classically see, like, I tend to see there's a lot of norepinephrine usage that has come up into the day-to-day clinical practice than compared to about 10 years ago. This is a good thing in a lot of ways, because we do see a lot of vasoplegia perioperatively, and previously we used to actually treat this vasoplegia with plenty of fluid administration, which is extremely detrimental. It's probably one of the reasons why we had bad outcomes perioperatively many years ago. So importantly, we need to look at, you had to minimize the catecholamine use. We also look at other multi-receptor targets. Instead of looking at one peripheral alpha constriction, you can think about looking at targeting the nitric oxide pathways for example, in septic shock. If you're handling septic shock, you can combine early norepinephrine in the early periods of septic shock itself with norepinephrine, methylene blue, instead of just depending upon norepinephrine. The other important strong literature evidence that's coming up is in the use of vasopressin. Early use of vasopressin has been shown to actually reduce limit the use of the dosage of the norepinephrine. So we can think about that particular strategy too. And to remember, use the right vasopressor for the right patient at the right time. So any dose of norepinephrine of more than 0.1 microgram per kg per minute should be used cautiously, and then it definitely produces a severe end organ vasoconstriction, especially nephrotoxic. The third part in the clear approach is what is called enhanced flow. One important point whenever you use catecholamines, you need to remember, you need to look at what is called a hemodynamic coherence. Hemodynamic coherence is about disconnect or a connect between the macrocirculatory targets, which we talk about usually when you talk about mean arterial pressure. It is a mean arterial as a macrocirculatory target. You should remember that pressure is not flow. What you're trying to do is, when you're resuscitating, you're actually increasing the flow, thereby actually producing more tissue oxygen delivery. The tissue oxygen delivery is a surrogate. The surrogate for the tissue oxygen delivery, what we use is a mean arterial pressure. It's a very bad surrogate in my opinion. So do not actually always, you need to remember this, do not always put a lot of stress on the correlation between the mean arterial pressure. That means if your MAP is great, your circulatory flow, microcirculatory flow is great. No, it's not true. So the hemodynamic coherence is extremely important concept for you to understand. So look at those parameters in your patients when you're actually resuscitating. The microcirculatory targets is also important. Like for example, a simple capillary refill time is a extremely very good indicator for you to look at perioperatively when you're resuscitating these patients in cardiogenic shock scenarios or even in septic shock scenarios or in a systemic inflammatory response. You know, this hemodynamic coherence is what you should keep in mind, because you shouldn't be just be happy looking at mean arterial pressure target that you've achieved using your vasopressor. So how to enhance flow? As I said, you have other microcirculatory targets like cerebral oximetry, sublingual microcirculation indices. These are commercially getting available. Cerebral oximetry is already available in all our operating rooms. It's pretty easy to use. And then you can think about using early use of inodilators like levosimendan, dobutamine or milrinone, or even sometimes there is a literature that's coming up. Even dexmedetomidine is actually being used to look at improving microcirculatory flows in these patients. The fourth approach as fourth step is about adjust fluid balance. Let me tell you one important thing. Too much fluid and too less fluid, both are bad. Okay, what happens is when you talk about, for example, in sepsis, in resuscitation, you tend to use in the early part, in salvage part, use the fluid. But that amount of the fluid that you're going to use an appropriate, as what Krishna was also saying, that you look at more importantly, a dynamic hemodynamic indicators, dynamic flow indicators. Excessive fluids can induce loss of hemodynamic coherence, as I was talking to you, due to hemodilution, changes in blood viscosity, edema formation, and oxidative stress. You need to remember this. Extremely important. Excessive fluids are not good in resuscitations. One of the things that's coming up very well in actually preventing excessive fluid administration is what is called a venous access ultrasound. Typically, till now, we actually look at, depending upon assessing the fluid status, in terms of your dynamic fluid indices as a guide to give the fluid, but in terms of assessing the volume status, perioperatively we do an IVC diameter, but that's it became a very basic indicator right now. Apart from that, you also look at venous access ultrasound scores in terms of looking at portal veins, hepatic veins, and intrarenal veins. If you have an IVC diameter of more than 2 and associated with any of these abnormal wave patterns on the hepatic portal or on the intrarenal veins, that means you have a bad score on the venous access ultrasound, and that means you cross the limits of the fluid administration. And it is time to stop fluid administration and start de-escalating your fluid therapy. So the last R is about resolving your underlying condition. It's a very, very important cornerstone in terms of resuscitation, whether you're talking about cardiogenic shock or you're talking about septic shock. It's important. You need to look at, apart from this is a parallel approach, as you're doing these stages of resuscitations, as I told you, whether it's a ROSE protocol or in a sepsis, the sepsis protocol, we'll just see it in the next slide. Whichever the stage you are in, you should look at parallelly optimize these patients in terms of trying to resolve the underlying condition. If it's a cardiogenic shock, early revascularization is extremely important. If it's sepsis, early identification of the root of the cause for the sepsis, administration of appropriate antibiotics or empirical antibiotic in case if you're waiting for your cultures is extremely important for you to also remember. Early administration of corticosteroids and low-dose corticosteroids is also sometimes indicated because corticosteroid administration does produce sensitization to the vasoconstrictor use, so that you can actually limit your vasoconstrictor use. There is as Dr. Rameshwar was talking about HP axis, it's also important to understand that sometimes these stress patients under the stress and cardiogenic shocks or any of the shock states does have a decrease in the HP axis stimulation, so the sensitivity of the catecholamines is low. So external corticosteroid administrations can increase the sensitivity to the catecholamines. So also other points to remember as you're looking at resolving the underlying condition under the 5-step approach, the last R signifies, look at avoiding low temperature. It is easy to miss this because when you're looking at resuscitating these patients, very often, whether it's an operating room or in intensive care, they do drop temperatures either by the basal conditions or by the ambient temperatures. So, and it's extremely difficult to resuscitate a hypothermic patients. So it's important for you to remember, unless there's a special condition, it's coming out from a cardiac arrest scenario in a post-cardiogenic shock, sometimes hypothermia does help in these patients. But in otherwise, avoiding low temperatures is extremely important. And also you remember, choose sedation wisely, because what happens is, when you use sedations indiscriminately, like for example, if you use propofol to sedate these patients in shock states, it increases the doses of vasopressors. Instead of that, you can start using drugs like dexmedetomidine, as I already said. It also improves the hemodynamic coherence. So wisely choosing the sedations in the critical care or in the perioperative settings does also limit the use of the vasopressors in these settings. Just to give you a little bit of glimpse about what do we do in septic shock, remember again, you can probably look at these protocols or salvage these patients, and you immediately see, depending upon the stages of the septic shock the patient presents, you can look at a salvage options, but if you already salvage this patient, look at optimization in terms of the hemodynamic targets. The targets are given. But remember, if you're looking at resuscitating a patient with a septic shock, always also pay attention to the diastolic arterial pressure. It's important because we don't look at usually diastolic arterial pressure. You normally go with mean arterial pressures. But your resuscitation targets in sepsis should also focus on the diastolic arterial pressures, apart from looking at early screening or a periodic screening for the echo to look at the LV. If the LV depression is there, early institution or early starting of your inotropes is extremely important for you to be successful in resuscitating septic shock patients. One important word of caution for all of you to remember, whenever you talk about resuscitating shock patients, it's also important for you to de-escalate or reduce or exit therapies into the patient. That means you would have probably in a patient with septic shock, even the Surviving Sepsis Campaign guidelines currently talk about it, lay a lot of emphasis and stress on this aspect. Now, you probably would have given a lot of fluid as a part of early resuscitation in septic shock, but when you're actually moving into a stabilization phase, you should start looking at de-escalation, start taking out the fluid. If the patient is producing urine, probably you need to look at decongesting these patients, because third spacing does produce bad results in outcomes of septic shock. You probably would have achieved your targets in the first two phases, whether it's in the ROSE protocol or in the SOST, the stabilize, optimize, salvage, optimize, stabilize, and de-escalate strategy of septic shock. You would have achieved in the first two stages. But if you don't pay attention again to the third spacing and edema that happens in these patients and address it in terms of de-escalation, they would probably have a bad outcomes at that particular point of time. So again, I was talking to, just to conclude, the perioperative management or the management of the cardiogenic shock has multiple sites and multiple, depending upon the stages in which these patients present. I just want all of you to remember this particular protective hemodynamics. Do not excessively use vasopressors. Very often, over a period of time, these vasopressors would be enough unless you want to chase. Do not chase these mean arterial pressure targets unnecessarily and produce. Don't go for the overkill. It doesn't really give you great results. Remember protective hemodynamics approach. Remember clear approach. Customize your targets. Limit the use of the vasopressors. Enhance flow. Adjust fluids, and then rescue resolve the underlying condition. These are the important 5 steps that you need to look at whichever the shock strategies, shock resuscitation strategies that you're going to use. I just want to drive home this point of a new concept that you should pay attention to this in terms of the shock resuscitation. Thank you very much.
Thank you, sir.
Thank you, Dr. Mahesh. Yeah, it's very clear. Briefly choose wisely, as we are also, in cardiology, choose wisely from the investigations, screening. So choose vasopressin or noradrenaline and choose early, wisely and early, and don't chase targets. These are the simple things, and then simple bedside maneuvers, capillary perfusion, then the leg raising, transverse diameters of the ventricle, the IVC dimensions, frequently looking at it, and simple things and then using the right drug, the right dose, at the right time. So that will, definitely improve. We have been watching, we have evolved also. At one point of time, as you mentioned, maybe 15, 20 years ago, we were thinking we were giving a little excess of fluid, and we were worried because that time vasopressin was considered as a last, addition. But now we know we are starting it early, NAR also, or antibiotic also in septic shock, as early as possible, give the right thing. So extremely happy. We are blessed to have all the stalwarts here, all our associates from our hospital and the audience. And thank you once again, Dr. Mahesh.
Thank you, sir. Due to running over of the time, we are having a slight rescheduling where we'll be clubbing session 2 and 3. So I request the panelists to stay back, and I'll invite the session 3 chairpersons before we proceed with the next lecture. Dr. Durga Prasad Rao, retired Superintendent HOD Anesthesia, Siddhartha Medical College. Please join us, sir. Dr. Rajesh Ganeshini, Senior Ophthalmologist, Sudarshini Hospital, Guntur. Dr. Sasidhar, Senior Endodontist, Duhita Multi-Speciality, Vijayawada. Now we proceed with our next lecture by none other than our very own visionary leader and our beloved Managing Director, Dr. Potineni Ramesh Babu, sir, Chief Interventional Cardiologist, Aster Ramesh Hospitals. Sir will be delivering a lecture on pathophysiology of cardiovascular complications in non-cardiac surgery. Can AI help to predict, prevent, and treat? I will also request Dr. Somnath sir, Dr. Bhaskar Naidu sir, and Dr. G. Krishnamohan sir also to join as panelists. Dr. Somnath sir, Dr. Bhaskar Naidu sir, and Dr. G. Krishnamohan sir, Senior Cardiologist, Aster Ramesh Hospitals.
So thank you for the kind introduction. At the outset, I express my sincere appreciation for the speakers who have come all the way from Chennai, Bangalore, Kochi, and we are really very happy to have you with us, delivering wonderful lectures. And before lunch, this topic, I would like to ask you 2 questions before starting. We face many questions from surgeons and anesthetists. Since my practice, when I started 37 years ago, I used to get a lot of referrals for cardiac clearance from general practitioners for hysterectomy or abdominal surgery and all. And as many of our colleagues, cardiologists, I used to write mild, moderate, or severe, and close perioperative monitoring is needed. That's all. So it was a guess, wild guess, static guess, without taking any of the parameters, and I was not following what was happening to the patient. And then it went on. And then 2 years ago, when we started having more and more non-cardiac cases, 2 cases, there were sudden problems. One patient operated, absolutely orthopedics, fine, shifted on the trolley, and then as soon as the patient reached ICU, he went into massive pulmonary edema, had massive MI, and we could not save him. We lost him. We never expected that he would die. He was around 60, totally asymptomatic prior to that. And another patient, likewise, then we started seeing more and more. In the morning, you have heard Dr. T.V.S. Gopal mentioning, despite the advances, whatever you have in anesthesia techniques, perioperative management, the recent, the vasopressors, better fluid and electrolyte management, there is no significant drop in the perioperative mortality or cardiovascular risk. What is the reason? If you find a person with a male diabetic who was playing shuttle, who was absolutely all right, ECG echo normal, so what would you do if his calcium score is 100? Will you clear the patient for surgery, or would you go for any other investigations? Similarly, when you find many of my colleagues, surgeons, they send the patient. A patient on a urinary catheter for 8-12 weeks, he wants to get his prostate removed, but then because of the risk factors, because of the age, we conduct a invasive cath or CT, and then we find approximately 80% or 90% lesion. Patient is absolutely asymptomatic. What do? Surgeon wants, no, I will wait for 3-4 weeks, or he can be on catheter for the 12 weeks. You first fix the lesion, because surgeons are worried, they delay, they are uncertain, they don't want anything to happen. And many, like me, these things happen. The colon cancer in the morning, there was discussion. Likewise, head and neck surgery, abdominal, acute, subacute cholecystitis. Now we are facing more and more of these dilemmas, and most of our practice is cardiology. Patients either had heart failure to have recovered, or post-PCI, recent, or 4-5 years, 10 years ago, or post-CABG. Some patients have multiple risk factors, absolutely asymptomatic. And day in and day out, I and Dr. Somanath take morning counseling for such critical patients, almost 30 patients, we do the counseling, and we keep seeing, and sometimes we are perplexed what to do. Can we predict properly? You'll see at the end of the session whether we can do that. We know, we heard the magnitude is very, very high, both in globe and India also. And as the coronary screening, what we have been doing for decades together, the routine cardiac screening, hasn't or is found to have so many fallacies in picking up the right patient who really has the disease, who will have problems, who will have in future MI or events or sudden cardiac death, or whether what you're doing, therapeutic decisions like stenting or surgery, will that improve? We'll see what happened in the past 40 years, what we have thought, and in the past 3-4 years, how there is a sea change in the landscape and understanding the pathophysiology. And I must tell you, I was thinking artificial intelligence or the machine learning and the quantum computing, hybrid quantum machine learning, all these techniques are useful in all walks of life, and I have seen personally that it helps cardiology patients very much in diagnosis and the therapeutic dilemma, and then picking up the patient much early. But once I started going through this perioperative mortality or perioperative cardiovascular disease, I'm very certain that artificial intelligence is the key. If you want to reduce the mortality from 3.1 to less than 1%, it is possible, but there should be a lot of brainstorming and a lot more data to come, pure data, because AI is supposed to have some biases and all, and then it should go into the public. And the surgeons and anesthetists, unfortunately, past 40 years, cardiology has taken a different direction, and slowly people are realizing. I will not discuss much about pathophysiology of circulatory shock, heart failure, AF, and it's all routine stuff. All senior anesthetists and surgeons and cardiology physicians know. I'll touch upon some bridging. And our institution, how we adopted artificial intelligence since 1998, I'll just present, and then the future. Future is good provided we have brainstorming sessions and proper thinking and alignment on certain things. When I say that we have not done good job in stable angina pectoris or screening the coronary artery disease patients, because the trials or the standard textbook, Eugene Braunwald, or the discussions in the cardiology conferences, we always focused on symptoms, and we focused on stress test, ischemia, treadmill test or nuclear stress test. And then we were focusing on stenosis severity.
This is a recent conference done in San Francisco, October. A very senior cardiologist have mentioned that we have never actually measured the heart disease, but we kept on following certain blind principles, because of which there has been substantial delay in accepting the right kind of investigations. We'll see what is the evidence to say that. Why did he say that? In a TCTMD conference, which is a global conference, you cannot talk, differently. And then the same. We sometimes, I was just asking 80%, 90% lesion, if my urologist wants me to fix up, I'm not sure, I don't know. Because this is a doctor whom we are following since 2017, and repeat CTCA shows almost 80 to 90% lesion. He is asymptomatic, he plays shuttle, and his treadmill is positive. His CT-FFR is positive, 0.78, but he doesn't want, and we also were not sure whether to fix this lesion. So still there are black boxes, still there is an enigma in understanding the pathophysiology and black boxes in terms of microvascular disease, collaterals, proteomics, genomics, lots of things. We know that 50% of the coronary artery disease is because of genes now, which we were thinking 10, 15%. No, there are lots of other things, genetic, genomics, epigenomics and all. Now these are the global prevalence of cardiovascular disease. It's going up, and in India, and you have seen that 90%, I will focus upon this perioperative MIs after surgery, and mostly silent and deadly. And these are preventable. How do you prevent? Is it the same routine screening which we have been doing, like only investigate symptomatic patients, or do a stress test before, or do a cath angiogram? This is the system which we have been following for years together. We will see where it led us. And we have seen this. Many deaths after surgery are caused by circulatory failure, and it is the third most common cause of mortality after cardiovascular disease and malignancy. And three dominant biologic killers: myocardial injury, major bleeding anemia, and sepsis. And acute heart failure, one of the dreaded complications we keep seeing after orthopedic surgery, after cholecystectomy in our own setup. Patients who were, however care our anesthetists take, some patients get into failure. So these are all the risk factors. An interesting factor about age, what all these things can we predict better? Do you need for every case echocardiogram or dobutamine stress echo or nuclear stress echo or coronary angiogram to identify a hidden disease? Or is the AI helping us to pick up the right investigation for the right patient? And one of the commonest sustainable arrhythmias is atrial fibrillation. Almost 52 million patients across the globe have this, and it has doubled in the past 25 years. And is there any way to predict? We see, okay, patient 60-year-old, they send the ECG, and perioperative, yes, okay, go ahead. Does he need any prophylaxis for atrial fibrillation? Is there any method? Does the ECG tell you that he is likely to get into atrial fibrillation so that he can give prophylactic amiodarone or beta blocker or colchicine or whatever to prevent this? Because even one episode of transient AFib has got longer implications for 30 days or even at 1 year. And also the aspirin, the routine aspirin which was being given and then which was withdrawn, is aspirin indicated when you find some inherent or hidden disease? So we know all these impact of atrial fibrillation, and the two-hit hypothesis, whether it is cardiogenic or vasodilatory or single shot where after cardiac arrest the patient goes into this, and then Dr. Mahesh has very clearly explained, be very, very careful in managing the shock. Another very important aspect in perioperative cardiovascular diseases, after the surgery, as in the morning was showing, our surgeon felt very happy that while doing the skin sutures, till that time everything was very stable. He praised the anesthetist, but suddenly patient had cardiac arrest, ventricular tachycardia. And similarly, there is a high incidence of perioperative increase in the troponins. It is silent, most often asymptomatic, unless it is very severe, massive MI patient won't have symptoms. So it goes silent, and there are longitudinal studies that rise in troponin in the initial 48, 72 hours, it results in longer, higher mortality at 30 days and 1 year. So, and if you don't track patient beyond 30 days, venous thromboembolism is another complication. Most of the time, 50% of the times, they present with pulmonary embolism. They won't come with pedal edema. They won't give you time to do venous Doppler. So you have to be very cautious in terms. We initiated a 3 to 9 post-discharge surveillance program for 42 days, for which we got a award in FICCI and Asian award for that, because we followed the patient for 42 days by either telephone or sometimes visiting. So post-operative care of a major surgery is very, very important. And again, the same thing. This I am bringing it because despite the identification, William Harvey of circulation, Einthoven's ECG in 1904, Linac and Braunwald's Bible cardiology, we hear day in and day out, sudden cardiac death. Is it predictable? Yes. Now we know 80% of the World Heart Federation says 80% of the sudden cardiac deaths are preventable. Either lack of awareness or access, ignorance, denial, lots of factors play, cost, all this expenditure. And there are several articles in the past 7-8 years, not only 7-8 years, almost 15 years, that there are certain procedures which cardiologists are following which are not right. There is clear evidence by following several lakhs of patients. What are those? We'll see. All cardiologists have been following globally. Whenever you want to screen a patient, somebody uses treadmill test, nuclear stress test, or dobutamine stress test, and PET CT, whatever, depending on the availability, number one. And then symptoms are very important before suggesting. Stress test is priority before taking the patient to cath lab. And in cath lab, it is the two-dimensional tubular vision and 50% stenosis, arbitrarily fixed 50% stenosis. And then lots of other things, debates, lots of debates in conferences, and there is no uniformity. I think Mahesh will be knowing, most of the people will be knowing, 80% lesion in 3 vessels. What do you do? This is the most of the topic discussion between cardiologists, surgeons, and a lot of, discussions, literature, quotes and all. This is despite almost 1984, probably this marathon runner, Jim Fix died, who was a marathon runner, whereas the other person. So people identified that risk factors are not really only factors based on which you should investigate the cases, because there is a change, paradigm change in the understanding of pathophysiology, where instead of fixing a stenotic lesion, now you are talking about vulnerable patient, vulnerable plaque, and then vulnerable condition, and then try to fix it. But that area, before going to that, just I'll talk about this. Artificial intelligence has created a lot of interest, debates, doubts, but I am very sure that it is a definite aid to all the physicians, and especially in the perioperative period, anesthetists can utilize it to bring down the morbidity and mortality. And AI, its health benefits, how it helps in several areas of diagnosis, imaging, computer vision, large language models, lots of things, speed workflows, all these things. I will not talk much about this quantum. Otherwise, European Journal recently, all the areas where AI can help in different departments, and then how it can quickly cut down the documentation time, and lot of future with AI, autonomic robotics and all these things. So in cardiology, in every department, congenital, cardiac, cardiomyopathy, CADs, everywhere, AI-aided CVD diagnosis. And ultimately, it is the multimodal fusion model which will give us a more direction, better direction, whom to investigate, how to investigate. Now you were talking, I was talking to my anesthetist yesterday, who was saying a 25-year-old guy who comes for a minor surgery, and do you want to take an ECG? No, he says, no, I don't want. ECG, what does it tell me? A 25-year-old guy is asymptomatic. ECG will tell you, AI ECG is now telling us much more than what we were imagining. And we used to screen the ECG and say, okay, you go for surgery. But now we know it gives us information about the cardiomyopathy progression much before it progresses or it shows up in echocardiogram or clinical symptomatology. Maybe in some cases several years ago, several years before. Lots of algorithmic voltage and complexes and all these things. And then there is something like heart delta age. AI is now able to give AI age minus chronological age is called heart delta age. If heart delta age is more, then patient is likely to succumb to several complications and lifestyle factors. And so AI is now also in structural diseases. So amyloidosis, hypertrophic cardiomyopathy, dilated cardiomyopathy, all these structural heart diseases, aortic stenosis, early diagnosis, severity of the stenosis, mitral regurgitation, then it has transformed, and many times we see ECG shows non-specific STT changes, right? We were thinking that these are benign. In fact, textbooks also mention non-specific STT changes are benign. But now they have seen adjusted odds ratio is 3.15 and non-specific changes imply that there is some myocardial fibrosis or remodeling. It will lead to something else in future. Similarly, the culprit vessel, many times in the ER, we see lesions, we see ECG, we cannot pinpoint the artery closure. Now, simple ECG, what you cannot see, it can identify whether it is occlusive MI. Now, the terminology of STEMI is changed. The European guidelines say occlusive MI, or is it reperfused, which vessel, all these things, it will tell. So, Wellen syndrome, T inversion, so it is a reperfused vessel, it will tell, AI will tell. It is much better than human eye and cardiology, senior most cardiologists. So, and then the prediction models. False, there is something like AI false ECG. They have followed. Echocardiogram is normal, LV function is normal, and then it has shown that over a period of time patient develops, it is intermediate phenotype. So, AI ECG can pick up heart disease with preserved ejection fraction, heart disease with intermediate phenotype, where it will get into problem. And then normal ejection fraction over a period of time, how it will pick up. Then coronary artery disease, incident coronary artery disease, it is able to pick up. You see the ECG and some voltage, some areas, it says no, this is equal to clinical risk scoring. It says this patient has got coronary artery disease. Absolutely normal ECG, normal echocardiogram. So the saliency maps, that is what we call as heat maps in artificial intelligence, explainability. Now it is able to explain. This is the reason why I am telling you that this patient is likely to have CAD. These are called saliency maps. And explainability was a big problem with AI earlier. Now it is able to tell us in many areas why it is saying so. It will tell now. And then lots of pericardial ischemia. In a perioperative area, it's difficult because the leads are different, and then patient is asymptomatic, only cardiologist, no angiogram is done. So it is difficult here. Similarly, post-operative atrial fibrillation, as I mentioned, whether is there a role of trying to identify atrial fibrillation before sending the patient to the OT, or taking consideration and other factors, or during the post-operative period after discharge. So likewise, similarly, X-ray, echocardiogram, Now you have lots of portable echocardiograms. Even on walking, it's a portable patch echocardiogram. You can have the lesions. So it is 600 times faster. And then you don't need echocardiographers. Even a simple nurse has recorded these echoes just on the direction. And then automatic rotor, it can give you the direction how to place this. So likewise, the current echocardiogram, it gives a lot of information. And before that, as I mentioned, ECG gives a lot of information, which I never imagined, maybe about 2 years ago. Only 2-3 years ago, the articles have been pouring in about AI ECG. It is equivalent to methylated DNA, which gives an estimate of longevity of a person. It is equivalent. So hemodynamic prediction, Mahesh mentioned, and then now the goal-directed fluid therapy, then stroke volume variation, and pressure volume variation, all these things, and it gives direction. It takes. The AI is going to study the patient completely in the OT, real-time dynamic monitoring to prevent intraoperative hypotension, the duration, the sepsis, the bleeding, everything it will take into consideration. And now you have something like digital twins, which I will be talking to you, how it has helped our cardiologists in identifying the disease much early and sudden cardiac death preventable. So this is digital twin. Where is it? Now, in CT coronary angiogram or in surgeons, where you identify 3D printing, you identify disease, you operate, and then you know what are the problems. So real-time transfer of the data, wearable data, daily whatever activities, and then the genomics, epigenomics, everything is fed into this in silico digital twin. And now for the functional aspect, anatomic, now the CT FFR, I'll be showing AI CT plaque morphology, hemodynamics, the feature extraction, segmentation, computer vision, everything is AI now. What all we have from heart flow about the CT FFR and how to identify. I mentioned about 80% lesion in the question. My urologist says, no, I won't operate. You first fix it. I won't fix it. I'll fix it if my digital twin, the information which I got it through these experiments, if it shows a very highly vulnerable plaque, that is high cholesterol, low attenuated, with lots of positive remodeling, and such patients, necrotic core, probably I won't use a stent because he will need surgery. I'll use a drug-eluting balloon in such patient. If it is a calcified, fibrotic, and there is not much of non-calcified segment, I won't fix it. You go ahead with surgery. I am there. In case you develop a problem, we'll fix it at that time. Because we know that there is no evidence to say that in asymptomatic or stable angina pectoris patient, even if you have triple vessel disease, if there is no left main disease, there is no evidence to suggest that treating the lesions, fixing the lesions will improve the symptomatic status or the longevity. So why do I fix up now in the pre-operative period when there is no evidence, and when we are fighting out whether to fix or not, even cardiologists, there is no uniform opinion how to investigate, how to treat, how to take the therapeutic decision. So this is how the digital twin is now going to take place in healthcare, cardiology, and even your oncology. Digital twins, what are the biomarkers and all, lots of applications are there. And yes, this is the intelligent ICU, and what all we have been doing so far, as I said, we have been doing wrong in the past several years, 40 decades we have been blind because we have been relying on risk factors to pick up a patient for screening of the coronary artery disease. And we know that much long ago, only 60% of the patients have singular, no risk factors, all acute MIs. And all the patients admitted in our ICUs, if you see, 60% of them don't. If we see the patients admitted in our ICU one day prior, we would say you don't need anything. You are a low risk guy. You are an intermediate risk guy. So you don't need statin, you don't need anything, but this patient has got double or triple vessel disease by that time, which I have missed with all my experience in my OPD. Because as per the guidelines, this and this, the colored charts are there, which are wrong. In Indian patients, especially, these are wrong. We cannot apply whatever Western standards, Western guidelines are there. And this is what the data available much long ago. And now we know these are the two important studies, CME in Miami heart study. If you take the people in the Western population itself, Sweden and US, more than 45-year-old, almost 50% of them have some subclinical atherosclerosis. 5% of them have severe degree, more than 50 to 70%. Some of the 1%, 1.5% have left main disease. And you are missing this 50% by not doing investigations. And I am sure these 50% people are the people who develop perioperative myocardial infarction or increase in the troponins, which go undetected. So these unidentified lesions, and we know pretty well that finding troponin is going to worsen the prognosis, long-term outcomes, then why not you pick up? You have to pick up the hidden disease. Supposing hidden disease you picked up either by invasive cath or non-invasive cath, if the coronaries are normal, almost be certain that the patient will not have a rise in troponins. This is shown in thoracic tumor patients. They have done the CT in 84 patients, CTCA, and wherever the lesion they have avoided, almost maybe 17% or so had, and then they avoided, and mortality was only 1. So much less than 3.6%, whatever was mentioned. So it is possible in oncology patients, in all surgery patients, to bring it down below 1%, provided you have clarity in what you are doing. Just looking at the ECG, looking at the X-ray, looking at the echocardiogram is not going to solve. For any number of years, same surprises you will continue to have. And this is, CME and Miami trials. And we know pretty well, the another most important thing I would tell you, we were taught that more than 50% only stenosis is important. But we know that majority of the heart attacks happen when the lesion is only 30%, 40%, less than 50%. That is a vulnerable plaque where the cap thickness is less than 65 microns, and that ruptures in an environment like perioperative period or lots of other factors, infections, inflammatory status, and all these things. This was known 1988, 1990s. But still we have never given importance that less than 50% also can cause problem. Only after the AI directed, the long-term studies, Scott Hart, ICON, and then PROMISE studies, then only you got this. So this is known, and it is not the 50% stenosis. There is no sacrosanct, and we have removed the recent AHA guidelines removed. And now the idea is to pick up, there is a genetic preponderance, despite having either risk factors or no risk factors, either hypercholesteremia. 50% of the patients don't have hypercholesteremia, CAD patients. So pick up whether the patient has got a genetic preponderance or predilection to have a plaque, then hit it. Hit it early. The plaque is spongy in 35, 40, 45, 50 years, not at 60, 70 when the patient had MI. However, whatever amount of statins you give, nothing will happen. Already by that time, there is a calcium, there is fibrosis, there is a plaque growth. You hit it when it is 30%, 40%, 50%. And then, if not, statins, at least aggressive lifestyle measures, pressures, blood pressure, 120 to 130, exercise, yoga, aggressive body mass index, that will bring down, at least retard the progression of the coronary atheromas. Means, as we mentioned, so this can be prevented if you identify subclinical advanced atherosclerosis. At least you are more cautious. And stress test, millions of stress tests are done all over the globe, including India. I know a patient who goes every year to get a nuclear stress test in Hyderabad, right, with 10 to 12 to 15 millisieverts of radiation. So the guidelines, everybody did not believe this, that CT coronary angiogram and CT FFR are much superior to cath till 8 associations came together in 2021. 1990, coronary calcium score was identified, but the paper was rejected by AHA. And 2010, they have identified that stress test, whether you do treadmill test or dobutamine stress echo or MRI or dobutamine PET, more than 90% do not have actionable information. That is known in 2010 if you see the papers. But nobody believed till these guidelines in 2021 came that stress test cannot be used as a screening test. It's a second line of test. When we do, when there is 70-80% lesion, when you want to correlate with the patient's symptoms, we have cut down our stress tests by almost 90%. So this is what made whole change, whole gamut, landscape of our coronary artery disease screening, and the same thing applies for your perioperative myocardial infarction or perioperative cardiovascular disorders, disability or complications. So it should not be paid part. This was there almost in 2018, but it took a lot of time for the people to accept this is how the coronary calcium looks. And then now 2024 AHA guidelines now allow anatomy first approach. It is not the physiology. AICT FFR, the perfusion CT and plaque quantification. The more the atheroma, the more the complications, whatever you do. Degree of severity of stenosis has got lesser importance compared to the plaque volume. And now people have realized that is a two-dimensional coronary angiogram, invasive cath, with all its limitations, is much inferior to a three-dimensional CT coronary angiogram if properly done under proper conditions with proper heart rate control. And then you identify the vulnerability plaque, and then this is how it is. And then perivascular fat attenuation. Then another inflammatory marker. If three vessels are there, if perivascular fat attenuation is there, that particular vessel is responsible. The lesion, 80%, that particular vessel is, you can address. Similarly, there was a lot of hue and cry about the radiation of CT coronary angiogram. All wrong. Compared to the invasive cath, CT has got 50% of the radiation, millisieverts. Many of our patients we do with 2 to 2.5 to 3 millisieverts. A cath, if an abnormal coronary artery is there, right coronary artery, we have been struggling for hours together, getting 15 millisieverts of radiation when we did not know RCA coming from left side. We struggled and struggled to get the RCA. And then why should a cardiologist get, why should the staff get radiation when you can get a better information? And then the mammogram calcification of the arteries is a surrogate marker of coronary artery calcification. So invasive coronary angiogram, this was an opinion, stop. It was done almost 2015 or so, but it took several years for it to be accepted. This is AICVD, and then the diagnostics, I'll just pass on. And the enigma of sudden cardiac death, 50% of the cases occur in asymptomatic patients. Avoid catheter first mindset. Nowadays what we do, now for any lesions, we identify, we sit in the CT console room, we give counseling, we discuss the heart team meeting happens there, we know which vessel should be addressed, we call the attendants, we give them time. Earlier what were we doing? Going to the cath lab, doing this, no, you have two blocks, I'll fix up 2 stents. Patient is confused, attendants are confused, they are not prepared, and that caused mistrust. For coronary artery disease, but cardiologists, mistrust is because ad hoc procedures with unprepared mind. Now, CT guided PCI is going to remove all these, probably in future, misconcepts in the society. And then, okay, bridging, I'll just pass on, this can be shared to you what all I could gather, different scenarios, not uniform measures are not uniform, drugs are given, not uniform periods are given. Again, it depends on the patient, the substrate, the type, the bleeding risk, the thrombotic risk, the genetic risk. We don't know in an individual patient. So the clinicians struggle most in these areas, and then definitely they have to have more information. A team has to form, cardiologist, cardiac surgeon, anesthetist, surgeon, intensivist, to discuss, especially post-operative cases, major cases, what is happening if something happens. So periodic meetings, then whether to proceed or postpone, it has to be decided not just out of fear for the surgeon. We have to be confident and we have to be prepared if problem occurs in 1 or 2% of patients. Let us be prepared. Don't delay, postpone surgery. Postponing the surgery is hell of a problem. When we postpone a CABG patient, when 20 attendants come from different places and we say for some reason mild fever, our sugar is 300, we are postponing, then they get upset. So postponing a major surgery, especially onco surgery or cardiac surgery, is extremely difficult to convince the attendants. So you have better information, better counseling, better team effort, and then this is how you do. And then certain new drugs, what to stop, what to give, and dangerous combination of drugs. All these things we should be very thorough and then be prepared when you're giving. And Cangular, as mentioned, is a recent drug. Probably it will help in better bridging in high-risk patients. So what did we do in our institution? Computerized ECG, we donated in almost 16 places, almost in 2000, and for 20 rupees ECG, and we were getting through the fax machine. That time mobiles and all WhatsApps were not there. So we started giving it to the peripheries, mandals, and then we were receiving it through the fax, and then there is another device, R10 device, where we gave in the peripheries, and we could get to our place. And then these are all the machines, whatever is technology is upgraded, we started getting it, like right from IVUS, OCTs, everything. And then even coronary angiogram, now virtual FFR. Instead of wire-based FFR, virtual FFR. We have virtual FFR with us. We haven't used it much because we have CT FFR. And then these are all the newer, whatever newer thing was there, we tried to acquire it. Now with the CT FFR, what we do, we discuss, and then it is much better idea, and then preparation for us. This is what I was telling, digital twin. The stenting, post-stent physiology, I can know by digital stent. I know where to stop the stent. If there is a lesion below that, and then it gives, no, that doesn't work. Select a bigger length stent, which you cannot do in cath lab. In cath lab, there is spasm, tubular vision, and in ad hoc procedures have the stent dimensions which are inferior to a well-prepared CT angio prepared this thing. So now the DAN is here, and then CT guided PCI is going to be a norm rather than an exception. And then IV contrast has got much lower kidney toxicity compared to arterial contrast because it goes a first pass effect of the kidneys. So these are all the adoption where we have done. We have an intelligent hospital network, and Dr. Karthikeyan will speak about this. What all we have done, tele-ICU, we do tele-ER triaging, tele-ambulance triaging, tele-ICU triaging, and then tele-OT. We added from the OT, monitor is directly seen there. So how the transient problems, because you can't fix, the operative OT staff cannot fix the gaze. So whenever there is a thing, and then you can predict the hypotension. There is a prediction algorithm for peroperative, intraoperative hypotension, sepsis, prolonged, bleeding, everything it can predict. And then if you have a digital twin, it will have a simulation, and then it will give us future. It won't take much, 3 to 4 years, 5 years from now, we are going to have everything. This is what we have, and we have something like when there is an abnormality, even in Mongol patient, if there is some problem, she picks up a phone and says, ward number 6, you have a problem there. This is tele-ICU, what we have. All these are our own innovated technology here. Otherwise, it would cost several, few crores. So this is how we give the signal and all these things. So we find that definitely AI is helping us quite a bit, and all these things are there. And then we are into almost clinical studies, more than 28 FDA approved studies. Every molecule, ticagrelor, PCSK9 inhibitor, lomocriptide heparin, we are participants in this contribution. All these are FDA approved studies only, and then we were recognized for the better quality. But with whatever is said and done, we always keep, whenever some newer device or newer drug is introduced, we are always careful not to adopt it immediately because of these, lots of debates for whatever reasons. During the COVID period, we have seen how biased were some of the organizations, and then the person who was there as an editor in New England Journal of Medicine says, I can never believe the studies. Some are genuine, definitely. You have to identify. You apply your mind, what is really good, and then let it be there in the market for some time before adopting. That is what the policy, which some of the drugs we have never used, and then they were withdrawn from the market. So this is where we are, and even now there is a lot of debate. In routine cardiac patients, if you ask three vessel blockade what to do, I cannot tell you anything. Because per-operative, there are several things which we do not know what is going to happen. What is this hypothalamus pituitary adrenal axis? What are the proteomics? What is happening? What are the drug effects? Drug effects? What is the anxiety and then the nutrition problems? What are these contributing to? So, very, very difficult to bring down, but there is a scope. We know that something is happening, something we are missing in routine cardiology practice. Now, sudden cardiac deaths, 80% are preventable. Why we are not able to do? Because it took pretty long time for the cardiology community to accept what is the reality. Now everybody is accepting, and it will take a while. So future is going to be something like, all multimodal fusion models which we use, and a real-time model with a digital twin, and then with the helping the anesthetists, cardiologists, physicians, that will definitely bring down the routine patients, and we stop static guess. From there we go to dynamic, continuous, updated probability. How is it? Then the ML risk models, then the intra-op, post-op monitoring. And in India, over a period of time, I'm sure we are going to have universal health program from April 1st. And they are going to have, everybody is going to have a unique ID number soon after birth. The government is very keen on improving the overall health of the population in such a vast country. We are very happy about it. And then you are seeing the airports, how your life has become very easy. Likewise in India, with the present steps which are being taken in healthcare, the central authorities, I'm very glad that we are going to show some improvement in bringing down the rank. India is almost 136 rank in healthcare. It is likely to come down to less than 50 in the next few years. But with all these things, still in the morning time, some cases we are perplexed, we have debates, we have the cardiology meeting, and then one cardiologist says something, but more or less objectivity is now there with AI. Objectivity is there. Rather than a tubular vision or just visual estimation is no more accepted. Somebody sees something, 50%, 70%, not many lesions. The angles are there in cath angiogram. Earlier we were all seeing this variance. And then people are dogmatic sometimes. But anyhow, so thank you once again. I'm sorry if I have taken longer than the time which I was allocated, but this is what I wanted to say. Definitely there is a scope for improvement in operative reduction in the cardiac disability and mortality.
Thank you, sir. Since we are already overshot the time, we are now proceeding with the inaugural and felicitation ceremonies, and request all the delegates to stay back, and also request the invited speakers to join us and receive our heartfelt gratitude during the felicitation ceremony.
Good morning to one and all. Present here on the behalf of Aster Ramesh Hospitals, we extend warm and heartfelt welcome to our esteemed guests, dignitaries, faculty members, staff, students, and fellow consultants. To commence the program, I invite the honorable dignitaries onto the stage. I warmly welcome Mr. Ram Mohan Rao sir, Chairman, Aster Ramesh Hospitals, to come onto the stage. I invite Dr. Ramesh Babu P., Managing Director and Chief Interventional Cardiologist, Aster Ramesh Hospitals, to come onto the stage. I warmly welcome Dr. Chaitanya Kumar IS, an eminent academician and leader in transfusion medicine and hemotherapy, as additional professor and head of Mangalgiri AIIMS. His contributions span clinical excellence, academics, research, and health system strengthening. He has played a pivotal role in developing advanced blood center services, national programs, and accreditation initiatives. With significant research output, patents, editorial roles, and national recognitions, he exemplifies innovation and leadership. Dr. Durga Prasad Sir, retired Superintendent, HOD of Department of Anesthesia, eminent teacher, Honorable Secretary ISA AP from 2006 to 2008, and reviewer of Indian Journal of Anesthesia. Dr. Ramakrishna SVK, a highly accomplished cardiac electrophysiologist and interventional cardiologist, Care Hospitals, Hyderabad. Dr. H.M. Hari Krishna, Professor and Head of Department Anesthesiologist, AIIMS, Mangalgiri. Dr. P.S.N. Raju Sir, Chief Cardiac Anesthesiologist and Intensivist, Apollo Hospitals, Vangaram. Dr. Praveen Kumar Neema, Head of Department Anesthesiology, AIIMS, Raipur. Dr. Mahesh Vakmudi Sir, a distinguished academician, Professor, Sri Ramachandra Institute of Higher Education and Research. Let us invoke the blessings of God Almighty by lighting the lamp. I request the guests on the dais to kindly proceed for lighting of ceremonial lamp. Let us bow to the light of lamp which brings auspiciousness, health and prosperity. As we light the lamp, I request the guests on the dais to kindly proceed for lighting of the ceremonial lamp. Let us bow to the light of lamp which brings auspiciousness, health and prosperity. As we light the lamp, we illuminate the path of knowledge, compassion and care.
Sir, I request Dr. Suresh G. Nair, sir, please come on to the dais, sir. Please, sir. Sir, Dr. Sam Shundra, sir, can you please come on to the dais, sir? Sir, Dr. Bhimesh, sir, please come on to the dais, sir.
Now, I request Dr. Ramesh Babu sir to briefly address the gathering.
Yeah, there is nothing much to address. I can only thank all the speakers who have been serving in the government institutions and also trained a lot of people like me. And also I thank all the audience taking Sunday and coming over here. So thank you very much.
Thank you, sir. A mark of respect and gratitude towards the faculty and seniors who have made outstanding contributions and achieved excellence in their respective fields, we, the family of Aster Ramesh Hospital, would like to felicitate them. I request Dr. Mahesh Vakmudi sir to kindly accept our appreciation and respect, and to do the honors, I invite Dr. P. Ramesh Babu sir and Mr. Ram Mohan Rao sir to do the felicitation. I request Dr. Praveen Kumar N. sir to kindly step forward to receive felicitation from Dr. Suresh G. Nair sir, Head Anesthesiologist, Aster Medicity, Kochi. I request Dr. P.S.N. Raju sir to step forward to receive the felicitation from Dr. Shyam Sundar, Chief Neurosurgeon, Aster Medicity, Kochi. I request Dr. Durga Prasad sir to step forward to receive the felicitation from Dr. Bhimeshwara sir. I request Dr. H.M. Krishna sir to step forward to accept felicitation from Dr. Krishna Mohan G sir, consultant cardiologist, Aster Ramesh Hospitals, Vijayawada. I request Dr. Ramakrishna SVK sir to step forward to receive felicitation from Dr. Somnath sir, Chief Cardiologist, Aster Ramesh Hospitals. I request Dr. Chaitanya Kumar IS sir to step forward to receive the felicitation from Dr. Ramesh Babu and Dr. Somnath sir, cardiologist, Aster Ramesh Hospitals, Vijayawada.
I request all the team of anesthesia department of Aster Ramesh Hospitals and other members of scientific committee to kindly step forward for a group photo. Dr. Chaya, Dr. Pavan,
Dr. Vamsi Krishna, sir. Dr. Shweta, Dr. Pavitra. Dr. Fanraj Kumar. Yeah.
thank you everyone. Thank you to all the dignitaries. Now we'll proceed with the next session.
Shall I call him?
ముందుగా మీరు అందరూ మా ఆహ్వానాన్ని మన్నించి వచ్చినందుకు మీ అందరికీ కూడా కృతజ్ఞతలు. సో ఈరోజు ఏంటంటే ఒక ముఖ్యమైనటువంటి జబ్బు అనాలో కాంప్లికేషన్స్ అనాలో కానీ మీ అందరికీ తెలుసు, మేము కార్డియాలజిస్టు కార్డియక్ సర్జన్స్ బైపాస్ చేసినప్పుడు లేకపోతే స్టెంట్లు పెట్టినప్పుడు హార్ట్ ఫెయిల్యూర్లో అలాంటి వచ్చినప్పుడు ట్రీట్మెంట్ ఇస్తాం. కానీ గత 2-3 సంవత్సరాలుగా తెలుసుకుంది ఏంటంటే ప్రపంచవ్యాప్తంగా 33 కోట్ల ఆపరేషన్లు జరుగుతున్నాయి. అందులో 5% మాత్రమే గుండెకి సంబంధించి. 95% గాల్ బ్లాడర్ కావచ్చు, కిడ్నీ కావచ్చు, లంగ్ ట్యూమర్ కావచ్చు, ప్రాస్టేట్ కావచ్చు, కిడ్నీ అలా వెసల్స్ కావచ్చు. వీటిల్లో ఏంటంటే అంతకుముందు ఒకవేళ గుండె జబ్బు వస్తే జాగ్రత్తలు తీసుకుని దానికి ఏదైనా చేసి కొంత రిస్క్ ఉందని చెప్పి తీసుకునేవారు. కానీ ఇప్పుడు తెలిసింది ఏంటంటే భారతదేశంలో 3 కోట్ల మందికి చేస్తే 15 లక్షల మందికి వేరే ఆపరేషన్ చేస్తే హార్ట్ ఫెయిల్యూర్ అవ్వడం, లేకపోతే హార్ట్ అటాక్ రావడం, బీపీ డౌన్ అవ్వడం అండ్ పెరి ఆపరేటివ్ మార్టాలిటీ అంటాం. ఇది దాదాపు 7% మరణాల్లో 7% ఉంది. అంటే గుండె జబ్బులు, క్యాన్సర్ తర్వాత 3వ ముఖ్యమైన కారణం ఏంటంటే ఈ మరణాలు సంభవించడానికి మిగిలిన అవయవాలకి మేజర్ ఆపరేషన్స్ చేసిన తర్వాత వాళ్ళకు వచ్చేటటువంటి కాంప్లికేషన్స్. సో ఇందులో మనకు అర్థమైంది ఏంటి అని అంటే గత 2-3 సంవత్సరాల్లో దీన్ని ఒక రకంగా నెగ్లెక్టెడ్ స్టెప్ చైల్డ్ ఆఫ్ హెల్త్ కేర్ అంటారు. ఎందుకంటే సర్జరీస్ వాళ్ళు అడిగినప్పుడు మాకు ఇదమిద్దమైన సమాచారం ఉండదు. కార్డియాలజిస్ట్ ఓకే క్లియరెన్సు ఎనస్థెటిస్ట్ చూసుకుంటారు కదా అనుకుంటాం. కానీ లోపల దాగి ఉన్నటువంటి గుండె జబ్బు వల్ల నెక్స్ట్ డే ఆ తర్వాత రోజుల్లో ఎంజైమ్స్ పెరిగి వాళ్ళకి 30 రోజుల్లో కానీ సంవత్సరంలో కానీ మేజర్ హార్ట్ అటాక్స్ వస్తున్నాయి, హార్ట్ ఫెయిల్యూర్లోకి వెళ్తున్నారు, లేకపోతే బీటింగ్ ఇర్రెగ్యులారిటీ, ఏట్రియల్ ఫిబ్రిలేషన్ అంటారు, ఇవి వస్తున్నాయి అని ఇప్పుడు తెలిసింది. అందువల్ల ఆపరేషన్కి ముందు ఎమర్జెన్సీ అయినప్పుడు ఆ ఆపరేషన్ టైంలో కూడా ఇంట్రా ఆపరేటివ్ హైపోటెన్షన్ అంటే కొన్నిసార్లు బీపీ డౌన్ అవుతుంది. అప్పుడు కిడ్నీలు కానీ లివర్ కానీ డ్యామేజ్ అవ్వడానికి అవకాశం ఉంటుంది, దానివల్ల ప్రాణాపాయం. సో ఇప్పుడు ఏంటంటే ఆర్టిఫిషియల్ ఇంటెలిజెన్స్ ద్వారా ఇప్పటి వరకు దాదాపు 3% పైగా ఈ మరణాలు కానీ ఏదైనా సంభవిస్తున్నాయంటే మేజర్ ఆపరేషన్స్ కొద్ది కాంప్లెక్స్ కేసుల్లో వాటిని తగ్గించాలి అని అంటే ఆర్టిఫిషియల్ ఇంటెలిజెన్స్ ద్వారా జబ్బు ముందే కనుక్కోవడం. అంటే రిస్క్ ఫ్యాక్టర్స్ ఉన్నప్పుడు కానీ 45 సంవత్సరాలు 50 సంవత్సరాలు దాటినప్పుడు కానీ పెద్ద ఆపరేషన్ అయితే కనుక సిటీ కరోనరీ యాంజియోగ్రామ్ చేసి అయితే అందరికీ కూడా 3 బ్లాక్స్ ఉన్నాయనుకోండి, అందులో ఏది చిక్కుతుంది ఏది కాంప్లికేషన్ వస్తుందని తెలుసుకుని జాగ్రత్తలు తీసుకుని మెజారిటీ ఆఫ్ ది టైమ్స్ దాన్ని టచ్ చేయం. ఇది స్టంట్లు కానీ బైపాస్ కానీ చేయం. కొన్ని స్పెసిఫిక్ లెఫ్ట్ మెయిన్ ఆర్టరీ ఉండి 3 బ్లాక్స్ ఉన్నప్పుడు మాత్రం అది ముందు చేసి ఆగడానికి అవసరమైతే అదర్ ఆపరేషన్స్. అంటే ఏది ముందు చేయాలి ఏది వెనకాల చేయాలి అనేది ఆ జబ్బు నిర్ధారణ చేసుకుంటారు. అలాగా ముందు కొంచెం మందులు వాడిన తర్వాత ఆపరేషన్ చేస్తే అప్పుడు కొంచెం బెటర్గా ఉండొచ్చు అదర్. కానీ కొన్నిసార్లు ఎమర్జెన్సీలో ఆపడానికి అదే కాకుండా అలాంటప్పుడు ఏంటంటే ఇంట్రా ఆపరేటివ్ మానిటరింగ్ అంటే క్లోజ్ లూప్ గోల్ ఓరియంటెడ్ ఫ్లూయిడ్స్ అండ్ ఎలక్ట్రోలైట్స్. అంటే ఆర్టిఫిషియల్ ఇంటెలిజెన్స్ ఏం చేస్తుంది, డిజిటల్ ట్విన్ అని ఉంది ఇప్పుడు కొత్తగా వచ్చింది. డిజిటల్ ట్విన్లో ఒక మనిషి ఆకారాన్ని, అందులో జీన్స్ని, ఎపిజీన్స్ని, బాడీలో ఉన్నటువంటి అదర్ ప్రోటియోమిక్స్ని, బీపీ ఉంటే బీపీ, షుగర్ ఉంటే షుగర్, ముందు వారికి ఏ ప్రభావం ఇస్తుంది అవన్నీ కూడా ఇన్ సిలికో అంటాం డిజిటల్ ట్విన్లో ఇచ్చి అందులో ఎలా రెస్పాండ్ అవుతున్నారో చూసి దాన్ని బట్టి ఈ పేషెంట్ కూడా మందులు ఇవ్వడం కానీ డయాగ్నోసిస్. ఇప్పుడు మేము CTFFR అంటున్నాం, సిటీ కరోనరీ యాంజియోగ్రామ్. అందులో ఆర్టిఫిషియల్ ఇంటెలిజెన్స్లో ఏం చేస్తుంది, సెంట్రల్ లైన్ ఎక్స్ట్రాక్షన్, సెగ్మెంటేషన్, ఫీచర్ ఎక్స్ట్రాక్షన్, కంప్యూటేషనల్ ఫ్లూయిడ్ డైనమిక్స్ ఇవన్నీ చేసి ఆ పర్టికులర్ ఆ కొవ్వు పగులుతుందా లేదా అనేది చాలా మటుకు మనకి సమాచారం ఇస్తుంది. ఇదంతా కూడా డిజిటల్ ట్విన్లో చేశారు. హార్ట్ ఫ్లో అనేవాళ్ళు చేసి ఆ తర్వాత ఎక్స్పెరిమెంటల్గా చేసి వాళ్ళు ప్రూవ్ చేశారు. అంటే ఇదివరకు ఇట్లాగా కాదు, ఈ ప్రతి వాళ్ళకి ఇప్పుడు 150 మందికి రక్తనాళాల్లో కొవ్వు ఉంటుంది, కానీ ఏది చిట్టుతుంది ఏది చిట్లదు అనేది ఆర్టిఫిషియల్ ఇంటెలిజెన్స్ ద్వారా కనుక్కొని అది ఆపరేషన్ ఏ ఆపరేషన్ చేసినా కూడా గుండె ఆపరేషన్ కావచ్చు, లివర్ ఆపరేషన్, కిడ్నీ కావచ్చు, దేనికైనా సరే మనం కనుక ఇన్ సిలికో డిజిటల్ ట్విన్ అలాగే అంతేకాదు ఇప్పుడు ఈసీజీ, ఇదివరకు మేము ఈసీజీ చూసి ఇది బాగానే ఉందనుకునేవాళ్ళం. కానీ ఈ రోజున ఆర్టిఫిషియల్ ఇంటెలిజెన్స్ ఈసీజీ ఏం చేస్తుందో తెలుసా? రాబోయే 3-4 ఏళ్లలో ఇది పేషెంట్కి గుండె పెరుగుతుంది. ఈసీజీ చూసిన తర్వాత మనం ఎకోకార్డియోగ్రామ్ చేసి నార్మల్గా ఉందనుకోండి, కానీ అది కనుక లేదు, డెల్టా హార్ట్ ఏజ్ అని అంటుంది. అంటే ఇదిగో 30 సంవత్సరాల వ్యక్తికి ఈసీజీ తీస్తే ఇతను సుమారుగా ఎన్నేళ్ళు బతుకుతాడో ఏ ఈసీజీ చెప్తుంది. దాని లాంగివిటీ అంటారు. ఇది మామూలుగా డిఎన్ఏ మెథైలేషను, టెలోమియర్ లెంగ్త్, ఆ క్యాప్స్, వీటిలో ఆ ఆర్గాన్, ఈచ్ ఆర్గాన్ యొక్క లైఫ్ స్పాన్ ఎలా ఉంది, ప్రోటియోమిక్స్ ద్వారా మనకి బ్రెయినేజ్ ఒకటి ఉంటుంది, హార్ట్ ఏజ్ ఒకటి ఉంటుంది, లివరేజ్ ఒకటి ఉంటుంది. సో ఇవన్నీ కూడా అదే కాదు. ఇప్పుడు రీజనరేటివ్ థెరపీ, సో ఇండ్యూస్డ్ ప్లూరిపొటెంట్ స్టెమ్ సెల్స్ అని మనకి స్కిన్లో ఉండేటటువంటి ఫైబ్రోబ్లాస్ట్స్, వీటిల్ని యమానాకా ఫ్యాక్టర్స్ అని అంటారు. ల్యాబొరేటరీలో వాటిని మనం కనుక పెంచితే మన ఓన్ బాడీ నుంచి మనం లివర్ తయారు చేసుకోవచ్చు. అంటే ఎంబ్రియోలో ఎలా ఉందో మన స్కిన్ ఫైబ్రోబ్లాస్ట్ని, సాక్స్టీ అని కొన్ని ఫ్యాక్టర్స్ ఉన్నాయి, 4 ఫ్యాక్టర్స్. యమానాకా ఫ్యాక్టర్స్లో ల్యాబ్లో కనుక పెడితే ఇది మీకు హార్ట్ కావాలంటే హార్ట్ అవుతుంది, కిడ్నీ కావాలంటే కిడ్నీ అవుతుంది. పార్కిన్సోనిజం డిసీజ్, వీటిల్లో కూడా ఇప్పుడు ఆర్టిఫిషియల్ ఇంటెలిజెన్స్ బాగా వస్తుంది. సో అలాగే ఎకోకార్డియోగ్రామ్, ఏఐ ఎకోకార్డియోగ్రామ్లో అంతకుముందు మనకి మామూలుగా మనిషి కనిపించేవి కాకుండా స్కానింగ్లో అది రాబోయే సంవత్సరాల్లో ఈ పేషెంట్కి హార్ట్ ఫెయిల్యూర్ రాబోతుందని చెప్పబోతుంది చెప్తాము. ఇవన్నీ కూడా 3-4 సంవత్సరాల్లో తక్కువ ఖర్చులో వీలైనటువంటి అందుబాటులో వస్తే ఇప్పుడు మనకి జరిగేటటువంటి కాంప్లికేషన్లో 180% మనం నివారించవచ్చు. గుండెపోటు మరణాలని 80% నివారించవచ్చు అని వరల్డ్ హార్ట్ ఫెడరేషనే చెప్పింది. కానీ మనకి తెలుసుకోలేక, ముందు కనిపెట్టలేక, ఆలస్యంగా వచ్చినందువల్ల, గోల్డెన్ అవర్లో రాకపోవడం వల్ల, అజ్ఞానం వల్ల కావచ్చు, యాక్సెస్ వల్ల కావచ్చు, ఆ నాకెందుకు వస్తుంది అని భరోసా కావచ్చు, ఆర్థికపరమైన ఇబ్బందులు కావచ్చు, వీటి వల్ల అందరూ కూడా ఆలస్యంగా వస్తుంది. అందుకని ఇప్పుడు యూనివర్సల్ హెల్త్ కేర్ అనేది ఏప్రిల్లో వస్తుందని మనగా సీఎం గారు అనౌన్స్ చేశారు దేశమంతా. వీటిల్లో వీలైన అందరికీ కూడా నాణ్యమైన వైద్య సేవలు అందడానికి అవకాశం ఉంది. ఫ్యూచర్లో 3-4 ఏళ్లలోనే ఆర్టిఫిషియల్ ఇంటెలిజెన్స్తో మనకి యూనిక్ ఐడి నెంబర్స్ ఇవన్నీ ఇచ్చి మన భారతదేశంలో ప్రతి పౌరుడి యొక్క హెల్త్ సెంట్రల్ హెల్త్ డిపార్ట్మెంట్, స్టేట్ హెల్త్ డిపార్ట్మెంట్లో నిక్షిప్తమైన పుట్టిన దగ్గర నుంచి సంవత్సరానికి 3 ఏళ్ళకి ఏమైంది అవన్నీ కూడా వాళ్ళు ఎలక్ట్రానిక్ రికార్డ్స్, డేటాబేస్ తయారు చేయబోతున్నారు. సో ఇది చాలా మన భారతదేశంలో మనం ఈ ఆరోగ్యపరంగా నేను 37 ఏళ్ళ క్రితం స్టార్ట్ చేసిన దానికి ఇప్పటికీ సమూలంగా చాలా మార్పులు వచ్చాయి. టెక్నాలజీలో వచ్చింది, పీపుల్కి అందుబాటులోకి వచ్చినాయి. ఇవన్నీ తెలుసుకుని ప్రజలకు సరైన అవకాశాన్ని వాళ్ళు వినియోగించుకుంటే చాలా మటుకు రుగ్మతల నుంచి వాళ్ళు కాపాడుకోవచ్చు. ఇప్పుడు మనకి కొచ్చిన్ నుంచి, బెంగళూరు నుంచి, చెన్నై నుంచి, హైదరాబాద్ నుంచి కన్సల్టెంట్స్ వచ్చి వీళ్ళందరూ కూడా పెద్ద మన ఇక్కడ ఎయిమ్స్ మంగళగిరి నుంచి వీళ్ళందరూ కూడా పెద్ద ప్రొఫెసర్స్ ఎంతోమంది టీచ్ చేస్తారు. వాళ్ళు వచ్చినట్టు వీళ్ళందరూ అడ్రస్ చేశారు. సో వీఆర్ వెరీ హ్యాపీ టు కండక్ట్ దిస్. ఎందుకంటే ఈ విధమైనటువంటి ప్రోగ్రామ్ ఇంతవరకు మాకు తెలిసి భారతదేశంలో జరగలేదు. ఏది హార్ట్ ఆపరేషన్ రూమ్, గుండె సర్జరీ కాదు, వేరే సర్జరీలో గుండె ఎలా ఉంటుంది అనేది ఈ 3-4 ఏళ్లలోనే దీని మీద విపరీతమైన ఆర్టికల్స్ వచ్చి దీన్ని నెగ్లెక్టెడ్ స్టెప్ చైల్డ్ అన్నారు. దీని మీద అందరూ కూడా డిస్కస్ చేసుకుని ఏం చేయాలనేది బ్రెయిన్ స్టార్మింగ్ సెషన్స్ చేసుకుని సరైన నిర్ణయం కనుక సరైన డయాగ్నోసిస్ చేసుకుంటే ఇప్పుడు అనవసరంగా మన భారతదేశంలో ఇంకోటి ఏంటంటే అనవసరమైన సర్జరీలు ఎక్కువ అవుతాయి, అవసరమైన వాళ్ళకి లేట్ అవుతుంది. అంటే డయాగ్నోసిస్ కానీ అది మనకి ఉన్నటువంటి లో అండ్ మిడిల్ ఇన్కమ్ కంట్రీస్లో ఇది జరుగుతూ ఉంది. సో ఇది కూడా మనకి రాబోయే రోజుల్లో ఒక యూనిఫామ్ యాక్సెసిబిలిటీ అన్నీ వస్తున్నాయి. సో డాక్టర్ దుర్గాప్రసాద్ గారు ఈయన సీనియర్, మీ అందరికీ తెలిసే ఉంటారు, సీనియర్ అనస్థిస్ట్, నాకు కూడా సీనియర్ మాకు గుంటూరు మెడికల్ స్కూల్లో. సో చాలామంది స్టూడెంట్స్ టీచ్ చేసి రిటైర్ అయినారు. సో రిటైర్ అయిపోయారు. సో డిఎంఏ అన్ని అనస్థీషియా హెడ్గా గుంటూరు గవర్నమెంట్ హాస్పిటల్ సార్, విజయవాడ గవర్నమెంట్ హాస్పిటల్ సిద్ధార్థ చేసి. సో ఇట్ హెస్ డన్ and then we are very happy to have all these people, senior people here with us. Okay. అదే క్వశ్చన్స్ ఏంటి అసలు ఎలాగ సెంటర్ అని అడుగుతున్నారు. విల్ ప్రిపేర్ సార్ పేపర్ మాకు కాంట్రిబ్యూట్ చేస్తాం కాస్ట్ ఎఫెక్టివ్గా హౌ టు డూ ఇట్ అండ్ ఎవిడెన్స్ బేస్డ్ విల్ ప్రిపేర్. ఓకే, థ్యాంక్ యూ ఆల్. సో అందరూ లంచ్ చేసి వెళ్ళండి. ఓకే. ఇటు అంటున్నారు. అలాగేమ్మా, అలాగే అక్కడ రానా ఇక్కడ. చాలమ్మా. అది బ్లర్ అవుతుంది బ్లాక్
హార్ట్కి సంబంధించి ప్రాబ్లమ్స్ మీద హార్ట్ ఉంది ఓఆర్ అనే టీంతో ఇక్కడ కేఎల్ యూనివర్సిటీలో సెమినార్ ఏర్పాటు చేయడం జరిగింది రమేష్ హాస్పిటల్ వాళ్ళు. దీని మీద మరింత సమాచారం మనతో రమేష్ గారు ఉన్నారు, ఆయన అడిగి తెలుస్తున్నాం. సార్, ఈ హార్ట్ ఉంది ఓఆర్ అంటే
హార్ట్ ఉంది ఆపరేటింగ్ రూమ్ అంటే ఇంతకుముందు కార్డియక్ హార్ట్ సర్జరీకి మేము ఎక్కువ ఫోకస్ చేసేవాళ్ళం. ఇది బైపాస్ కానీ వాళ్ళు మాట్లాడి ఇప్పుడు ప్రపంచం అంతా కూడా అంతే జరిగింది. కానీ చాలాసార్లు మేజర్ ఆపరేషన్ అంటే క్యాన్సర్ కానీ కిడ్నీ కానీ లివర్ కానీ హెడ్ అండ్ నెక్ కానీ జరిగినప్పుడు చాలాసార్లు అంటే ప్రపంచవ్యాప్తంగా 33 కోట్ల మందికి ప్రతి సంవత్సరం ఆపరేషన్ జరుగుతుంది. అందులో 95% హార్ట్ కాదు. అది ఆ 95%లో కూడా హార్ట్ కాంప్లికేషన్స్ 5% దాకా వస్తుంది. అంటే భారతదేశంలో ఉదాహరణ 3 కోట్లు జరిగితే 15 లక్షల మందికి హార్ట్కి సంబంధించిన కాంప్లికేషన్స్ వస్తాయి. కొంతమంది ఆపరేషన్ థియేటర్లోనే మరణిస్తున్నారు, కొంతమందికి ఆపరేషన్ తర్వాత 24 మరణిస్తున్నారు, బీపీ డ్రాప్ అవుతుంది, హార్ట్ అటాక్ వస్తుంది. చాలా మందికి సైలెంట్గా హార్ట్ అటాక్ వస్తుంది, తెలియదు. అంటే ఎంజైమ్స్ ప్రోపనిన్ ఎంజైమ్స్ పెరుగుతున్నాయి నెక్స్ట్ డే ఆ నెక్స్ట్ డే. ఈ చేసినప్పుడు ఏమవుతుంది, వాళ్ళకి నెలలోనే సంవత్సరం మళ్ళీ హార్ట్ అటాక్ రావడం, హార్ట్ ఫెయిల్యూర్ రావడం జరుగుతుంది. అలాగే ఏట్రిక్ ఫిబ్రిలేషన్ గుండె వేగం అటు ఇటు కొట్టుకుంటాం. సో ఏట్రిక్ ఫిబ్రిలేషన్ ఎదుగుతుంది. దీన్ని కూడా చాలా ఇంపార్టెంట్. దానివల్ల హార్ట్ ఫెయిల్యూర్ రావచ్చు, బ్రెయిన్ స్ట్రోక్ రావచ్చు, దానికి రక్తం కాల్చబడి మందులు ఇవ్వాలి. ఎక్కువ ఇస్తే మళ్ళీ దానివల్ల హెమరేజ్ వస్తుంది. సో ఏట్రిక్ ఫిబ్రిలేషన్ ఎవరికి వస్తుంది అన్నది కూడా ప్రెడిక్షన్. నార్మల్ ఈసీ చూస్తే మనకు తెలియదు, మనకంటే కనపడదు కార్డియాలజీ. ఆర్టిఫిషియల్ గురించి కనపడదు. ఇదిగో సంవత్సరంలోనో 2 ఏళ్లలోనో 3 ఏళ్లలోనో ఏట్రిక్ ఫిబ్రిలేషన్ వస్తుంది. సో ఇలాంటి వాళ్ళకి జాగ్రత్తగా ఉండండి. ఇప్పుడు మనకి యాపిల్ వాచ్, ఫిట్ ఇలాంటివి అవి దానిలో మనం ఏట్రిక్ ఫిబ్రిలేషన్ చాలా మందిలో కనుక్కోలేదు. అది కరెక్ట్ కానీ 90-95% పైన కరెక్ట్గా ఉంటుంది. సో ఆ రకంగా ముందు కనుక్కునే దానికి అంటే దాగి ఉన్న బ్లాక్స్ కానీ లేకపోతే అయాన్ ఛానల్లో కొత్తగానే కొంతమందికి జన్యుపడిన లోపాలు వాటిని కూడా కనిపెడుతుంది. పొటాషియం సోడియం ఛానల్స్ అలాగే అది ఇర్రెగ్యులర్ వీటిని కనుక్కుంది. హార్ట్ ఫెయిల్యూర్ ఎక్కువ నార్మల్ ఉంటుంది, ఈసీజీ నార్మల్ ఉంటుంది కాదు. సంవత్సరంలో ఇదేదో హార్ట్ ప్రాబ్లం వస్తుంది, చిన్న ప్రాబ్లం నాకు తేడా కనిపిస్తుంది. ఆ వేవ్స్లో ఏఐ. సో ఆ రకంగా మనకి ఏఐ వల్ల చాలా మనకు హార్ట్ అటాక్ మామూలు పీపుల్లో కూడా 80% హార్ట్ అటాక్ నివారించవచ్చు. ఏది మనకి ఇప్పుడు వరల్డ్ హార్ట్ అటాక్ అయినా ఇది జరుగుతుంది, ముందు కనుక్కోలేకపోవడం దాగి ఉన్న బ్లాక్స్. నెంబర్ 2 నెక్ వచ్చినప్పుడు గ్యాస్ అనుకోవడం, ఆ డినయల్ లేకపోతే యాక్సెస్ లేకపోవడం, సరే నాకెందుకు వస్తుంది అనుకోవడం, దీనివల్ల జరుగుతుంది. 80% మరణాన్ని ఏ విధంగా మనం నివారిస్తామో పెరి ఆపరేటివ్ పీరియడ్లో కూడా చాలా కాంప్లికేషన్స్ని మనం నివారించడానికి ముందు జాగ్రత్తగా ఉంది. ఇంకా ఇప్పుడు అవగాహన పెరిగి ప్రపంచవ్యాప్తంగా కూడా కొన్ని చాలా జర్నల్స్లో వచ్చింది 2-3 సంవత్సరాలు. సో ముందు మనం చూసుకుంటే ఇంట్రా ఆపరేటివ్ పీరియడ్ కూడా క్లోజ్ లూప్ సిస్టమ్ అని ఉంది. అంటే కంప్యూటర్ ఆటోమేటిక్ డిజిటల్ ట్రీట్మెంట్ ఈ రకంగా మనం ఇన్ఫర్మేషన్ ఇంట్రా ఆపరేటివ్ సెంట్రల్ కమాండ్కి వెళ్ళిపోతుంది. అక్కడ అది అనలైజ్ చేసి పేషెంట్ బీపీ పెరిగింది, ఐసీజీ పెరిగింది, బీపీ తగ్గబోతుంది 10 నిమిషాల్లో అని ముందే చెప్తుంది. అంటే ప్రెడిక్షన్ ఆఫ్ హైపోటెన్షన్. అలాగే పేషెంట్ సెప్సిస్ రాబోతుంది, ఇన్ఫెక్షన్ రాబోతుంది, ఈ రకమైన కారణాలు అని కూడా మనకి రకరకాలుగా మనం తెలియజేస్తుంది. ట్రీట్మెంట్ కూడా ఇస్తుంది. అలాగే ఫ్లూయిడ్స్ ఇవ్వడం కానీ ఎలక్ట్రోలైట్స్ ఇవ్వడం కానీ అదే క్లోజ్ లూప్ సిస్టంలో అనలైజ్ చేసి బాడీకి రిజల్ట్స్ కావాలని గోల్ డైరెక్టెడ్ ఫ్లూయిడ్ థెరపీ, అలాగే ఎలక్ట్రోలైట్ థెరపీ. ఈ రకంగా క్లోజ్ లూప్ సిస్టంలో అది ఇంట్లో ఆపరేటివ్గా జాగ్రత్తలు అండ్ టెలిఐసీయూ ద్వారా ఆపరేషన్ టైంలో కూడా మానిటరింగ్, ఇంటికి వెళ్ళిన తర్వాత ఈ వేరబుల్స్ అంటారు వాటి ద్వారా ఈ పోస్ట్ ఆపరేటివ్ మానిటరింగ్ ఇవన్నీ కనుక సరిగ్గా చేస్తే మనం కాంప్లికేషన్స్ నుండి పట్టుకోవచ్చు అని వాళ్ళే ఎక్కువ ఎనస్థీషియా వాళ్ళకే ఇచ్చారు. ఎందుకంటే ఈ వాళ్ళే కదా మేనేజ్ చేసేది. మేము ఊరికే చూస్తాము, ఒకసారి చూస్తాం. ఇప్పుడు అలా కాదు, టీమ్ అంతా చూసి కాంపిటేటివ్ చేస్తే మళ్ళీ ఎవ్రీ టైము ఎవ్రీ కాంపిటీషన్ వచ్చినా ఎవ్రీ డే మళ్ళీ అందరూ కూర్చొని ఒక టీమ్ లాగా కూర్చొని చూస్తే కానీ మనం కరెక్ట్ ట్రీట్మెంట్ ఇవ్వగలుగుతాం. కార్డియాలజీ పరంగా ఏమి వాళ్ళు, క్రిటికల్ కేర్ పరంగా ఇంటెన్సివ్ కేర్ వాళ్ళు ఏమి వాళ్ళు. ఆ రకంగా మనం దాని సర్జన్ కూడా ఊళ్ళో ఎలా ఉంది దాన్ని బట్టి ఏమన్నా కాంపిటేషన్ వస్తుంది, మళ్ళీ బ్లీడ్ అయ్యే ఛాన్స్ ఉందా, రక్తం పలచబడి పిల్లలు ఇవ్వాలా వద్దా, ఇంజక్షన్ ఇవ్వాలా వద్దా, ఇవన్నీ కూడా చాలా అంతరాలు ఉన్నాయి.
రీజన్కి కూడా. అండ్ పేషెంట్ సబ్స్ట్రేట్ అంటే అలాగే పేషెంట్ సబ్స్ట్రేట్ అంటే కాంప్లికేషన్స్, టైప్ ఆఫ్ సర్జరీ, ఎమర్జెన్సీ, లాంగ్ సర్జరీ, ఇవన్నిటి మీద కూడా ఆధారపడాలి. యా 35 ఏళ్ళు దాటితే కనుక మన భారతదేశంలో వాళ్ళకి సడన్గా 30% 40 ఉండేటటువంటి ఈ కొవ్వు పొర చెట్టడం వల్ల, అంటే కొవ్వు పొర 60 మైక్రాన్స్ లోపల ఉంటే చిట్లు ఎందుకు అవకాశం ఉంది. దాన్ని 150 మైక్రాన్ తీసుకెళ్ళాలంటే ఎక్సర్సైజ్, డైట్, వెయిట్ రిడక్షన్, కొలెస్ట్రాల్ లోయింగ్ వచ్చి కొలెస్ట్రాల్ 50 మిల్లీగ్రాములు తీసుకురావాలి. ఇది కనుక చేస్తే ముందే కనుక్కోవాలి. సింటమ్స్ ఏముండవు, 3 గ్లాసులు ఉన్న సింటమ్స్ ఉండవు. ముందు కనుక్కోవాలి. ఎస్పెషల్లీ కనీసం మనకు ఒక ఫ్యామిలీ హిస్టరీ, ఎక్కువ ఫ్యామిలీ హిస్టరీ నేను చూస్తూ ఉన్నాను. అలాగే బీపీ ఉంటే కూడా చాలా మంది ఎక్కువ రక్తంలో ఫామ్ అవుతుంది. షుగర్ ఉన్న, స్మోకింగ్ చేసిన, ఫ్యామిలీ హిస్టరీ ఉన్న, వీటన్నిటి వల్ల జరుగుతాం. అందువల్ల ముందు కనుక్కుంటే మనం చేయవచ్చు. గోల్డెన్ అవర్ ఓకే, అన్నిసార్లు మనం ముందు ఇచ్చిన కొంతమంది చిట్లొచ్చు. అలా కనుక చిట్టినప్పుడు గ్యాస్ లాగా వస్తుంది. గ్యాస్ అని బంధించవద్దు. నేను దాదాపు 35 సంవత్సరాల నుంచి చెప్తానే ఉన్నాను. కొన్నిసార్లు చెప్పుకుంటాం, ఇంకా చెప్తానే ఉన్నాను. కానీ ఇప్పుడు కూడా మా దగ్గర వచ్చే పేషెంట్ 6 గంటల లేట్కి ఎందుకు వచ్చావు, ఒక రోజు ఎందుకు లేట్కి వచ్చావు, 2 రోజులు ఎందుకు లేట్కి వచ్చావు, నేను గ్యాస్ అనుకున్నాను. ఎవరు ఈసీజీ తీసి వెంటనే ఇంజక్షన్ కోసేయటం, స్టాంటిల్ బెటర్, కరెక్ట్ జబ్బు ఏంటో చెప్తారు. దాన్ని బట్టి మీరు కరెక్ట్గా మందు కోరుకుంటే మీ ప్రాణాలు నిలబెట్టాలి.
భవిష్యత్తులో హెల్త్కి సంబంధించి ఏఐ ఎంతవరకు తీసుకొస్తామండి?
బాగా తీసుకెళ్తుంది. ఏఐ లేకపోతే మనం డాక్టర్లో ప్రాక్టీస్ చేయలేము. మనకి ఎంత విజ్ఞానం పెరుగుతున్నప్పుడు ప్రతి అవయవం గురించి, అవయవం బ్రెయిన్, లంగ్స్, లివర్, కిడ్నీస్ అన్నీ నాకు తెలియదు. అలాగే ఈవెన్ స్పెషలిస్ట్ కూడా పూర్తిగా తెలియదు. నాకు హార్ట్ గురించి పూర్తిగా తెలియదు. అదంతా కూడా ఏఐలో నిక్షిప్తమైపోతుంది. జర్నల్స్లో నుంచి, బుక్స్లో నుంచి సమాచారం. ఇప్పుడు క్వాంటమ్ కంప్యూటింగ్ అంటే హైబ్రిడ్ క్వాంటమ్ మెషిన్ లెర్నింగ్, అది అన్ని చోట్లకి వచ్చేపోతుంది. 2-3 ఏళ్ళు ఇప్పుడు అమరావతి వస్తుంది, అలాగే వచ్చేస్తుంది. ప్రతి హాస్పిటల్లో కూడా ఉంటుంది. ఎందుకంటే టెంపరేచర్కి సంబంధం వస్తుంది. అది కనుక అయితే పుట్టిన దగ్గర ఏం జరిగింది, జన్యుపరంగా ఏమున్నాయి, మెటబాలిక్స్ ఏమున్నాయి, ప్రోటియోమిక్స్ ఏమున్నాయి, అసలు రియల్ టైం వేరబుల్స్లో ఏం జరుగుతుంది, అసలు పేషెంట్ పరిగెడుతున్నాడా, ఏం తిన్నాడు, సరిపడా తిన్నాడా, ఈ సమాచారం అంతా వచ్చినప్పుడు అది కరెక్ట్గా అది చేసి ఇలా చేసి ఇలా చేసాం, అది ముందు పడుతుంది, ముందు పడదు, మీకు జీన్స్లో ప్రాబ్లం ఉంది, మ్యుటేషన్ ఉంది, అవన్నీ చెప్తాం. ఓకే,
సో చూసారు కదా, హార్ట్కి సంబంధించి ఎట్లాంటి శస్త్రచికిత్సలకైనా ఏఐని కూడా అనుసంధానం చేసుకుని వైద్యం అందించడం జరుగుతుంది. భవిష్యత్తులో ఏఐ అయితే హాస్పిటల్స్లో చాలా పెద్ద చోటే తీసుకుంటుందని చెప్తున్నారు. అండ్ భవిష్యత్తు ఇప్పుడు చిన్న వయసులో కూడా హార్ట్ అటాక్స్ రావడానికి చాలా రీజన్ కొంచెం నెగ్లెక్ట్ వల్ల జరుగుతుందని చెప్తున్నారు. గోల్డెన్ అవర్లో కనుక వస్తే వాళ్ళకి చాలా మటుకు వైద్యం అందించి కాపాడే ప్రయత్నం చేయొచ్చని చెప్తున్నారు. వీడియో జర్నలిస్ట్ సురేష్తో హారిక వైకేఎస్ విజయవాడ.
Good afternoon, everyone. Now we resume session 2, remaining presentation. I warmly invite esteemed chairpersons of the session, Dr. Mahesh Amara, Dr. Chaya, Dr. Himabindu, Dr. Dheeraj, and Dr. Swarnikant sir to come on to the dais. For which session? I invite Dr. Vamsi Krishna M to take up this session. Emergency laparotomy on warfarin.
Good afternoon all, and thank you for the chairpersons for staying here for the post lunch session. This is interesting. Is not an uncommon case. It's a very common case that we come across in routine practice. This is a 58-year-old female who presented to us with severe pain abdomen and dark colored vomitings for one day, and she had not passed flatus for 2 days. Straightforward, the diagnosis will be intestinal obstruction will be the first diagnosis that will come into our mind. But the problem is this patient is a known case of coronary artery disease and hypothyroidism. She underwent mitral valve replacement with metallic valve few years back and was on oral anticoagulants with acetram 2 milligrams per day. And there was history of closed mitral valvotomy 20 years back for this patient. After that, 10 years back she underwent balloon mitral valvotomy, and few years, it means 2-3 years back, she underwent mitral valve replacement. Since then she was on oral anticoagulants. She is otherwise conscious, well oriented, and having signs of sepsis. It is tachycardia, tachypnea. Lungs for bilateral air entry is normal. Abdomen is diffuse tenderness is there, and guarding is there. 2D echo was done, which has shown normal functioning prosthetic valve, and there is dilated LA and normal LV function, moderate pulmonary hypertension. There is sinus tachycardia. INR was greater than 10. This is the problem. As she was on already anticoagulants and landed into sepsis, probably secondary to the intestinal obstruction, her INR is very high, and APTT is also more than 180, which is not recordable actually. And she landed in acute kidney injury also. Her creatinine is 2.6, which was normal 1 month before. She was on regular follow-up with us since mitral valve replacement. And she is anemic. There is leukocytosis and thrombocytosis. Her platelet count is more than 5 lakhs. So CT was done. Plain CT itself has shown signs of intestinal obstruction at the level of jejunum with possible bowel gangrene. We have not gone for contrast CT for this patient in view of her acute kidney injury, as plain CT itself has given some diagnosis which requires emergency surgery. This is the 2D echo report, which has shown moderate pulmonary hypertension with normal functioning mitral valve, metallic mitral valve, and INR is very high, and APTT is not recordable actually. Creatinine is high, anemia and thrombocytosis is there along with leukocytosis. CT has, the radiologist has given the suspicion of bowel gangrene, which is an absolute emergency for taking up for emergency laparotomy. At this point, the discussion is how to decrease the INR rapidly, as this is an absolute emergency. Each hour delay in surgery for this patient will increase mortality by 3 to 5%. In such scenario, how to decrease the INR is the discussion rapidly. What are the options available to decrease the INR? Can the chairpersons discuss, ma'am? Mic cut.
So PCC concentrate.
This is very, most of the times it's not available readily. That is the problem with PCC. Actually, we have given an immediate IV injection of vitamin K, but the problem with vitamin K is it takes some time for the clotting factors to get restored. So our option is available is the easily available option is the fresh frozen plasma, and with fresh frozen plasma within 15 to 30 minutes we can revert the INR to normal levels when the patients were on vitamin K antagonists. Okay, and particularly this patient is already having acute kidney injury, moderate pulmonary hypertension and sepsis. Here the problem is again not to overload, not to not to decrease the preload, particularly not to underload the patient. So we used the dynamic parameters in this patient. Particularly, we immediately at the emergency room itself went for invasive blood pressure monitoring, and we used the pulse pressure variation, particularly to titrate the fluids. As she is already at presentation itself is having tachycardia and tachypnea, which are the signs of landing into sepsis, and BP is also lower side for this patient. And the fluid balance in the perioperative period is very important. Except pulse pressure variation, and in the intraoperative period we can use can we rely on the CVP in this patient is the question. What about your opinion, ma'am? Can we rely on the CVP in this patient?
CVP will not be able to give the correct picture of the exact cardiac status.
Okay, okay, sir. So, we accept this pulse pressure variation as the patient is while in the intraoperative period. Any other parameters that can be used to titrate the fluid, as the surgery itself requires massive fluid shifts.
We can see the IVC collapsibility in this patient.
That is an intra-abdominal surgery, laparotomy. IVC collapsibility measurement may be difficult, sir. That is the problem that we faced. And we can we use this echocardiography?
TE, if at all we have the facility and expertise of taking help of TE, it would help us.
Yes, yes, sir. Actually, TE could be very useful in this patient. And if suppose if this is an elective surgery, and there is no absolute emergency, when we need to stop the acetram? That is the another question for elective surgery. That is actually how many days we have to wait after stopping the acetram?
72 hours. 72 to 3 to 5 days is the ideal time.
Okay,
And meanwhile, we can bridge the patient with heparin, unfractionated heparin.
Okay, sir. Actually, what we follow is that after stopping acetram, when patient is posted for surgery, we do regular PT-INR. If the PT-INR is within INR is less than 1.5 or acceptable range, even not to, we won't wait for 3 days also. Can we take up surgery at that point? I think we can. I think we can, sir. And what are the how to monitor the acetram effect? One is PT-INR. Is there any other tests that were available to monitor the acetram effect? Is one more question, sir, for the discussion.
We can take help of TEG also if we have.
Okay, okay, sir. Okay. One more question is that even for emergency surgery, even after FFP, the INR is not coming down. What will be the other option except PCC? Is there any other options that will be? This is very important actually, that we can face the scenario, particularly when the patients were in sepsis on oral anticoagulants coming for an emergency surgery. Even after giving FFP, sometimes we may not achieve the INR to an acceptable range. And PCC is not easily available at most centers, and that is very costly also. What other options that were available, if at all any there?
we can try for cryoprecipitate.
Okay, okay, sir. Okay, thank you. Actually, the fibrinogen levels were, we usually do serum fibrinogen levels. If they are less than 200 milligrams per liter, we go for cryoprecipitate in that scenario. But most of the times, this with FFP itself, the INR will come down to normal, and after FFP transfusion of 10 ml per kg, we did for this patient we did INR after 30 minutes. INR came down to 4. That is, and one more thing is that and how to maintain mechanical valve function, not to prevent its obstruction after stopping acetram is one more question, sir.
One thing is to maintain hydration part.
Yes.
If you can maintain the patient euvolemic status, to some extent it can help.
Okay, okay, sir. And one is hydration is a very good this thing to prevent the valve obstruction. But any other parameters that we can regularly monitor to see the valve is functioning normally, or to make it valve function normally when the patient received FFP, and as surgery itself is a procoagulant state.
Transesophageal echo or the regular conventional echo.
Okay.
We can see directly the valve status.
Okay, sir. In this patient, actually, we have not used transesophageal echo. We continuously simple auscultation, and we have continuously monitored the mechanical valve beating sound, clicks, that we placed a stethoscope over the chest and fixed it, and we kept that entire throughout the period of surgery. We continuously at regular intervals we auscultated the cardiac sounds and made sure that valve function is valve is normally functioning by hearing the metallic sounds. That is one more thing. And surgery went well. And when to start the anticoagulants after a major surgery like laparotomy? That is one more question, sir.
With this, we have to take the help of a surgeon. From the surgical point of view, we should make sure that the drains are very minimal. Probably in the next 12 to 24 hours, we should be able to start the anticoagulation.
Okay, sir. And what anticoagulant that is preferred in a patient with acute kidney injury and on metallic valve in the post-operative period?
Conventional heparin would be the ideal one.
Okay, sir. If there is heparin resistance, or if heparin-induced thrombocytopenia is developing, is there any other option, particularly in acute kidney injury? That is one more point.
The problem with low molecular weight heparins are most of them they will be precipitating the kidney injury.
Yes.
Out of that, fondopyrinax would be the best choice if we have to use it.
Okay, sir. And will there be any use for heparinides?
I did not use any time.
Okay. I am also having no experience, but in one case where heparin-induced thrombocytopenia has developed, particularly in such scenario, we have an experience with the bivalirudin, which can be easily titratable, and it has very low, very short half-life, less than half an hour of half-life, and it can be used for continuous infusion, and we can titrate, we can monitor the bivalirudin effect with APTT or ACT also. That for one case we have an experience with where a patient is having kidney injury, acute renal failure with heparin-induced thrombocytopenia. We have that experience. That is another option. We have kept ready bivalirudin for this patient. And after surgery, and when patient was on anticoagulants, particularly with heparin or low molecular weight heparin, what are the available laboratory parameters to monitor the achieve coagulation status, whether that is in acceptable range or not.
If patient is on heparin, we'd monitor with the APTT.
Yes, sir. If the patient, suppose if the patient is on low mark load heparin, how can we monitor, sir? Is there any other available monitoring options? Is one more question for discussion here.
A regular BT-CT also will be.
Okay, sir. Actually, there is no easily available monitoring options in the when the patient was on low mark load heparin. But if needed, we can monitor. Is there any role for anti-factor 10A, measuring the 10A levels?
Definitely.
But that is not available easily, routinely, sir. And what are the options of regional anesthesia in this patient in the post-operative period?
Since because of the coagulation issue, we will not be able to place an epidural catheter. So we have to rely on the paravertebral blocks or QL blocks or SL serratus erector spinae blocks.
Okay, quadratus lumborum block. Yeah. That actually, and is there any contraindication for the deep muscular, intramuscular blocks like quadratus lumborum block when the patient was on anticoagulation is another dilemma.
When compared to the epidural, this would be a safer option, but best would be the erector spinae block.
Yes, okay, thank you, sir. And what will be the infective endocarditis prophylaxis option for a patient undergoing laparotomy with acute kidney injury with metallic valve?
Regular cardiologist. We'll go with regular IE prophylaxis.
Yes.
Renal protective drugs we have to choose, and regular amoxicillin can help.
For this patient, we have stopped a Citram. Already patient is having severe vomitings, and infective endocarditis prophylaxis was given with cephalosporins, and immediately 4 units of FFP was transfused. And in view of anemia, particularly hemoglobin is 8 grams, and is having moderate pulmonary hypertension. We have transfused 1 unit of packed cell in the ER itself, and vitamin K 10 milligrams IV given, and we have given 1.5 liters of fluids, and emergency laparotomy was planned. But after FFP transfusion, also her INR is 4. That is within half an hour itself we repeated the INR. So we repeated another 3 more units of FFP, and after this INR came down to 1.3, and we operated with the minimum amount of blood loss, acceptable blood loss of not blood loss is not that as we anticipated. It is around 1 liter only. So we transfused another 2 units of PRBC in the intraoperative period, and after fluid resuscitation and maintaining hemodynamics, our urine output improved. And the patient was shifted to ICU, extubated on the same day, and in the post-surgery we have given 5,000 units IV heparin 3 times a day. Here is the dilemma is that whether to go for continuous infusion or intermittent doses of heparin is in dilemma, but we use intermittent heparin doses for this patient, and daily APTT was monitored. On day 5 enteral feeds were started, and once enteral feeds were started and renal function was normalized, we switched to low mark load heparin and started acetram also. For 3 days we continued the acetram and low mark load heparin, and on 3rd day we stopped the low mark load heparin, and with INR of around between 2 to 3, we discharged the patient and asked to follow with the surgeon within 1 week to check the INR again, whether that is in stable 2 to 3 or 2 to 4 range or not. Okay. Thank you, sir. Any questions or any inputs from the audience? Sir?
Thank you, Dr. Vamsi Krishna, sir.
Thank you.
For your
Sir, we'll take the questions after a while, sir.
Yeah.
Thank you, sir.
Okay.
Thank you.
I invite Dr. Shweta, a consultant anesthesiologist, Aster Ramesh Ongol, to take up the session, Emergency Craniotomy on Dual Antiplatelets.
Very good afternoon to one and all. It's a post-lunch session. Hopefully everyone is awake. I'll be making it a little short, finishing it within the time. Presenting you an interesting case, a recent PTCA patient who actually came to our Yeah. 77-year-old male patient with a known history of diabetes on oral hypoglycemic agents, hypertension, and a coronary artery disease with an recent PTCA to LAD 3 months back. He was put on dual antiplatelets with clopidogrel and ecosprin. He was wheeled into a ER with complaints of headache and history of seizures since a day. And on arrival, he was in altered sensorium. On examination, he was drowsy, arousable, but obeying simple commands. His GCS was 15/15 with no neurological deficits, and the rest of the vitals and systemic examination was normal. Based on his clinical examination, we wheeled into a neuroimaging. Neuroimaging showed, CT brain showed acute SDH with a good midline shift of around 10 mm. The rest of the investigations were normal with PTINR normal and a platelet of 1.5 lakh, and ECG showed all Q waves in the anterior leads, and echo was showing a regional wall motion abnormalities in LAD with an EF of around 44% with mild degenerative valve disease. Based on his initial findings and the examination, the cardiology opinion also was taken based on his recent CAD status, and multidisciplinary team counseling was done, and actually the patient was planned for a emergency right frontotemporoparietal craniotomy, the evacuation of SDH. Seeing this patient are multiple questions ponder. This is a case in front of you in the ER. These are the few questions which ponder in your mind, open for discussion. How do you assess the platelet quality in these patients already on antiplatelets? The normal labs seem normal, BTCT normal, PTFTTIN are normal, platelets count is absolutely fine, but still we are cautious when we are treating these patients for elective or an emergency surgery. Now, how do we assess the patient platelet quality in these patients? To the panelists.
Thromboelastogram.
Yeah. Nowadays, with the multiple point of care platelet assays available, widespread use of thromboelastography, ROTEM, sonoclot, these are the few things which are widely used. They help you guide through the requirement of blood and blood components so that we cautiously use. Next, what is the role of blood components when posted for emergency procedures? When such patients are being posted for the emergency procedures, how do we balance the role of giving the blood and the blood components?
Since this patient will be on dual antiplatelets,
Yeah, sir.
It is more of the qualitative problem than the quantitative problem here.
Yeah, correct, sir.
So, as madam said, we'll try to assess the platelet dysfunction from the TEG.
Yeah.
If required, we'll keep SDPs ready,
Yeah.
single donor platelets
Yeah,
ready,
yeah, good.
and then we'll optimize the patient.
Yeah.
According to the time constraints,
Yeah.
and then if platelet, if once 1 or 2 packets of SDPs are transfused,
Yeah.
We can assure that quality of anticoagulation will be maintained.
The role of transfusing blood components prior to the procedure is still questionable, sir.
Questionable.
Yeah, yes. The moment the surgeon opens up the dura or in and around that time will be probably a better time to transfuse because
once the
we have to focus on the
clot
cardiac
is evacuated,
part.
that would be an ideal situation.
Correct, sir. Because we need to focus on the cardiac part also, because we don't want the cardiac to be in trouble. So we need to be cautious on that part. And what are the my next question to ponder is how do we prevent the perioperative bleeding? We don't want too many mishaps, too many fluctuations happening in your patient. There are certain measures which we take to prevent perioperative bleeding from the surgical, from the surgeon side, from our side. What are the few things which we take into consideration to avoid, to prevent the transfusion of blood and blood components? Too much excessive transfusion is also harmful for the cardiac part, for the cardiac side. How do we prevent? From the surgical side, we ask for a better microsurgical hemostasis. We ask the surgeon to not to ponder around the dural sinuses so that don't trigger much of the bleeding from surgical part, and hemostatic agents, use of those agents in and around the clot area. These are the few things which we tell from the surgical side. From our side, we maintain normal pH. We have to maintain.
We should try to maintain good oxygenation.
Yes,
maintain the hemodynamics.
Yeah.
Maintain the volume status.
Yes.
And keep an eye on the mean arterial pressures.
Yeah.
And avoid things which will imbalance the oxygen supply demand of the heart.
Yeah, acidosis, no acidosis, calcium level should be normal. Okay, no much use, excessive use of crystalloids. You use more of crystalloids in your case, you're causing damage to the heart, and also on the coagulation system, causing a reduction in your quality, circulating platelets are reduced. You are again causing excessive bleeding to your patient. So cautious use of crystalloids, and obviously cautious use of blood and blood components in your case. This is kind of a double-edged sword which you need to balance between the risk of excessive bleeding, at the same time risk of your stent thrombus. So you need to be more cautious. Next is a very important question. You take up the case for surgery, procedure is done. When do you restart your antiplatelets? Because your heart, your LAD stent has been placed just 3 months before. So when do you restart in your post-operative period? When do you restart antiplatelets?
First of all, we can continue the use of ecosprin.
Yeah.
Aspirin can be continued.
Yeah.
We can withhold only clopidogrel.
Okay.
And immediately after 12 to say 18 hours, get a scan done.
Okay.
From neuro side.
Yeah.
If reasonable midline shift is reversed and there is minimal bleeding, we can take a help of a cardiology team and restart it in less than 24 hours.
Yeah. Okay. Yeah, usually within the first 24 hours, we need to restart ecosprin. If at all, if we have given a break, then within the next 48 to 72 hours, we need to start up the next agent. If there is any bleeding or anything, we need to add on with terofeban infusion so that we avoid the stent thrombosis part with a cautious monitoring of ECG and echo. Now, next, let's move on to what we did in our case. These are the few things up for discussion. What we did in our case is with good pre-op counseling, and we made a 2 unit of Paxils and 2 unit of SDP. We secured wide bore IV cannulas, and arterial line was secured for invasive blood pressure monitoring. We proceeded with general anesthesia with the cautious crystalloid usage, and intraoperatively, once the dura was open, we transfused SDP, and Paxils also was transfused, and approximately the blood loss during the procedure was approximately 500 to 750 ml, including the clot. A subleal drain was placed, and the rest of the procedure was uneventful. Till now, we were in the smooth part of the curve. Okay, so we pre-op GCS was good, so we decided to extubate the patient on table. Post extubation, his GCS was 15/15, no neurological deficit, so we shifted the patient to MICU. continued the routine neurotropic agents, antiepileptics, antibiotics with pain management, and GCS was monitored throughout the night. Next comes the twist in the story. GCS over 8 to 10 hours. After 8 to 10 hours, GCS dropped. GCS dropped to 8. Slowly GCS dropped. So the next thing was we wheeled the patient to the CT. CT was showing reaccumulation of SDH with mass shift, with midline shift. So we immediately secured the airway, put him on mechanical vent. We counseled the attenders. For an emergency, redo craniotomy and evacuation of SDH. But somehow the attenders were not willing due to multiple issues concerning the patient. So they opted for a conservative line of treatment. So we, after all the undue risk explained, we started with the conservative line of treatment. We transfused one SDP, pack cells were transfused, inotropic support was started, and patient vitals were maintained stably that day. We post-operative day 2 with stable vitals, we got a repeat CT done on mechanical ventilator support only. A little reduction in the SDH size was noted, and cardiologist advice, upon cardiologist advice, the dual antiplatelets were started on POD 2, and patient slowly was recovering, shifted over to TPs, and by POD 3 the SDH slightly reduced, much better. Patient was still on dual antiplatelets. GCS was good, E4 VTM5, and the next day by POD 5 the patient was extubated with better GCS, but little E4 VTM6, but the limb power on the left side was around 4/5, a little loss of his power, but otherwise he was pretty good. The drain removal was done by POD 4, and she was shifted to room by POD 10, and the suture removal was done by post-operative day 12. By post-operative day 15, he was discharged with dual antiplatelets and statins on advice with a GCS of 15/15, but with 4/5 power on loss, left hemiparesis on the left side. The rest of the wound was healthy. What we did better in this case is we were very cautious with the fluid and the blood and blood components management. We didn't aggressively treat it, and throughout the course, regular cardiologist monitoring, ECG and the troponins were regularly monitored throughout. There was no issues from the cardiac side. So there was not much issues. Only issue we faced was the SDH rebleed immediately in the POD 1. And what other thing we could have added up in the management of this case was thromboelastogram would have guided us more in the management of blood and blood components. We went a little blindly into the whole process of transfusion, but otherwise if TEG was available, it would have aided it, and we would have probably avoided the even 1 or 2 components of transfusion. But that was the one thing we were in this thing. Otherwise, everything went on smoothly. Thus, when you're managing such patients, for a better outcome, we need to always balance a life-threatening intracranial bleed against the risk of acute stent thrombus. So we need to be more cautious when you're balancing, and we need to balance and then treat your case.
If at all we have an option of giving any advice to the neurosurgical team,
yes, sir.
Better not to put the close the skull bone flap,
so that
we can anticipate such type of problems in the post-operative period.
Yeah, that is one more added
thing, sir. Definitely been bit helpful.
Yeah, it will be helpful for sure.
Yes, definitely that would be helpful. But in this scenario, a rebleed chance and another craniotomy, so we have taken an option. They have taken an option mostly because antiplatelets needs to be started 24 hours. So a repeat scan within 6 hours would be much helpful. The main thing here is any progression in the bleed within 24 hours with serial scans. If at all there is no progression or any new bleed or no progression, then we can start the antiplatelets in the first 24 hours, after 24 hours. So a repeat scan is ideal and must. And in this scenario, taking the patient's general condition and also the coronary status, an option was taken to place the bone flap. That means that we didn't go for any craniectomy there. So craniotomy and replacement of the bone flap was done at that same sitting. The only reason being not to subject the patient to another surgery and take the risk again, because the brain was fine and there was no surfacing. The only thing is a rebleed here. Yeah, definitely removing the bone flap would be ideal.
If things goes bad, we'll think like this. If things are all right, we think in another way.
That's there. Thank you, Dr. Shweta.
Thank you.
We next call upon Dr. Kartikeya J, Consultant Anesthetist and Intensivist at Aster Ramesh Hospitals, Vijayawada. He's going to talk about AI-augmented tele-ICU systems in the perioperative setting.
Good evening, one and all. After the impactful session about AI in modern developments and modern science and evolving technology by Dr. Ramesh sir, I'll take you through, breeze through a couple of slides. Continuation of that, but I think the session is completely changed with us being post-lunch and a bit delirious and drowsy. So I quickly break this topic into four subtopics. I'll breeze through evolution of AI and telehealth, our journey in telemedicine chapter, augmentation of AI in the peri-op anesthetic period, and challenges currently that AI is facing in the modern medicine. So it all started with EMS philosophy. This is Mark Olsky. So he's actually born in a train when his mother was fleeing away from the World War II. So he advocates modern medicine, and he always had emphasized that we need to constantly update our knowledge and skills to treat and transport patients to the best destination and have best treatment. So what the World Health Organization say, there is a life expectancy gap of around 18 years between the richest and the poorest countries due to unequal access for the healthcare. AI offers the potential to close this gap and increase the efficiency and accessibility. Also, utilizing AI-based digital technologies, we can personalize and give advanced, timely treatments with modern data. So we hear the word saturation. We hear that we have too many orthopods, we have too many anesthetists, too many doctors in our current city or state, wherever we stay. But we are still short of 9 million doctors. We have close to 0.7 doctor per 1,000 population, where other countries on a global average is 1.8 to 2.2. We are also short on nurses. We have 1 to 1.7 nurses, while other countries have 5 nurses per 1,000 of population. So we are still quite short. So the doctor-to-patient ratio in India is 0.7, where the global average is 1.4, and other countries it's 1.7, 1.9. There is still 83% shortage of specialist medical professionals, according to Health Ministry data. In terms of evolution, we all started off with carrier pigeon sending off messages, smoke signals coming through, messages in a bottle, Pony Express telegrams, balloon mail telephones, and we evolved into cell phones and modern AI technology. So the healthcare evolved from informal caregiving and spiritual healing to science-based technology development. So going across with the evolution of healthcare, we all transformed from episodic care to continuous care, where there are remote monitoring and diabetic sensors installed for real-time monitoring, and from subjective judgment to quantified data, where we have digital imaging, digital vital monitoring, and Apple recently formed out a mirror where we can wake up and stand in front of a mirror. We can see all our vitals in a single frame. We also evoluted from one-size-fits-all treatment to precision medicine, which is the crux of current technology, based upon genomics, epigenomics, and targeted therapies. And we also evoluted from hospital-only treatment to hybrid virtual care, where it incorporates telehealth and in-person treatment. So why tele-ICU? The programs concentrate more on clinical resources in remote care centers to bridge the gap between the richest and poorest countries. It provides care in distant area, round-the-clock 24/7 availability, reduces the financial burden, scalability of the beds increase, helps in early diagnosis, prompt treatment, and improve the level of existing ICU care. So these are the other financial benefits of tele-ICU: reduction in the length of stay, paperless workflow, electronic health records, reduction of overtime, scalability of the beds, and accreditation and easier insurance claims and settling. So we also have the round-the-clock surveillance from a central command stage center, where collaboration and support is available from all subspecialties and super specialties. So AI is based upon four main things. One is AI-based telemedicine is based upon four main things, to be precise. One is machine learning, where it analyzes the patient data, personalizes the treatment, and gives the plans. The second one is NLP, which is the natural language processing, which is a very nice tool, have a chatbots, and personalize the medical drugs and treatment. The other one is a computer vision, which incorporates convolutional neural network. So that detects the cancerous lesions, diabetic disorders quite early. And there is also deep learning, which detects digital X-rays, MRIs, and interprets very quickly. So this is all where it began. This was more than a decade ago, where Cloud Docs, this is a personalized version of tele-ICU of Ramesh Hospital. So it incorporated three main principles, where we input continuous data streams from electronic health records, monitors, and lab systems. Then we process by AI algorithms, and output alerts were given quite quickly to clinicians for early interventions. So we created this network across all the ORCs, outreach centers, keeping the three main hubs: the Vijayawada Hospital, 2 hubs. One is the cardiology and neurology, and the Guntur Hospital being the multi-specialty hub. So these are the ORCs that are spread across a couple of districts nearby to us. There's more than 20 ORCs where we collect data, we monitor real-time patients, and we have also expanded to several other hospitals for easy access. So this is a slide which shows the central command station. And once the command station finds any abnormality, the announcement of tele-alert goes through quickly. Direct point of care alert goes through a hub, which is visualized, and audio message has been sent quite clearly. So there's a dual assessment at all points, where there's an audio-video connection, and there's also multi-parameter monitoring. So together, things are analyzed by 24/7 doctoral support. This is how CPR is being monitored in the emergency room. And we also have a sophisticated tele-ambulance, where we give continuous alerts and monitoring advices. This is the TeleSmart ambulance, where we can see the nurse giving out patient data, and we are giving prompts through the speaker. Couple of examples in the recent time in the perioperative period, where we have detects being alerted quite quickly. So there's a 38-year-old female who had an emergency laparotomy for obstructed hernia, developed suddenly shortness of breath and severe tachycardia and ventricular tachyarrhythmia on post-operative day 2. This alert was given in 10 seconds time, the quite quick response time, and she was shocked and she was fine afterwards. Couple more examples: resection of prostate, day 1, type 2 diabetes, hypertension, COPD, and ischemic heart disease history, develops breathless suddenly and respiratory distress. So he's been alerted quite quickly. And another case which has actually come to a cath lab with acute coronary syndrome, had anterior wall MI, initially stabilized with medical management, then shifted to cath lab, had the procedure, good TIMI flow, and went to HTU, where there's an alert, she suddenly got worse. So in terms of perioperative period, how things work. So this is how real-time monitoring happens. Like I said, dual monitoring, where we see an operation theater monitor, and there's a person who is constantly monitoring the vitals in the tele-ICU department. So alerts will be given straight to the operating room in case if anything is missed, even though we have a constant anesthesia monitoring over there. So we all started off from 2000 BC, and initially there were days where they used sponges soaked with opium and mandrake plant for surgical pain relief. But now we have evolved slowly into robotic anesthetists, where robots can intubate patients. So the augmentation of artificial intelligence in the perioperative period, so it can be divided into three things. One is the preoperative AI, where it predicts the preoperative risk, estimates transfusion needs intraoperatively, predicting difficult airway, and pre-op stratification of post-operative complications. The intraoperative AI, which is augmented, helps in making decisions regarding regional anesthesia, intraoperative monitoring, prediction of hypotension, fluid and vasopressor administration, and depth of anesthesia. While the post-operative AI predicts in adverse events, alerting changes of the patient condition, discharge planning, and optimizing pain control. So other modalities of AI used in telemedicine. So we have AI-powered wearables, teleconsultations, medication management, virtual triage, remote monitoring, diagnostic assistance, and rehabilitation. So in terms of AI development in anesthesia, so we have CLADS, which is a closed-loop anesthesia delivery system, where, like Mahesh sir said in the morning, determines the right drug with the right dose at the right time. So it has a constant infusion pumps, which the data is being monitored through a computer-generated-based system, and the vital signs are monitored in a different screen, and the depth of anesthesia is being monitored by the bispectral index. So it helps in ventilation control, hypnosis control, nociception control, neuromuscular control, temperature and metabolic parameter control. So this is the first robotic tracheal intubation done in 2012. So this has a success rate of 91%. A recent study showed the success rate has increased to 98%, but even 2% non-successful intubation, that can lead to mortality. So it has a couple of arms, robotic arm, joystick, and a video laryngoscope and a software control system. The other feasibility of automated total IV intravenous anesthesia drug surgery delivery system for the cardiac surgery has also been tested. This is also a closed loop system like CLADS before. So there's something called cutting edge artificial intelligence model for AI enhanced electrocardiography. So this is used for complete heart block dissection identification. So the success rate was 84 to 94%. So people were tested based upon their ECGs. They were about 7 to 12 times more likely to develop complete heart block compared to low-risk patients. So another AI intervention. So this has a sensor is placed and the ECG is connected. So based upon the sensor and the ECGs, AI-driven AF detection in embolic stroke patients can also be used. So this has high success rate in the recent times as well. So we are changing slowly. Most of the radiologists might not like this slide, but in terms of efficiency, the radiologist detected anomalies are 78% accurate, while AI detected anomalies are 92%. So comparison between radiologist and AI detected anomalies, we still have almost 15 to 18% difference. AI related interventions in critical care, we can detect the sepsis early. We use Muse and SOFA score, where the sensitivity is 70 to 75%, but AI solutions give the score of 90%, specificity of 65 to 70%, and AI solutions give the score of 90% again. And the main difference between AI-based and traditional scores-based sepsis detection is in the response time. So based upon traditional scores, we have a rapid response time of 2 to 4 hours, while real-time response and within minutes, you can actually detect sepsis and intervene quite early. So pros and cons of AI in healthcare, is it good or bad? But it also depends upon who created it and for what purpose it has been created. It's always a double-edged sword. It offers immense potential for faster, more accurate diagnosis, personalized treatments, administrative efficiency, and decrease in bias. So the main advantages, we can see there's a breakdown of time savings. Data analysis, we have 15% improvement. Alert generation and critical incident detection, 10% improvement, and decision making, it helps at around 5%. So anything out of these three, that's always a plus for the patient to detect the sepsis early and intervene early. In terms of challenges, privacy and security concerns are always prevalent for AI. Ethical considerations, data quality, precise algorithm division, automation and job losses, volatility. So overcoming these challenges requires strong collaboration among healthcare providers, technology developers, and regulatory bodies. So the current ICU rounds involve many of the clinicians. You need a critical care consultant. You need sometimes you need anesthetist. You need cardiologist. You need neurologist and a parent consultant, and a physiotherapist and dietitian together to have a multidisciplinary round for a critical care. But in future, you will have a single person sitting in a robot docked and operates with multiple arms, and he will be able to do everything what all these people can do. So I don't like the automation and job losses, but I'm afraid the future will be different. Predictive analytics, clinical decision support systems, natural language processing systems, and real-time alerts are going to play a key role in the future ICU rounds, where, like in the photo, one can sit in the docking station and do everything. Don't have copyright for this photo, so I might be sued later. So the medical futurist envisions that AI is not a replacement for doctors, but it is an essential tool. Like we had stethoscope for the last two decades, I think AI will become the stethoscope for us in the next 2 decades. With the advancement of AI, telemedicine is also set to become increasingly efficient, accessible, and focus on the needs of the patient. So diagnostic accuracy, tailored treatments, and broadening of healthcare is the primary goal of our AI-related telehealth. But on the same way, like it's a double-edged sword, we also need responsible use of AI to uphold patient safety, privacy, and deliver quality, precision-centered patient care. Thank you for that.
Thank you, Dr. Karthikeya. We'll take any questions later in the session. I thank all the chairpersons gracing this session. We'll now have the next session. For the next session, I call upon stage the chairpersons, Dr. Samarjit Dev, Additional Professor of Anesthesia, AIIMS Mangalgiri, Dr. Mahesh Amara, HOD Anesthesia, Lalita Hospitals, Dr. Subit K, Consultant Urologist, Aster Ramesh Hospitals, Dr. Shivaprasad M, Consultant CTBS Surgeon, Aster Ramesh Hospitals, Dr. Swarnakant Y, General Surgeon, Consultant, Aster Ramesh Hospital, Dr. Ram Manohar T, Consultant Cardiologist, Aster Ramesh Hospitals, Dr. Chaitanya K, Consultant Medical Gastroenterologist, Aster Ramesh Hospitals, Dr. Somnath HS, Consultant Cardiologist, Aster Ramesh Hospitals, and Dr. Bharat Chandra K, Consultant Orthopedist, Aster Ramesh Hospitals. I now call upon our speaker, Dr. Praveen Kumar N. Dr. Praveen Kumar Garu is a Chancellor in Indian College of Cardiac Anesthesia. He is an adjunct professor at CME Indore. He has served as professor and head cardiac anesthesiologist at institutes like AIIMS Kochi and AIIMS Raipur. He is a recipient of Brig PN Butt Oration for the year 2024, which was awarded by Indian Association of Cardiovascular Thoracic Anesthesiologists. He is an academician par excellence, national and international speaker with around 200 publications and has authored chapters in 10 books. Thank you, sir. We'll now start the session.
Thank you very much. At the outset, I would like to thank Dr. Ramesh, Aster Ramesh Hospital team, and my colleagues over here, Dr. Samarjit and so on. I would be talking about, am I audible at the back? Yeah, thank you. I would be talking on advances in perioperative pain management in cardiac patients. Well, I started my career at Sri Chitra Institute, Trivandrum, and you may be wondering why I'm showing this picture. The reason is that when I started cardiac anesthesia practice, the analgesia was totally narcotic analgesia, that's morphine and only morphine. And from there, I moved on to AIIMS Raipur. And fortunately, you see I was shaping the department of anesthesia, not cardiac anesthesia, the department of anesthesia. And fortunately, we selected one of the chairperson, Dr. Samarjit. And he's so good in, you see, the pain medicine, chronic pain, acute pain, etc., that I took a lot of, you see, I would say, lead from the way he used to manage the patients, blocks, etc., that I felt that future for anesthesia is blocks. It's not the narcotic analgesia. The future in anesthesia is excellence in blocks. In fact, I have seen some of the patients where I felt that it would be very difficult to give anesthesia, and those patients were managed by Dr. Samarjit under some or other kind of block. So it was so fascinating, and so, you see, it changed my thinking about analgesia, perioperative analgesia. And I felt that, you see, the blocks, etc., has to be the integral part of management. So from there I moved on. I retired from AIIMS Raipur in 2020, and from there I moved on to Amrita Institute, Kochi. And there, when I joined, the practice was same narcotic anesthesia. But I felt that a block should be the part of it, and that's why all these photographs, that I made sure that all the cardiac patients, they receive one or other kind of block. And by the time, you see, it was 2 years for me there in Amrita Institute, all the patients, they were receiving ESP block, whether it is a neonate or it's an elderly patient, unless the patient become unstable while inducing. Otherwise, all the patients, they were getting blocks. And believe me, the blocks made the life very easy for the patients. The post-op delirium incidences came down drastically. The patient satisfaction improved like anything. So I start with my talk about perioperative pain management. See, if you look at in cardiac patients, it is a very important, very prophetic and profound statement by the ESC and ACC-AHA that inadequate analgesia is a modifiable cardiac risk factor. What does it mean? That a patient not having appropriate analgesia can be in difficulty. So the analgesia has to be appropriate for the patient. Now, what inadequate analgesia does? It triggers tachycardia, hypertension. It increases the wall stress of the left ventricle and creates a prothrombotic state, and which can end up in perioperative myocardial injury. Here I would like to let you know that the perioperative myocardial injury and perioperative myocardial infarction, they are two different entities. When you talk about injury, there may not be any ischemic event, but if you check the cardiac troponin, you will find cardiac troponin is above 99th percentile. But when you talk about the perioperative myocardial infarction, it is associated with the symptoms, associated with the change in ECG and increase in the enzyme. So there is a difference between the perioperative myocardial injury and infarction. Now you see the incidence of myocardial injury after non-cardiac surgery. In one of the very large systematic analysis, review and meta-analysis, they found an incidence of 17.9%. That is in a population of cardiac patients undergoing non-cardiac surgery, 5,30,867. So it is not something very, you can just, say that it is not important. 18% is a huge, it's a very big incidence. Almost one patient out of 5 cardiac patients during perioperative period can have myocardial injury, when undergoing non-cardiac surgery. Now this myocardial injury in non-cardiac surgery, there are so many studies, some 25 studies. They found that it is associated with 8.1% mortality in patients, those who suffer from myocardial injury, as against those who do not. And if you talk about the mortality at 30 days and at 1 year, still it remains high, 8.5% in those who suffer from injury and 20.6% at 1 year in those who suffer from injury, while those who do not, it is just 1.2% and 5.1%. So it is clear that the perioperative myocardial injury has to be taken care of, has to be avoided. Now, as I have mentioned, that what is responsible for that? It is perioperative myocardial injury, and the trigger of that perioperative myocardial injury is inadequate analgesia causing tachycardia, hypertension, prothrombotic state, and so on. Okay. So not only this inadequate analgesia associated with perioperative myocardial injury, it is associated with nausea and vomiting, impaired immune function, delayed wound healing, delayed discharge, psychological stress, and so on. Now you see, when we talk about perioperative, what kind of analgesia you are going to give to a patient. There is no, you see, one suit fits all, nothing like that. It has to be tailored for each patient. The reasons are that each patient is different, their social background is different, their level of education is different, the kind of disease with which they are coming is different, the type of surgery they are going in, that is different, and the pain history. Suppose some patient has gone under some or other kind of surgery before, and if the analgesia was not good during that surgery, the patient's reaction or patient's mental makeup will be very different than the one who has been given a very good perioperative pain care. So that also, you see, makes a difference in the kind of analgesia you are choosing for the patient. Now you see, recently the Association of Anesthetists and British Pain Society, they came out with the concept of pain team. Like you see, many of the places you go, they have got a heart team. You go to the places, they have got, it's not, this is something that has, you see, the importance, perioperative importance has gone up like anything. Now, who all are the members of the pain team? It's headed by the pain specialist, anesthesiologist is the member, surgeon is the member, and the nurses, they are the member. The reason being that you see what is happening to the patient, the feedback is given by the nursing staff. Hospital administration is a very important member of this pain team. The reason being that if the patient goes out of the hospital, discharge, post-discharge, if the patient is not satisfied, naturally it lowers down the image of the hospital, and therefore the hospital administration is there on the board of pain team, and they ensure that whatever has been decided by the pain team has to be implemented. Psychologist is a member, and yes, the patient also, because you can talk to the patient and you can come to know that what kind of the intraoperative, postoperative, preoperative pain relief, etc. is to be designed for the patient. Now what the pain team does, you collect appropriate information, because again, when I said, I just mentioned that every patient is different, surgery is different, patient's psychological makeup is different, patient's background is different. So these are all the important information that is collected by the pain team. Now it is the responsibility to ensure that whatever the pain team, the kind of analgesia the pain team has decided for a particular patient is really implemented. It is the responsibility of the pain team to educate the staff. Reason being that you see when we talk to the patient, we say, दर्द हो रहा, हाँ भी हो रहा, कितना दर्द हो रहा, थोड़ा थोड़ा तो होगा ही. That is, you make the patient understand that you see you have gone under surgery means pain is a part and parcel of the surgery. No, it's not like that. You can make the patient absolutely pain-free. Just for example, I give you that spinal anesthesia when you operate, the patient is absolutely pain-free. So same kind of conditions, by giving blocks and by giving appropriate analgesia, you can create in intensive care unit and in the wards, and you can make the patients stay journey in the hospital as if they have just come out for the whatever is wrong, but otherwise their life, their everyday was as good and as effective and as productive as it was before. Now you see, generally speaking, when we talk about how do you measure pain, visual analog score, that is the scoring system. But nowadays, what is being mentioned that you don't go by the scoring system, you go by functional activity score. That is, you ask patient whether he can, the operated part, whether the patient can move that operated part or not. You talk to the patient, ask him whether he can take deep breath or not, whether patient can cough or not. The patient has to be able to perform all these activities without having discomfort. If the patient can perform all these activities, that means your level of analgesia is good. So I just mentioned about it. So another important 2 points that is there, that is anxiety and depression. Like morning we talked about, you see, Takatsubo. See, many patients who are really very anxious and not willing at all, or they are really very, very fearful about the surgery, the pain, etc. It is the responsibility of the pain team to make them understand that, see, we are operating so many patients in this hospital every day, and everyone go back home. Everyone has they have safe and sound and comfortable journey. So for you also it would be as good as for others. You don't worry about. Try to reassure the patient, and that's the job of the pain team to make sure that. And so the involve patient, whatever the decision you take about the analgesia part, involve the patient. Some patients, they are, you see, very, anxious, and they fear more. Now, what kind of analgesia you can think of is, it depends on the patient characteristics, comorbidities, pre-existing analgesia use, drug interactions, and the surgery being undertaken. Now, what is the basic theme? That aggressive prevention of myocardial ischemia, that is the most important thing. And you have to go for tailored multimodal analgesia and guideline directed cardiac therapy. You see, sometimes if suppose say your analgesia is not working well, you may have to go for beta blockade, you may have to go for, you see, the calcium channel blockers, and if necessary, you see, if the patients are on statin or RAS blockade, etc., they have to be continued. Now, what are the drugs we use for multimodal analgesia? Paracetamol, one. NSAIDs, if they are acceptable. Now, the recent guidelines are saying that modest doses of NSAIDs can be used. Dexmed, yes. Ketamine, low doses. Lignocaine, low doses. Steroids. So these are the out of these 5 drugs, at least 2 or 3 should be there while you are managing the patient intraoperatively. Regional analgesia block, whether it is neuraxial or it is peripheral block, has to be an integral part of anesthetic management. You cannot, you see, if you do not know how to give block, like if you talk to me, I have not been practicing block, but if you talk to me, I am to give anesthesia, I must understand and learn and practice regional analgesia. You should not, because you see, if you are an old man, like I am now 70-year-old, if I am to give anesthesia to a patient, if I am to undergo anesthesia for any surgery, I will choose an anesthesiologist who can give proper blocks and plus general anesthesia. Without block, no anesthesia for elective surgery. Now opioids, we talk about opioid-free anesthesia, opioid-free analgesia. Maybe yes, maybe no. Because if necessary, the patient should not be denied opioids, if necessary. But if you can manage without opioids, yes, you can. And now a lot of non-pharmacological things are also coming in, like music therapy, like having earplugs, reducing the noise level in the ICU, etc. So that all those kind of things also should be practiced. Now just I will give 2 examples. Can I take 3 minutes more, 2 or 3 minutes? Can I take 2 minutes? Yeah, okay. So I will give just one example. A patient coming with a stable coronary artery disease, preserved LV function, and having intermediate risk abdominal or orthopedic surgery. The choice, it's a GA plus multimodal analgesia. Go for paracetamol, NSAIDs, low dose ketamine. Now ketamine low dose is just 1 to 2 milligram per kilogram per hour, not the anesthetic dose. It is just NMDA receptor antagonist dose only. Or you go for a low dose lignocaine, and as I have mentioned, nerve block, peripheral nerve block, or regional block, whatever is appropriate for the patient. Now another one is, suppose say you have a patient with severe LV dysfunction, ischemic cardiopathy, and going under for major lower limb surgery. A regional block is the primary method of anesthesia, no GA. It's a regional block, okay. You may go for spinal with opioids, or you may go for epidural with opioids. Avoid intubation related sympathetic surge and provide dense post-operative analgesia. These are important things. GA sometime in this kind of patients can actually by making very big change in the preload and afterload can cause very severe hypotension and jeopardize the myocardial health and create more problems. So these are the patients where the regional anesthesia, regional block, that is what can actually give a very good outcome for the team and for the patient and for the institute. Because you become something that, okay, yes, any kind of patient, difficult ones, bad ones, we are the ones, we can do it. So what I would suggest to that there is a need to develop pain team. It is different than the acute pain service. So with this, I stop here. Thank you very much. Thanks for your kind attention.
Thank you, sir. Thank you for your insights on perioperative pain management, and especially in cardiac patients. We'll now move on to our next case discussions. Our first presenter is Dr. P. Chaya Devi, Consultant Cardiac Anesthesiologist, Aster Ramesh Hospitals, Vijayawada.
Good afternoon, everyone. Today I am presenting about a patient who presented with chest pain and an incidentally detected renal mass. A 70-year-old man presented to the hospital with chest pain since 3 days. He is not a known hypertensive or diabetic. Patient had coronary angiogram done 3 days earlier, which revealed triple vessel disease and was advised CABG. This is the angiogram of the patient, showing right proximal RCA 50% stenosis and PDA 70% stenosis. So LAD shows mid LAD 90% stenosis, distal LAD 90% stenosis with diffuse disease. Distal circumflex shows 80 to 90% stenosis, and OM shows 80 to 90% stenosis. So this patient was admitted for further management. His clinical examination was normal, troponin was elevated, other blood tests were within normal limits, and HB was 12 grams per deciliter. 2D echo showed a mild LV systolic dysfunction with ejection fraction of 45% with RWMA in LAD territory. He was further investigated to be posted for CABG. Arterial Doppler, both lower limbs showed diffuse erythematous changes. Venous Doppler was negative for DVT. Carotid Doppler showed mild to moderate erythematous changes in bilateral carotid arteries. Ultrasound abdomen. Right kidney revealed an isoechoic lesion measuring 3.7 into 2.7 centimeters in the lower pole, which was predominantly exophytic. Left kidney was normal in size and outline. Serum creatinine and blood and CUE were normal. To further investigate the mass, CECT was done. CECT showed a lobulated, slightly dense lesion in the lower pole region of the right kidney, with enhancement in arterial phase and washout in venous phase, which confirmed a neoplastic lesion. There was no evidence of metastasis. This is the CECT of the patient. So this case involved a multidisciplinary decision making involving cardiologist, cardiothoracic surgeon, urologist, and anesthesiologist. This is a complex clinical scenario with dual pathology. So patient presents with chest pain and an incidentally detected renal mass. Both conditions individually warrant major surgery. This raises the question which condition should be treated first, and it highlights the challenge of prioritizing risk versus urgency in multi-system disease. So I would like to ask the panelists as to which condition should be treated first.
I cannot answer, madam, because I was the cardiac surgeon involved. But I will leave, let others speak first, then I will tell.
From the cardiac side, if patient is relatively stable, first we will consider looking at the renal mass.
But troponin was elevated.
Yeah, troponin was elevated, but at the same time, we can stabilize the patient. And if renal tumor is really worrying them, if we go for CABG first, we can't take the renal surgery immediately. So first we have to select which one to be taken first. If the kidney tumor is aggressive one, we will first go with renal surgery. If we have relatively bit comfortable time, cardiologist will go first.
So I'll present to you what we did. Because angiogram had revealed triple vessel disease and recommended CABG, we thought isolated nephrectomy was unsafe, and ejection fraction was 45%, increasing the perioperative cardiac risk. So we planned for a combined CABG and nephrectomy. The advantages of this is it avoids risks of future cardiac events during a separate nephrectomy, avoids delays in treating suspected renal carcinoma, provides single anesthesia exposure, shorter cumulative ICU stay, and reduced cost. There are risks, but literature supports combined surgery in selected patients with acceptable outcomes. So we went for a balanced anesthesia with midazolam, fentanyl, propofol, sevoflurane, and vecuronium with arterial line and CVP monitoring. We initially performed nephrectomy, then packed the nephrectomy site, went for CABG, and then closed the nephrectomy site in layers. 3 grafts were done. So post-operative care is very important in these patients. There is need for monitoring for MI, arrhythmias, renal dysfunction, and bleeding. The patient was extubated in 5 hours, and he was stable. And biopsy report revealed a clear cell renal cell carcinoma. So the patient had successful combined CABG and partial nephrectomy. With early detection and early surgery, patient had a good prognosis. The learning points from this case are: combined surgeries are feasible with proper selection and planning. Elevated troponin should never be ignored even without classic MI signs. Perioperative evaluation must consider both cardiac and non-cardiac risks simultaneously, and multidisciplinary planning ensures safe outcomes in high-risk patients. The take-home messages: elevated troponin plus CAD plus malignancy is a high-risk decision-making scenario. Combined CABG plus nephrectomy may be preferred to avoid dual high-risk surgeries. Perioperative optimization and meticulous monitoring are essential for safe outcomes. Clear communication between specialties improves survival and recovery. Individual plan is superior to rigid guideline-based approach in multi-pathology cases. Thank you.
This was a case where we thought, should we combine the clean surgery and clean contaminated surgery? And this was the level 1 of renal cell carcinoma, that is a clear cell. And we thought we'll combine both. What we have not informed in our case is we regularly monitor this patient with TE. We wanted to detect any new onset of RWMS so that we can intervene. But this case we successfully managed very well with the combined effort. There are very few case reports of combined renal cell carcinoma and CVG. This is one among them. Thank you.
Why not to go for coronary first and
then we have to wait for nephrectomies.
Yeah, correct.
So, but
the reason being that the idea of addressing coronary is you believe that see the disease is so much that the patient can have myocardial injury during the surgery, during nephrectomy or partial nephrectomy. So now see by doing partial nephrectomy, you are putting the patient at a risk of myocardial injury during the period when the kidney is being operated.
But we were continuously monitoring and the cardiac team was standby.
No, it's
the surgical team.
No, what I'm saying is if you monitor, if you check the troponin later on, you may find that there has been an increase. But if you do coronary first, fix coronaries, improve myocardial blood supply, and then you go for the kidney surgery. Or maybe you can have it in 2 different stages. Today you do the coronary, and later on you can do either open or laparoscopic partial nephrectomy. But in any case, if I am to give anesthesia for this patient, I would ask for that first go for coronary, and next it can be in the same setting also, but coronary first, followed by the kidney.
Yes, sir. As you mentioned, it's an isolated lower polar tumor. So only partial nephrectomy was the only idea. If it was an extended lesion with an IVC thrombus, you would have required an radical nephrectomy, which will take much more time, much more intervention. We have to dissect the IVC, open it, causing problems for the cardiac team also. The other issue which we faced was the issue of position for surgery. Usually conventional partial nephrectomy we do through a line approach where the patient should be lateral. But actually we can do an extended sternotomy with a subcostal extension where we can keep both sides open and the cardiac team can intervene immediately if you find anything abnormal happening. That was another modification which we thought we could do. But because it was an isolated lower polar lesion, we thought we could manage it much faster and we could finish hardly around 1.5 hours of procedure for the partial nephrectomy. And we kept the wound open to look for any bleeding post-operative because they give heparin and then they can be bleeding at the site of partial nephrectomy. So these were the precautions which we took. Once they finished their procedure, then we could close the wound also.
So regarding this level 3 and level 4, we have good experience personally combined CVG and renal cell carcinomas when we have effectively maintained. And in this case, the flow was not that limited and we were confident from cardiac surgical team that it can be managed smoothly. and that is the reason we went ahead. And I am more worried about post-operative. In first 3 months, if you stop ecosprin clopiols, I am really worried for the grafts blockage and all. And as I said, there is no floor limiting factor. We can conduct both the surgery simultaneously, even though it is level 1 or level 2 kind of a renal cell carcinoma. Yeah.
Definitely.
Hello. Suppose in some patients we come across thrombosis also with the renal vessels. So IVC thrombosis we can anticipate. So if that is there, what would be the scenario, sir? We'll go ahead with both surgeries simultaneously or stepwise?
You mean tumor thrombus, sir?
Yeah, tumor thrombus.
Can be dealt with in the same sitting, sir, because only we have to extend the renal vein into the IVC to extract the entire thrombus, and that itself is curative for the patient. So it can be combined with CABG with an extended sternotomy so that both areas are exposed together. We have a cardiac team always when we are doing an IVC thrombus also. So the same way when they are doing a CABG simultaneously, it can be done together.
Can be the advantage of taking nephrectomy first is the coagulation issues can be postponed for 2 hours, and this can be done in, this is done in the left lateral or right lateral, sir? This is in the lateral position. After doing this CABG and taking up the nephrectomy, they are having this chest drain tubes, they are coming in. So this is positionally also it is difficult by taking up the cardiac case next. So this is an advantage, taking up the organ on nephrectomy first and cardiac next, because heparin, that's why coagulation issues will be there.
Again, and open the abdomen, look for bleeding.
Yes.
Abdomen closed, then we did CABG.
Yes. Then any other surgery which was done along with the CABG, any other organ, any other surgery?
Sir, in my experience, we have done cholecystectomy with CABG. There was intestinal obstruction with CABGs, intestinal perforation with CABGs, simultaneously right from where I studied in our own institute, AIMS as well as PGI. We had a good experience. And in this case, we are confident that the simultaneous can be done.
In all those cases, CABG is the last one.
All intestinal surgical abdomen given first preference. Yes. We went ahead with the surgical abdomen, even retroperitoneal tumor, and then we did simultaneous CABG or a valve replacement in fact also. Yes.
Okay, thank you.
Yes, sir. See, the idea is you open the abdomen, finish up the job, pack it, close the abdomen, again paint the patient, position it, paint and drape again separately. All instruments are changed, all the staffs are changed, do CABG, do valve replacement, then again paint, completely cover the sternum, open it, look for any bleeding, remove the packs, wash with any solution, then close it. This is how we are practicing.
No, what you said that we were doing if the patient is coming with say carotid artery stenosis and coronary. So what we would do is coronary first, keep the chest open, go for the carotid, repair the carotid, come back, close the chest, and then close the neck wound. But you make the patient's heart to sustain any kind of stress. The idea is to, that is the idea to put the coronary first.
Sir, in carotid, I'll share my few experience. When the sternum is open, carotid also open, we place the cannula in the aorta and it is connected to distal carotid, both are connected. We are establishing directly aorta distal carotid perfusion, do carotid endarterectomy and remove the cannula and do CABG simultaneously, sir. So this has given an added advantage of without using intracarotid shunts. So these are the cases where when we are doing off pump, we are doing like this also, sir.
No, both are off pump only.
Yes, sir.
Coronary as well as you don't need pump for that nowadays.
Nowadays the guidelines also have changed. So CABG is preferred first. Then unless it is symptomatic carotid artery disease, where handling is a big issue there, sir. Thank you.
Thank you, ma'am.
Thank you.
The next presenter, Dr. Himabindu K, Consultant Cardiac Anesthesiologist, Aster Ramesh Hospitals, Vijayawada.
Good afternoon, everyone. Now I like to present cholecystitis with triple vessel disease. Who goes first? Next. 60-year-old male patient, diabetic since 20 years, presenting with a complaint of right hypochondrial pain, and tenderness was also noted in the right hypochondrium. Ultrasound abdomen suggested acute calculus cholecystitis with Corey perforation, bilateral mild pleural effusion, and grade 2 fatty liver. Subsequently, patient developed shortness of breath. TROP-T was positive. ECG, no ST elevations were noted. Angiogram was done, and left main plus triple vessel disease was noted. Echo showed EF of 50% and grade 2 diastolic dysfunction, and ectopics were noted during the study. So these are the angio lesions, like left main 80%, LAD 90, diagonal is 90, LCX is non-dominant, and RCA is also 90. So this heparin was started after angio, 5000 units, IV 6 hourly, and CRP is 200, and serum creatinine is 1.1. Mild leukocytosis was noted, and the case was discussed with the cardiologist, cardiothoracic surgeon, and general surgeon. And now let us see who goes first. Open for panel. General surgeon or cardiologist?
I think again it's same like the previous one. From cardiologist point of view, troponin positive, but patient also has active infection of cholecystitis. First, of course, if it is a perforation, then I think we will not wait. So it would be simultaneous only, again similar to the last case, but probably again, as he has already said previously, we will open the abdomen and treat it first and then CABG.
Yeah, but what we did, I'll like to present. Because of high suspicion of perforated gallbladder and high inflammatory markers and risk of sepsis progression, high perioperative cardiac risk was explained, and CT surgical team was kept on standby. Heparin was stopped, NPO status confirmed, and high risk consent obtained. And next, coming to all emergency drugs were kept ready in OT, cannulated, radial artery cannulated for continuous BP monitoring, IJV cannulated for CVP monitoring, good premedication induced with fentanyl and etomidate, and maintained with O2 sevoflurane and vecuronium. Hemodynamics was stable throughout the procedure, and surgery was uneventful. So patient was extubated on table, shifted to cardiac ICU after open cholecystectomy. And post-op pain was with tramadol and paracetamol. Antiplatelets were started on post-op day 1, soft diet on post-op day 3, drains removed on post-op day 5, and discharged with ivabradine, metoprolol, clopivas. And after 3 weeks, CABG was performed. Anyone can? Okay. So next, one more case I like to present. This is a case 2, like patient 69-year-old female with diabetes mellitus since 25 years and hypertension since 25 years and thyroid hypothyroid since 5 years and CVA history 6 years ago, came with the complaint of right hypochondrium and epigastrium since 6 months, aggravated with food intake radiating to back, and is not relieved with proton pump inhibitors. Ultrasound suggested chronic calculus cholecystitis and 8.5 mm in the fundus and 4 mm in the body, focal wall thickening at the fundus, and patient was scheduled for laparoscopic cholecystectomy for general anesthesia, and the patient was referred for cardiac evaluation prior to the surgery. And echocardiograph revealed ejection fraction of 45%. Regional wall motion abnormality was noted in LAD territory, paradoxical septal motion, trivial AR, mild MR, and mild TR, and mild PH was observed. As angio revealed triple vessel disease, we posted this case for CABG considering reduced EF, regional wall motion abnormalities, and after discharge we are planning for interval cholecystectomy. Key learning points were: elderly diabetics can present with abdominal symptoms instead of chest pain. CRP 200 plus suspected gallbladder perforation implies severe systemic inflammation. Early cardiology and CT surgical involvement improves the outcome. And stop heparin before surgery and restarts antiplatelets as early as possible. Etomidate for hemodynamic stability and invasive monitoring. Avoid tachycardia and hypotension. TROP positive case have high morbidity despite no ST elevations. Once the abdominal source is controlled, definitive CABG is to be done. Thank you.
Yeah, ongoing ischemia, if 2-3 more millimeters ST depressions with this left main, the previous case you were talking.
First case, no ST changes.
No,
sir.
supposing there is, how do you manage? How do you protect the heart during your cholecystectomy? No.
Sir, if there is a sure shot type 1 MI where it is ACS related, it is a different scenario. Here is a non-ACS related, and I would like to, as a surgeon, I would like to stop laparoscopic procedure and consider if there is an ongoing, it is reversible, I'll consider open cholecystectomy rather than lap cholecystectomy. That is the first choice. We should know when to stop any surgery when there is ongoing ST changes. Okay, that is very important in this case.
Yeah, sometimes protection with IABP, NTG, controlling the heart rate with esmolol, something where you reduce the metabolism and improve the diastolic perfusion to buy time, may sometimes, yeah.
Like there is a supply-demand mismatch when there is a hypotension which has happened because of poor analgesia, poor anesthetic effect. If the patient has a predisposed already triple vessel disease, when there is hypotension happens because of RV dysfunction per se, if you don't give volume, there will be LV problems and the coronary ischemia and also. It has to be corrected, depth of anesthesia and all the factors to be considered.
Yeah, closed loop medication to protect the heart, both heart rate and NTG, something like that. That's what in future.
If your surgeon and the anesthetist both understand the cardiac physiology, probably yes, you can manage the show. But if your anesthetist is not very well versed with cardiac issues, I would still say that fix cardiac. Because see, the anesthetist has to understand demand supply mismatch. That is the most important thing known to cause the perioperative myocardial injury. And if it happens, see, the surgery would be done within 2 hours time, but if it happens, it has got a lasting effect up to 1 year. You may discharge the patient 7 days later. The patient may have mortality after a month or may have mortality after a year. So the myocardial injury that must be prevented. And that is what was the key point when I talked about the perioperative analgesia. That your analgesia has to be really very, very good. Otherwise, if you just give general anesthesia, you don't give block. I would say, if suppose your patient, you are going for say abdominal surgery first, still you go for GA plus epidural, have a very good analgesia, or GA plus facial plane block. Block must be there. That is important.
Thank you.
Thank you, ma'am. Next presenter, Dr. Pavan Kumar, Consultant Cardiac Anesthesiologist, Aster Ramesh Hospitals, Vijayawada.
Good afternoon, everyone. We came a long way in the heart and over CME. Most of my topics are already covered, so I'll be going through briefly through my slides. I'm talking about ongoing MI for a non-cardiac surgery, which is heart surgery. A 85-year-old male with a known case of hypertension on medical management had a history of fall 4 days ago at home. He went to local hospital in West Godavari district, and they have taken an ECG which showed an evolved anterior MI. They have tested TROP positive, and they have given loading dose of dual antiplatelets. Hence, he was referred to Ramesh Hospital for further management. it was diagnosed as IT fracture posted for DHS. So investigations, hemoglobin was 9.6, WBC count was 15,600, and echo showed EF35 with regional motion abnormality in the LAD territory. There was LV apical aneurysm and grade 4 diastolic dysfunction. So this is the ECG. Then the cardiologist advised CTCA. The calcium score was 450, and there was 80 to 90% LAD stenosis. And surprisingly, there was this study showed positive for pulmonary thromboembolism. So here in this case, my goals would be I don't want to have any precipitous drop in SVR. I want to maintain coronary perfusion pressure, which is diastolic blood pressure. The targets would be the heart rate somewhere around 60, mean arterial pressure somewhere around 70, 75, and diastolic blood pressure more than 60. So I'll keep the blood products ready, avoid tachycardia, and avoid any fluctuations in blood pressure. Because of pulmonary thromboembolism, I would avoid hypoxia, hypercarbia, and I just want to prevent the RV strain. So this is how we went with this case. We have put an arterial line, we have put a central line, and we kept all the inotropes and vasodilators ready. Because the patient was given loading dose of clopidogrel only 2 days ago, so we have gone for the GA, routine GA, midazolam, fentanyl, thiopentone, sleeping dose of thiopentone, ecuronium, and then extubated with neostic wind. And it was on-table extubation, and post-operative we have managed with multimodal analgesia. So on discharge, the patient was given Clexane for 3 days, later shifted to rivaroxaban and clopidogrel. The main discussion in this case would be because the ECG showed evolved MI and echo showed LV apical aneurysm. Are we justified in doing a CTCA, or we could have gone with CAG, or we could have gone with echo and ECG in hand, we can go with the surgery. So why we have opted for CTCA? Because anyway the patient is 85-year-old, and the chance of having a CAD is very high. So already there is evolved MI with the LV apical aneurysm. So because of there is already a non-viable myocardium. Only thing to rule out LMCA disease, we can go for CTCA. In this case, we have done CTCA. What does the guidelines say? Guidelines, according to 2024 ACC-HA guidelines, it states that if the patient is having acute chest pain with no history of CAD, maybe you can do CTCA. And if the patient had CTCA 2 years ago, with a calcium score of 0, then if the patient is coming now, we can just go for surgery without CTCA. And emergency surgery, any emergency surgery, there is no point of going for any CT. And before taking any patient for CTCA, you just see the meds of the patient. If the meds are less than 4, and if the DASI score is less than 34, or if the functional status of the patient, if you can't assess the functional status of the patient, or there is indeterminate type of functional status, then definitely if you suspect a high risk coronary anatomy, then definitely you have to go for a CTCA. It is said that if there is SVD, the MACE cardiac events are thrice without any vessel disease, and if there is TVD, the MACE is 8 times more. What does the guidelines say about angiogram? Angiogram is strictly restricted for the highest risk patients. The routine indication for angiograms also apply in the perioperative period, like ACS or accelerated angina, despite having maximal anti-anginal therapy or any LMCA disease. And regarding troponins in the perioperative period, this is a slide showing where the troponins can be increased in the perioperative period. Preoperatively, there might be increase in troponins in the case of heart failure, cardiomyopathies, or any chronic kidney disease or pre-existing pulmonary embolism. Intraoperative period, because of stress and massive hemorrhage, there might be increase in the troponins, and in the postoperative period, sepsis and again AKI pulmonary embolism can increase the troponin levels in a patient. This is the chart showing the mortality rate with the troponin levels. If the troponin levels are more than 1000, the mortality rate is more than 30%. So here also the TOP-T was positive, but whether it is because of pulmonary embolism or it is because of MI, it is morely clearly shows that there are ECG changes, there is LV apical aneurysm, and the RV is not dilated, the PA pressures are not increased. So we suspect that this troponin increase only is because of myocardial infarction rather than a pulmonary thromboembolism. So again comes the question whether to do cardiac intervention or to do a non-cardiac intervention first. So in this case, if you do a cardiac intervention either with a PCA or a CABG, it restricts the stoppage of dual antiplatelets. And long bone fractures, if not treated early, delays the quality of life. So non-cardiac intervention is followed by cardiac intervention. And many studies say that even if you do cardiac intervention first, the results are not, there is no much difference in the results. And risk classification, it is widely explained in the morning. If the METs are less than 4, there is a indicates high perioperative cardiac risk. If the EF is 35, the mortality risk increases more than thrice. Troponin trend, nowadays they say that if you measure the troponins and NT-proBNP levels preoperatively, if you add to the RCRA score, the validation is more with adding troponin levels with it. And there are many scores considering the MI risk assessment like TIMI score, Gray score. This is the TIMI score and this is the RCRA score. But no score will clearly tells us the exact risk of the patient going for a non-cardiac surgery. So post-operative monitoring, serial ECGs and troponins will be seen, strict heart rate and blood pressure control, optimized analgesia, and restarting aspirin and clopidogrel as soon as the surgical bleeding is controlled. And coming to pulmonary embolism with non-cardiac surgery, concerns are in any long bone surgery, the DVT, the incidence of DVT is 1 to 2%, and the pulmonary embolism will be like from range from 2 to 22%. So here we would maintain normovolemia, we would avoid the overdose of drugs during induction because there is slow circulation time, avoid increase in ventricular afterload, avoid sudden hypotension in regional anesthesia, and avoid increase in PVR with avoiding hypoxia, hypercarbia, hypothermia, acidosis, and using nitrous oxide in the intraoperative period. This is the pulmonary embolism which can happen in the perioperative period. The first one shows the risk assessment of the patients going for surgery. This is a Caprini risk assessment score. There are other scores like PODA score, which tells whether the patient is patient is will be getting any pulmonary thromboembolism or not. Once risk is seen, then we will see whether the patient is hemodynamically stable or not. If the patient is not hemodynamically stable, then definitely you have to go for pulmonary thromboembolism treatment as such. So post-op management, always anticoagulant started as soon as bleeding risk is minimized. Start low molecular weight heparin and start DOACs 24 hours after surgery. Always there are new ASRA guidelines 2025. It can be easily seen. We just want to see whether when to stop the anticoagulation and when to start. They are clearly given in the guidelines. And post-operative period, this patient had hemoglobin of 6.8. So there are guidelines. There are two strategies: the restrictive strategy and the liberal strategy. But in the MINT study, it was clearly shown that there is no big difference in the restrictive or liberal strategy. But since the The number of complication rates are little lesser in liberal strategy. We usually go for a liberal transfer strategy. And here the trichomesis are risk stratification is very important and multidisciplinary approach. And you should individualize the management according to the patient. And as already said, means myocardial infarction after non-cardiac surgery, knowledge about perioperative troponins is very important. Thank you.
Sir, one question. In cholecystitis patient, previous case, there is any role of percutaneous drainage, then you can give antibiotics, go for later surgery with cholecystectomy.
In cholecystitis, like I presume it is the severe cholecystitis, either gangrenous cholecystitis,
yes,
or a perforation, or a inflammatory, or a sepsis. Okay. Now these four condition comes and there is simultaneous cardiac surgery has to be done. Now in all such cases, preferred is percutaneous cholecystostomy, and manage the sepsis, manage the inflammation part. Okay. Meanwhile, observe the patient next 2-3 days or 4 days of post-operative period. If any setting of development of cardiac event, if requires immediate intervention, which can be managed with stenting, go for a stenting, then bail out cardiac surgery, interval CVG later on. Then after 3 to 4 weeks, when the patient is stabilized or with or without any intervention of coronary, then interval cholecystectomy has to be done. However, when the patient has undergone CVG, now we have consider him as just acute cholecystitis, which is a mild in nature. He underwent CVG. Now post-operatively he developed changes of a gangrenous cholecystitis. Here the question is, we have put him on heparin and all. Okay. So we have to stop heparin. We don't give antiplatelets in such patients when we are anticipating, and percutaneous cholecystostomy has been done. If a center doesn't have, at least with a very minimal invasive, do a surgical cholecystostomy with a T-tube drainage and all. Sir is much aware, so Sonakanda sir, and bail out the situation. All these combination you have seen, it has a clear-cut role, PC cholecystostomy.
Thank you, sir. I thank all the panelists for chairing the session. We move to the next session. I invite the chairpersons onto the dais for the next session. Dr. Durga Prasad, sir. Dr. Ramarao L., Consultant Cardiologist, Aster Ramesh Hospitals. Dr. Somnath, sir, Consultant Cardiologist, Aster Ramesh Hospitals. Dr. Chaya Devi P., Consultant Cardiac Anesthesiologist, Aster Ramesh Hospitals. Dr. Krishna Mohan G., Consultant Cardiologist, Aster Ramesh Hospitals. Dr. Fani Rajkumar, sir, Consultant Surgical Oncologist, Aster Ramesh Hospitals. The first speaker, Dr. Chigurupati Kirti, Senior Consultant Cardiac Anesthesiologist, Dr. Vaivira Hospitals, Vijayawada. A distinguished cardiovascular and thoracic anesthesiologist with advanced training from Sri Chitra Institute of Medical Sciences and Technology, Trivandrum. Ma'am is a double university gold medalist and international speaker with American Society of Regional Anesthesia and has multiple high-impact publications, several of which are cited in Miller's Textbook of Anesthesia. She also had international clinical exposure at Mayo Clinic and Cleveland Clinic and was recently honored with Hall of Fame Award by Ganga Hospitals. We welcome you, ma'am.
Thank you so much. Good evening, everybody. I'm very delighted to be here, and thank you so much for this opportunity. My topic today is perioperative myocardial injury, also called as MINS or PMI, that is myocardial injury in non-cardiac surgery. I know that you all had bombarding sessions from morning and you have many to go, so let's make this, this topic a little fun. So in day-to-day life, when you hear about injury, what is that reminds us? Our kids. Kids are the ones who are like, they're prone to injuries, they fall, they get up. So let me answer certain questions from this picture so that we understand the topic in a lighter way. So what are the chances that these people, any of them can have injury? It is 100%, right? Any kid can fall down during playing. So it is 100% that these kids can have injury. So what is the nature of injury? So in the animations I have made, you can see there are two kids, this one, here, this one, who are actually falling down, but then getting up and then, moving forward with the game. So they haven't cried, there is no bleed. So there is obviously no sprain or fracture because they're continuing to play. So you understand that there are no symptoms or signs of injury. But because you're seeing them fall down, you know that injury has happened. So that is what is peri-op myocardial injury. Next, are there any precipitating factors? Yes, they can be child related because impulsive kids who are naughty, they don't listen to you, who are they take risks, they have higher chances. And kids who have already fallen down, got up, had fractures before, they have more chances of injury, right? So there are the child related factors. They are the game related factors. Like if somebody is just walking slowly, the chances that they fall down are less. Having injury is less. If somebody is doing somersault like this in the thing, there is very high chances that they can have injuries. Next, environment related factors. Like because the kids here are playing in a lawn, there are less chances that even if they fall down, they don't hurt themselves. But if they're doing it on a road, on a rough surface, on a rocky surface, there are very high chances that they will have injuries. This is exactly what happens in peri-op, when you're talking about a patient. So what are the precipitating factors for the patient? It can be patient related, it can be surgery related, it can be anesthesia related. Okay, next, how do you diagnose it? As I told, because there was no bleeding, there was no sprain, there was no fracture, the patient did not cry, there can be only certain markers which can tell you that the injury has happened. Will there be any long-term effects? Yes. Yes or no? Because we know some of our injuries are very kind. They do not leave any scars on us. We just get on very well. But some of the injuries are very bad. Once we have them, they just remain with us. When you do the same activity, it can come back in the same way or in a severe form. Or that part, when you hit again, you have a higher propensity to have a fracture. So the long-term effects vary with each injury. That is what we are going to deal. So let us convert all this into a perioperative setting. Before we go into the topic, I would like to, brush something in our physiology that we have read many years before. The structure of a cardiac myocyte, we know it is a striated muscle which has myofibrils. In them are the myofilaments which form sarcomeres. These sarcomeres, they have the thick chains and the thin filaments, the myosin and the actin. Myosin is almost a 470,000 Dalton molecular weight molecule, which has two heads, one to bind to the actin molecule to produce the action required. This is the troponin, which has the actin. It is a 7-unit, like a spirally bound structure, bound around tropomyosin. And then comes our heroes of today's session, the troponins. So troponin I, troponin C, and troponin T. Troponin C binds with calcium. Till the troponin C binds with calcium, troponin I is the one which is hiding the myosin from the actin so that it does not undergo any contraction. And troponin T is the one which is binding to the tropomyosin. So because as we go, we are only going to talk about troponin as a marker of perioperative cardiac injury. That is the reason we need to know what the structure looks like. So this is how it is. This is a light chain. This is the, the thicker, thick filament, myosin and actin. Once the calcium comes bind to the troponin C, the troponin I goes little away, the myosin head is disconnected from the actin, and so the myosin head is now free to bind with the actin filament and cause the movement. That is how the contraction occurs in the heart. So with this background, let us start with what is the definition of a myocardial injury. So there are multiple definitions. Just for the theoretical sake, let us see 3 or 4 very important ones. The MIN Society Vision Group in 2017 have given definition is Myocardial injury is just to result from ischemia, obviously, right? And that has to be within 3 days of the surgery, with the high sensitivity troponin T more than 20 nanograms per deciliter. So this particular group has given a certain, the concentration of troponin that is very important to diagnose a perioperative myocardial injury. But they said you don't need to demonstrate myocardial ischemia. How can you demonstrate myocardial ischemia? It can be either by a symptom or a sign. Either patient should complain of a chest pain, ECG should show a change, echo should show a regional wash motion abnormality, and if any of these is positive, angiography should show a block. But you don't need to demonstrate any of this because it is just an injury, it is not ischemia or infarction. So, and the most important thing is, because we are talking about ischemia, any non-ischemic causes of myocardial injury should be ruled out, because if the patient is in AF, patient has a pulmonary embolism, or patient has, as I said, tachycardia because of any other reason, it is very high chance that his troponins may be elevated. In that case, they say you do not call it as a myocardial injury. So AHA in 2021, what they said is they did not give any specific number for the troponins. They said it should be more than 99 percentile. So the acute change, they said, was within 30 days, but most importantly within 72 hours after the surgery, as commonly said, because of the ischemic changes that happen in the heart, and you have to rule out the non-ischemic changes. As I said, the non-ischemic and the signs of ischemia should not be present in these patients. The fourth universal definition of myocardial infarction, they define myocardial injury as increased cardiac troponin more than 99 percentile, considered acute if, then you might ask me, if the patient has elevated troponins before surgery, then how do I know it? So in high-risk patients, if you have done troponins before the surgery, change of 20% of the value will tell you if it is acute and because of the perioperative period. And but in these cases, they have not given any timeline for the increase. The basal PMI, they have defined it as an absolute increase in high sensitivity troponin more than 14 above the baseline within 7 days after the surgery, and they have not said you don't need to differentiate ischemia or non-ischemia. Just any time if the troponins are high within 7 days after the surgery, consider it as perioperative myocardial ischemia. And the same thing, even the STEP compact, they have the similar definition that goes in defining it. So what is the incidence? The incidence is around 8% in the patients who are more than 45 years undergoing non-cardiac surgeries. And a recent systemic review and meta-analysis done by MINS, for them the incidence was around 17.9% in around 5,30,000 surgeries that were done. But as an average, you can take it between 8 to 10%. So, and the incidence also changes with what troponin are you measuring. If you are measuring a high sensitivity troponin, then obviously your incidence will be high. And if you are not measuring the high sensitivity troponin, the incidence will be low. And they said if you are measuring a troponin I, the incidence was 20%. With troponin T, it was 17.4%. So what are the risk factors? These are all the common risk factors we have for every surgeries. Older patients, male who are hypertensive with a history of coronary artery disease, prior myocardial infarction, heart failure, patients with kidney problems, emergency surgeries, they are all high risk. And usually they said general surgeries carried a higher risk than orthopedic surgeries, maybe because they were mostly done under blocks or regional anesthesia. So then let us little understand about the release of cardiac troponins. As we said, in the sarcomere structure, you have many troponins that are attached to the light chains which cause the contraction. But what we have to remember is there are a lot of free form troponins that are present in the cytoplasm that are responsible for the initial release of the troponins after an injury. So let us just look into what happens when there is a little myocardial injury. If this is a structure of cardiac cell, what happens whenever there is a myocardial injury, initially there might be an increased proteolysis that can occur inside the cell. There can be formation of the blebbing, that is the vacuoles that form. These non-bound troponins can be carried through these membranes because of the increased permeability, and they can enter into the bloodstream and can cause increased troponin values. Or there can be a classical secretory pathway in which the troponins that are attached to the endoplasmic reticulum are transported to the Golgi apparatus, and from there they are released into the bloodstream. So these things happen in the initial phases of injury when the cell is still non-necrotic. But once the cell becomes necrotic, what happens is the troponins that are attached to the sarcomeres, they get detached from them, and these are the ones which are entering into your bloodstream. So initial phase of injury is just the free troponins that enter the bloodstream, and the later phase when the necrosis of the cell starts, it is always the bound troponins that are released into the bloodstream. But whatever it is, even if it is a non-necrotic pathway in which the smaller troponins are released, or the necrotic pathway in which large covalent complexes are released, our blood investigation cannot differentiate whether it is the shorter one or the complex one. It just gives you if it detects the troponins in the bloodstream. So any one of it will give you as a myocardial injury. So how do you differentiate it from the myocardial infarction? So in myocardial infarction, simple, because every one of us knows it, it is myocardial injury which goes beyond injury, because all myocardial infarctions have an injury, but all myocardial injuries don't lead to infarction. In the same way, like all injuries, all fractures would have had a history of injury, but all injuries don't lead to fracture. So along with it, they will have symptoms of myocardial ischemia. They'll show ECG changes. They may have pathological Q waves. They might show regional wall motion abnormalities during the echo. Or if further investigated, they can have a thrombus in the angiography or the investigations done. So as I already said, all myocardial injuries did not lead to myocardial infarction, but all myocardial infarctions will have a history of myocardial injury. So then what are the types of myocardial ischemias? As we all know, myocardial infarction has majorly two processes, that is type 1 or type 2 myocardial infarctions. Type 1 is because of the disruption of the atheroma, which can block the vessels and cause ischemia. Type 2 is a demand-supply mismatch. It can be either because of a fixed stenosis that is present at that particular place, which is not able to increase the blood flow that is required because of the increased demand, or the increased demand supply mismatch, that is if you have a severe tachycardia where you're not able to pump enough blood during that point. So for us, during the perioperative period, studies have shown that normally what we see in our cardiology wards is type 1 MI mostly, but in the perioperative period it is usually the type 2 MI where there is a mismatch between the supply and the demand. So it can be because of hypotension, hypoxia, tachycardia, anemia, many factors which can precipitate it. So for us, during the perioperative period, what is more important is the type 2 injury. Then one question might be asked. Yeah, you're saying, anemia can precipitate injury, tachycardia can precipitate, hypoxia can precipitate, then what is happening? Okay, this is just one slide which is showing that usually most of the perioperative MIs are because of the type 2 MI. Okay, then let's discuss what we were discussing previously, the type 2 MI. As I was saying, the most common question that arises is what is happening to the auto-regulation that normally happens in everybody, which is because normally when we have tachycardia, everybody is not having myocardial ischemia. Then what is happening to that auto-regulation during the perioperative period? It is getting disrupted because of multiple factors that are happening during the perioperative period. It can be because of the systemic inflammation where there is an increase in the neutrophil lymphocyte ratio, the surgical stress itself, the hypermetabolism, the pro-inflammation via the sympathetic system, and these all causes a disruption in the cardioprotective mechanism, which cause a hemodynamic strain because of an increased preload and increased afterload also. And also there is always a segment of autonomic dysfunction that happens in the heart, which all of them together will lead to a cardiomyocyte damage. So outcomes, maybe I'll finish in 2 minutes. The outcomes, as we know, because obviously in a patient with myocardial injury will have a poorer outcome than the patient without a myocardial injury. So in hospital mortality was 8% compared to 0.4% without an injury. 30-day mortality 8.5% in comparison to 1.2%. 1 year mortality was 20.6% in comparison to 5.1%. The long-term follow-up is usually not there in many of the studies, but data pulled from some of the studies showed that even the long-term mortality was high in patients who had a myocardial injury. So the basal PMI study also showed the same thing, that patients with perioperative myocardial injury had a higher mortality than the patients without a myocardial injury. And all the other things like acute heart failure, tachyarrhythmias, extra cardiac cases, type 1 MI, type 2 MI, they also increase the events in the patients who had myocardial injury. How do you prevent it? Simple, because we have to just maintain an environment that is ideal during the surgeries. Avoid hypotension, avoid tachycardia, avoid anemia, avoid hypoxia when and how much ever it is possible. So these are the things. Some of the studies have been done asking if continuation of aspirin will help, if beta blockers continuation will help, if statins will help. But till now, because it is a very new topic that is still under study, there is no consensus that has come up which will say that any of these drugs continuation might help or harm the patient. So I cannot tell you that these particular agents have to be continued in the preoperative period to have better outcomes. How do you manage it? As I said, this is a upcoming topic. There are very few studies who have concentrated on the management. There is one study called MANAGE, which is management of myocardial injury after non-cardiac surgery in 1,700 patients. What they have done is they have used dabigatran because it's an oral anticoagulant. They have given a dose of 110 milligrams BD for 35 days in patients in whom myocardial injury was diagnosed. What they found out was these patients were followed up for 2 years, and the major cardiac events, complications, were much lower in this group. What are the major cardiac vascular complications? Vascular mortality, MI, non-hemorrhagic stroke, peripheral artery thrombosis, amputation, or venous thromboembolism. Then you can ask me, were the side effects of bleeding increased in this group? As much as they observed, they did not. But what was the flaw in this structure, in this study is, in the selection bias itself. In the patients who were assumed to have an increased bleeding, they were eliminated from the study. So we cannot generalize these findings to the general population. So that is the problem with this study. So that is the reason I cannot tell this is the one you can follow also, but there are many studies that are coming up. So what are the current guidelines? The European Society of Anesthesiology Intensive Care, they say you have to do cardiac troponins before and after surgery for high risk. Why guidelines? Because after this talk you can ask me, we don't do regularly troponins for every non-cardiac surgery. But for high risk, you might consider doing it. The Canadian Cardiovascular Society, they say that in high-risk patients with raised pro-BNPs, it is important to measure troponins for 3 days post-surgery. And the AHA guideline says post-operative measurements can help the patient in the first 2 to 3 days after surgery. So what do we conclude regarding this topic is, obviously, like the universal precautions, preoperative optimization of the cases is very important. Identify the high-risk patients, follow a balanced anesthesia and analgesia. You should have a high degree of suspicion if you want to, suspect a patient with myocardial injury. And investigate only when required, because maybe our resources will not allow us to do troponins for all the non-cardiac cases serially. Studies are yet to come, so maybe in the future meets when we meet, maybe we'll have better studies which will give us better guidelines on this topic. Thank you so much.
Thank you, ma'am. Ma'am, we request you to stay back on the stage and to join the panelists to chair the rest of the session. The next speaker, Dr. Ramakrishna SVK sir, a senior interventional cardiologist and cardiac electrophysiologist with over 18 years of experience. He is currently Clinical Director of Cardiac Electrophysiology and Academic Director of EP Fellowship Program at Care Hospitals, Banjara Hills. Sir is internationally certified by the Heart Rhythm Society, USA, and is a Fellow of American College of Cardiology, European Society of Cardiology, and the Society of Cardiovascular Angiography and Interventions. His expertise includes complex electrophysiology, ablation procedures, advanced pacing, and structural and coronary interventions. We welcome you, sir.
Before that, Dr. Kirti, you have done excellent job, Amma. So, anyhow, we'll have some share of thoughts after this. Right, okay.
Thank you so much. At the outset, let me thank Dr. Ramesh sir and the entire team from Aster Ramesh Hospital to have me here in this CME. Let me acknowledge first that this is the first time, sir, I am seeing a CME on this kind of a topic. I mean, it goes to Dr. Ramesh sir only, the credit goes to him. So my topic is rather extensive, perioperative arrhythmias in non-cardiac surgery. Practically, many patients can have arrhythmias in the perioperative period. So various studies depending on how we monitor these patients and how they are reported. They have reported from around 16 to almost 61% patients undergoing non-cardiac surgery, they can develop arrhythmias in the perioperative period. If you take patients undergoing cardiac surgery alone, that's obviously it will be much higher, probably more than 90%. The heart is a very sensitive organ. There are many things like hypovolemia, hypoxemia, electrolyte imbalances, all these things can affect the heart. So obviously add to that in the perioperative period, you have a sympathetic overdrive, autonomic dysfunction, all these things, obviously arrhythmias are going to be much more common. It's better to have a checklist like this when you have arrhythmias on table. We don't need to go into all these things, but it is essential to understand that there are several treatable conditions in the perioperative period when you have a patient with a cardiac arrhythmias. So obviously there are several patient-related factors, a recurring theme today that you have repeatedly listened to, anesthesia-related factors and surgery-related factors. The single most important patient-related factor is patient having a pre-existing cardiac disease. Patients who have coronary artery disease or valvular heart disease, cardiomyopathies, and especially patients who have implanted electronic devices. Some patients with neurological conditions can have arrhythmias. Patients with old age, post-operative atrial fibrillation is a very common complication in these patients. We have gone through this anesthesia-related factors many time and again. Patients can develop arrhythmias during any phase of anesthesia, starting from the induction, intubation, and all those things. Most of the anesthetic drugs are safe, but there are some anesthetic drugs which can cause arrhythmias in these periods. Even patients who undergo local anesthesia also can develop arrhythmias. Even a simple procedure like a central venous cannulation because of stimulation of the carotid sinus reflexes can cause bradyarrhythmias in these patients. Of course, patients who are undergoing cardiac surgery, they are at a very high risk, but there are certain non-cardiac surgeries also, like abdominal surgeries, especially laparoscopic surgeries, they can have arrhythmias in the perioperative period. So today, we can differentiate these patients into two groups, patients who have an implanted devices, patients without implantable devices. I will concentrate more on patients who have an implantable electronic devices. So today we have several devices like the pacemakers, we have the leadless pacemakers, we have the ICDs, of which we can have a conventional ICD, we can have a subcutaneous or extravascular ICDs, we have the CRT devices, we have the loop recorders. So there are several devices available in the market. Of course, apart from other things like chances of infection and all, the most important thing that we are worried about is the chance of electromagnetic interference. So EMI can occur in any of these procedures, non-cardiac procedures, especially when you are using cautery, diathermy, radio frequency, or any source of electromagnetic energy that can interfere with the function of the cardiac devices. So when you have a pacemaker, the pacemaker actually sees this electromagnetic interference as an intrinsic cardiac activity, and it will stop pacing. So the patient can have a catastrophic asystole. If he is dependent on a pacemaker, he is going to have an asystole, and it can be catastrophic. So they can have inappropriate mode switches. Some pacemakers do have a rate response, and especially when they have a vibration sensor, it will sense it as increased activity, and it can increase the heart rate of these patients. Rarely these devices can go into a complete reset, which means the programming has completely gone and you have to reprogram the device immediately. We used to see this runaway pacemaker long back. As a student, I have seen only one case, but these current generation devices, we hardly see this kind of a complication. If it is an ICD, the most important problem is inappropriate shocks. The ICD can detect this electromagnetic interference as a ventricular activity, and it will deliver a shock to the patient. And these shocks can be really painful. Patients can move during the surgery, and if you are at a critical point in the surgery, any movement in the patient movement will lead to complications. So even the subcutaneous ICDs or the extravascular ICDs that are available, they can give inappropriate shocks because of myopotential oversense. The CRT devices, we can have a combination of both pacing and ICD malfunctions. We can have a loss of pacing, we can have inappropriate shocks. Very rarely we can have a complete device reset in a CRT, which can be very catastrophic considering these patients have severe LV dysfunction, they can land up in heart failure again. The implantable loop recorders, usually they are not much of a problem in the perioperative period, but whatever data has been there, it has to be retrieved before sending the patient to surgery, because you can lose the data because of EMI. So before you take this patient, it is essential to know what kind of a device the patient has. It is not unusual today that we have several patients who do come to us that some device has been put to me. We are not sure what the device is, whether it's a pacemaker, an ICD, or a CRT, you never know. A simple palpation of the prepectoral, you can see if it is a small device, it is a pacemaker. If it is a large device, it can be an ICD or a CRT. But still, it will be prudent to know which particular kind of a device. A simple X-ray in AP and lateral views can give us the clue to what kind of a device the patient has been implanted previously. So the comprehensive strategy involves the device clinic, where the patient has been checked previously, the pre-procedure checking of the device and optimize the settings and prepare the patient for the surgery. During intra-procedural period, you have to have monitoring and emergency management and the strategies to backup strategies. And post-procedure, again, you restore the settings and see that the device is functioning normally. So you have to plan appropriately, have the checklist, kind of pacemaker. You should know the manufacturer also. I'll come to that why. You should know the indications, especially if the patient is dependent on a pacemaker, you should be very careful. Any electromagnetic interference can lead to loss of pacing, the dependency of the patient. During the pre-procedure, it is essential to interrogate, program the device, and test the magnet response of the device. Obviously, intra-procedure is about monitoring the patient and backup responses. Post-procedure, again, reprogramming the device, and if the new settings, you have to inform the device clinic. This was what I said. We know that most of us are we know that we can put a magnet and turn the pacemaker into asynchronous pacing mode. But how will the pacemaker respond to a magnet? It depends on various companies. In the sense, different devices and different manufacturers have different magnet response. So it is essential to know which particular device and the company also to know what is the appropriate response, because if we don't know, we will not be able to tell whether the device is functioning normally or not. So a practical strategy in this patient is, if you have a infra-umbilical surgery and the device is far away, you can just proceed. But if you have a supra-umbilical surgery and the device is nearby, you see whether it is a defibrillator. If it is a defibrillator, just disable the ICD therapies, and if the patient is dependent on pacing, you have to have a backup pacing therapies. If it is not a defibrillator, it's just a pacemaker, if the patient is dependent, you switch on to asynchronous pacing mode and send the patient for surgery. If he is not dependent, it is probably safe to send him without any programming. Apart from the programming of the devices, there are certain strategies that we have to use to prevent electromagnetic interference. When you are using a cautery, keep the current path away from the device, as far from the device, at least 15 centimeters away from the device. Use bipolar cautery whenever it is feasible. Whenever you're using unipolar cautery, limit to less than 5-second pulses. Avoid whole body return electrodes. Let me emphasize this, a device with a low battery increases the risk of current intrusion and increases the risk of electromagnetic interference. Keep the magnet ready. and know the magnet response of various devices and various companies also. You have to have the device program always. It is advisable to keep it in the OR or near to the OR, and be ready for backup pacing, transcutaneous or transvenous. This is extremely important if the patient is dependent on pacing. If it is an ICD, apart from switching off the therapies, keep a magnet, but remember that the magnet can switch off the therapies, but it cannot go into asynchronous pacing. Backup pacing may not be available if it is an ICD. So you have to be prepared for having backup pacing strategies. When you use external defibrillation paddles, make sure that these paddles are far away from the device, at least around 7 to 8 centimeters away from the device. Especially anteroposterior paddles should be used in these patients. And leadless devices, we have quite a good number of patients with leadless pacemakers now. Remember, magnets don't work. You have to program the device prior to surgery. So these are the current guidelines that we follow. If you have a transvenous implantable device, if it is an ICD, you just have to reprogram if the patient is dependent on a pacemaker, we reprogram to a asynchronous mode and disable the ICD therapy. If not, just use a magnet. If it is just a pacemaker, if the patient is dependent, again, use a magnet or reprogram to a asynchronous mode. If the patient is not dependent, you just need to have a magnet standby and monitor the patient. Even for non-transvenous devices like a leadless pacemaker or a subcutaneous ICD, we have certain recommendation. If it is a subcutaneous ICDs, if the EMI is above the groin, I mean, it's very near to the ICD. Remember, it is a groin here because the subcutaneous ICD is much lower as compared to routine conventional ICD. You have to switch off the therapies if it is very nearby. Otherwise, if you think it is far away, no intervention is needed. For a leadless pacemaker, it is mandatory to program the device to asynchronous mode if the patient is dependent on this thing. So I will not take much time on the arrhythmias part because we can have any number of arrhythmias or almost all the arrhythmias are possible in the post-operative period. Sinus bradycardia is very common because of various reasons, hypothermia, drug effects or other things. Asymptomatic bradycardia does not require any treatment, but we have several drugs like atropine or isoprenaline or dopamine infusion can be used. AV blocks, the first degree AV block is usually safe and benign, but you have to monitor the patient to see whether this patient is going, especially if it is a new onset first degree AV block, which the patient doesn't have at baseline, it is prudent to monitor the patient. A second degree AV block, if it is a Wenckebacking, it is usually safe, we can just monitor the patient, but if it is a type 2 Mobitz AV block, these patients can have a high grade AV block. You have to be prepared for a backup pacing for these patients. Of course, a third degree AV block, again, if you have a narrow QRS escape rhythm, which is likely to be a stable escape rhythm, you can monitor the patient. But if it is a wide QRS and infrahesian disease, treat the conditions, treatable conditions, secondary conditions that we have seen, and get ready for pacing, transcutaneous, and if possible, transvenous. So we have the algorithms which have been given by the guidelines. Premature beats are very common, not required to treat normally, but beta blockade can be very effective if you need to do. A word about SVTs. SVTs are fairly common in the perioperative period. Most of them are actually pathway mediated SVTs. They are usually well tolerated. If there is no structural heart disease, patients are usually hemodynamically stable. We do have time to give IV adenosine or beta blockers in most of these patients. So of course, the one situation where you have to be aggressive is when the patient has a pre-excited atrial fibrillation, where cardioversion is the only treatment that can save the patient. Atrial tachycardias are quite common, around 6% of the patients. If the patient has a structural heart disease, again they are poorly tolerated. You can consider beta blocker or class 3 antiarrhythmics in these patients. Flutters, we can see flutters in such patients. Most of these flutters are patients with structural heart disease. We have a very rapid atrial rate. But mind you, the only problem that we are going to face is when the patient has a 1-to-1 AV conduction with a flutter. That is a situation where we have to be very aggressive and control the flutter on table. The treatment of an acute paroxysm, again, electrical cardioversion, class 3 and class 1C drugs are useful. Other things like beta blockers or calcium channel blockers can be used for rate control. AF is a frequent problem. I think among elderly patients and patients who have structural heart disease, the most common rhythm is rhythm disturbance is atrial fibrillation. Many patients who undergo CIBGs and other cardiac surgeries, they have almost 60% incidence of having atrial fibrillation. Post-operative atrial fibrillation is pathologically slightly different from other forms of atrial fibrillation. Control of ventricular response is essential. Class 3 antiarrhythmic drugs are useful and effective. Amiodarone is quite safe, especially in patients with structural heart disease. In patients with structural heart disease, we cannot give class 1C antiarrhythmic drugs. And of course, if the rhythm is unstable, cardioversion is the treatment of choice. But if the patient is having chronic atrial fibrillation before he comes to the OR, probably we should not rush to give amiodarone or cardiovert the patient, because these patients may have thrombi, which can lead to systemic embolization, and it may be unlikely, it's unlikely that the patient may revert to sinus rhythm and maintain sinus rhythm. So there is no point in urgency in trying to revert the patients to sinus rhythm. You can think of a rate control strategy in these patients. Ventricular arrhythmias are equally quite common. Isolated ventricular premature beats are fairly common in the post-operative period. Usually no treatment is required, but then keep a view about these things. If there are multiple morphologies or there is an R on T phenomenon, it is these PVCs that can cause problem in the operating theater, and especially if the patient has a structural heart disease. Lidocaine is a very useful drug in this particular situation, and IV beta blockers also can be used. A word about VT, I would like to emphasize here that we have to see whether it is a monomorphic VT or a polymorphic VT, because if it is a monomorphic VT, it is most likely to be a reentrant tachycardia, where all your class 3, class 1C, everything is going to help you. But if it is a polymorphic VT, none of these things are going to help you, because apart from the substrate, there are some dynamic components like ischemia or electrolyte imbalance or inflammation that are going on. So we have to be more aggressive with a polymorphic VT. So it is essential to identify whether it is a monomorphic or a polymorphic VT. Non-sustained VTs can be monitored safely. The main strategy is prevention and instituting immediate treatment. Monitor the electrolyte levels, especially potassium and magnesium. Of course, if there is hemodynamic compromise, DC version is the only treatment of choice. Amiodarone is safe and very useful in these things. The only problem is amiodarone has a slightly delayed onset of action, so we have to load the patient immediately. Maybe a double loading dose has to be given immediately. So the administration of multiple antiarrhythmic drugs should be avoided in this particular group of patients. Of course, ventricular fibrillation is one thing. It is a catastrophe on table, and if we can if we see any kind of this thing, the only thing is think about myocardial ischemia, treat the underlying hypoxemia, electrolyte imbalance, and start the ACLS protocols. Finally, a word about the drug interactions. Several anesthetic medications can induce arrhythmias. There is a long list of these things which can be found in any standard books. There are some interactions between antiarrhythmic medications and anesthetic medications. So we have to keep in mind that these drug-drug interactions are very essential to monitor these patients in these things. So to summarize, the arrhythmias in OR is not an uncommon phenomenon. In fact, it is a fairly common phenomenon. Most of these arrhythmias are safe and benign. The most important thing is to determine whether the arrhythmia is benign, the patient is hemodynamically stable, or the patient is going to be hemodynamically unstable. Then the choice of anesthetic agents is important. Prevention is as important as treatment. Recognition of risk factors and adequate selection of drugs is essential. Electrolytes should be monitored before and after the surgery. It's mandatory. Supraventricular tachycardia usually responds with treatments like adenosine, while AF doesn't respond. Class 3 drugs like amiodarone and sotalol are very useful and safe in this particular patient, especially those patients who have a structural heart disease. Don't underestimate the use of magnesium, potassium, and adenosine in managing these patients. The management in perioperative dysrhythmias does not always include the use of antiarrhythmic drugs, which should not be delayed and should be administered as early as possible. Thank you.
Thank you, sir. So we request you to stay back on the stage and join the panelists to chair the rest of the session, sir. The next speaker, Dr. I.S. Chaitanya Kumar, sir, Additional Professor and Head of Transfusion Medicine and Hemotherapy at AIIMS Mangalagiri. He is the first MD in immunohematology and blood transfusion from Andhra Pradesh with over 25 publications, significant leadership roles at AIIMS, and extensive expertise in blood banking, apheresis, hemovigilance, and transfusion safety. He has played a pivotal role in establishing advanced blood center services and national training programs and is widely recognized for his academic, administrative, and research contributions.
Good evening, everyone. At the outset, I'd like to thank Ramesh sir for giving me this opportunity. I'll go ahead with my presentation. I'm going to discuss something about the blood transfusion that is going to happen most of the times in cardiac interventions. I'll try to make some comments about organ transplantation also, because part of my field lies in that. And finally, the stem cells and regenerative medical aspects. But before I go into blood transfusion, I have to inform what is the current patient blood management guidelines, because there is something called blood health. We have been hearing about cardiac health, renal health, liver health. So similarly, WHO has also started something called blood health. The WHO has given latest guideline last year. So I'll try to mention few points from those also. Now if we see, this is what WHO has given in 2021, and the last year's book is more comprehensive. It has somewhere around 126 different strategies by which we can prevent transfusion. If we see part of blood banking is something that is related to giving and promoting our units, but no blood banker or no transfusion medicine expert will encourage their own blood unit be issued or transfused to patient. Why? This is because blood has many side effects. So this is one important thing. So we always try to do something called transfusion-free transfusion medicine. So the three pillars of this include detection and management of anemia and iron deficiency early, minimization of blood loss and optimization of coagulation during and later on also leveraging and optimizing the patient-specific physiological tolerance of anemia. So even if patient has some anemia, if he is able to tolerate, there is no need for transfusion. So I'll go into more of this. Any surgery, especially pertaining to cardiac surgery, there are many risks. For example, some procedures will have higher bleeding risk, especially redo cardiac surgeries. There will be some patient-specific factors and general risk factors as described here. It can be high age, coagulopathy, patient having multiple anastomosis. So all these will definitely affect the blood transfusion requirement for any patient. Now if we see, there are multiple criteria to say a patient may require or a patient may have perioperative bleeding, which may be somewhere between class 0 to class 4. So these are multiple definitions. And if we have to categorize what level of perioperative bleeding a patient has, then the worst case scenario has to be taken. Like for example, if a patient is requiring RF7A, it means it's directly a class 4 massive perioperative bleeding. And why I'm discussing regarding this perioperative bleeding is, if patient is having more blood loss, they will obviously require more number of units. So here we can see this is a study by Petro. So class 1 and class 2, they have clubbed together here. So patients who take less than 10 units during their surgeries, they have far better chance of survival. While the patients who are having more than 10 blood products or blood units transfused, they have highest chance of mortality. So this is why we try to avoid blood transfusion as much as possible, and we try to take so many measures. So this is one more latest guideline from transfusion medicine. So we try to do something called ROTEM test protocol. Usually people who have TEG, these are all point of care tests. So TEG is there, but we feel more comfortable with ROTEM because we can manipulate the ROTEM with different kinds of modifications. So this is one important thing. We try to transfuse patients depending on what characteristics the patient has in ROTEM. For example, immediately after a surgery, we try to check the clotting time in INTEM. INTEM means it's intrinsic pathway thromboelastometry. So if it is more than 240 seconds, it means that heparin, deheparinization or protamine is not sufficient. We haven't given sufficient amount of protamine, so we try to give protamine. If the maximum clot firmness is less than 9 mm, that is in FibTEM. FibTEM means fibrinogen thromboelastometry. We try to give them cryoprecipitate. Now fibrinogen concentrates are also available at lowest price, so we can use those also. And similarly, this is the protocol. This protocol is maybe useful for CT surgeons only. This cannot be used for maybe, for example, PPH patients may not be useful this protocol, because each and every category is different. So there are different protocols for different kinds of patients. ICU categories, ICU protocol is different. The protocol for neurotrauma is different. PPH protocols are different. This is for cardiac intervention. So similarly, we try to administer patients with platelets when the FibTEM is normal, but the amplitude at 10 minutes in extrinsic thromboelastometry is less than 40. So it means that platelets are not functioning. Maybe it can be due to various reasons. So this is one simple indicator. And last but not the least, if there is hyperfibrinolysis, we try to give them tranexamic acid. These are the guidelines actually from European Association of Cardiothoracic Surgeons. This was published this year only. So they suggest this protocol. So before admission only, we have to try to identify anemia, its causes actually, and manage the patient before we plan them for surgery. And pre-op also we have to do many tests, like for example, guideline directed management of antithrombotic medication, patient function testing is there. I'll go into these. So in addition to that, platelet function testing in patients, especially on dual antiplatelet therapy, is required. Fibrinogen testing is also required. So the recommendations are checking pre-op hemoglobin levels, then oral IV iron therapy, erythropoietin requirement may be there, anticoagulation and antiplatelet also may have to be managed. There are obviously some challenges, but depending on patient, all these are actually variable. And if we see this picture, we can see patients who are having neither anemia nor transfusion, they have very low chance of complications. If patients have anemia, the complication rate will be more severe. If they have received transfusion, some complications are again less. If both anemia and transfusion are there, then again the complications are more pertaining to different diseases. Now one can also see whether my patient require manipulation of dual antiplatelet or aspirin. So this is one simple tool. There may be many other tools. AI is also providing many tools now. So it will assess and give what is the risk of patient having bleeding. So maybe these kind of objective tools can also be used when we try to manage patients. So this is one more tool. There are like here actually there are multiple machines. So Verify Now is there, Multiplate is there, TEG is there, and ROTEM is also there. Even through ROTEM and Multiplate actually we can know whether aspirin that we are giving, whether it is functioning, whether the platelets are resistant or they are okay. They are currently we are able to stop the platelet function. Similarly in ROTEM and TEG also, there are different kinds of metrics, like for example ARATEM is which can be used for aspirin management, aspirin testing. There is ADP-TEM, there is again TRAP-TEM. So all these can be used for monitoring antiplatelet drugs also. And we were discussing about this also, the previous slides. So patients who are on aspirin, if it is emergency surgery, they can be proceeded to go for surgery. If it is urgent or elective case, if high risk of bleeding is there or patient is refusing blood transfusions, then aspirin may be stopped 4 days before surgery. If the patient is normal or has low bleeding risk, then aspirin can be continued. And dual antiplatelet therapy also, this has been discussed till now. This is one more protocol by European Journal of Cardiothoracic Surgeons. This is old strategy. So This has also been discussed by the previous speakers. Coming to intraoperative management, meticulous surgical hemostasis, autologous blood transfusion, especially acute normovolemic hemodilution, intra-op cell salvage, maybe using autologous priming also, ultrafiltration, heparin, protamine titration. So all these are some strategies that can help in reducing the intra-op bleeding. There are again different institutional algorithms that can be followed in the post-op period. As we can see, ROTEM is also part of it. Here also the same protocol. This is called cardiovascular A5 algorithm. So here also we try to first rule out hyperfibrinolysis. If it is ruled out, then we try to see whether heparin effect is there or not. Then we try to correct fibrinogen deficiency. If fibrinogen is deficient, then we try to give him fibrinogen complex concentrate or cryoprecipitate. Then this is followed by platelet requirement and generalized other factor deficiencies. We always try to give fibrinogen first because that is the factor that is first depleted in massive bleeding. And the other factor deficiencies can be rectified with FFP transfusion. The last is protamine overdose, where patient may require other drugs also. This is one more study, point of care hemostatic testing in cardiac surgery. Here we can see POCT guided transfusion management. This is from Germany. So it significantly decreased the odds of patient receiving allogenic blood products requiring re-exploration. Similarly, post-op acute kidney injury and thromboembolic events. So all these have been reduced, but no statistical differences were found in regard to hospital mortality, cerebrovascular accidents, or length of ICU stay and hospital stay during this study from Germany. So in the same study, what they have found is usage of ROTEM. It reduced somewhere around, the total transfusions were reduced to 17%. FFP utilization was also reduced by 64%. Platelet utilization was reduced by 10%. There was potential reduction of up to 70% in acute renal failure, sepsis by 86%, thromboembolic events by 100%, and the composite adverse events were reduced by 79%. So when we should test with what, I think there are many protocols pertaining to this, but this is what the latest protocol or guidelines is. So we try to check not only with ACT after release of cross clamp, we try to do XTEM and FIBTEM also in ROTEM, and after administration of protamine to correct the heparinization, we also try to do INTEM and HEPTEM. So these two will help us in treating the patient better and giving what the patient may require. So depending upon the size of amplitude increase required in ROTEM, we try to increase the dose of fibrinogen and various drugs also, including platelets. This is just one example. Here in the first picture, we can see all the times are prolonged actually, CT, CFT, A5, A10. So this indicates actually residual heparin. Below HEPTEM is there. So in this actually heparinase will be used when we do ROTEM. So here it is normal. So it indicates that heparin is still more, so this patient will require protamine. And this is the normal patient, so both INTEM and HEPTEM are normal. And the last patient is actually protamine overdose. So again, we have to manage this patient with either FFP or APCC. And we have to remember that protamine is not vitamin P. This is one more algorithm. So if people don't have a ROTEM, if they have TEG also, we can use a similar algorithm. Before I go further, actually there is the massive transfusion, massive blood loss protocols. Now in the beginning of maybe 21st century, we have been thinking the requirement is maybe formula driven, 1:1:2 ratio. Then later on it became 1:1:1 massive transfusion protocol, wherein we try to give 1 red cell, 1 platelets, 1 FFP. Now it is more of ROTEM or TEG guided. We try to call it as goal directed blood transfusion. So if patient has some issue, we try to give only those components. For example, this is what we follow for plasma exchanges and red cell exchange. We try to do this at least 2 to 4 patients daily, and we follow this protocol. So if patient's hematocrit is, if the patient is losing somewhere around 30% of his blood, we try to correct it with red cell. It can be priming the machine, it can be anything. If patient is going to lose 1 volume of blood loss, then we try to correct PT and APTT with FFP when the INR is more than 1.5. If the patient is going for 1.5 units of blood loss, means the patient will be already continuously getting crystalloids and transfusions. So if patient has lost somewhere around 7.5 ml, then we try to give even cryoprecipitate, and platelet count we try to administer whenever the platelet count falls less than 50,000. And this is only pertaining to what we can do. But when it comes to the blood banking part, there actually we have to see there are again 3 kinds of transfusions. It can be elective, there is something called urgent, but both can be clubbed together, and there is emergency. So if a patient requires on emergency, what we do is we try to give, sometimes if we have time for blood grouping, pardon me for the mistake there. So if we have time for grouping, we try to give them group specific blood actually. Even without cross matching, we can give immediately group matched blood in a span of 5 minutes to casualty, it can be OTs. So this helps the patient in avoiding the hypovolemic shock and acute kidney injury that can happen because of hypoxia. And after we do this, we try to do cross match also, and we try to see that everything, all the routine procedures will go on. Sometimes there may be a situation wherein, for example, if you have a positive patient, I have seen somewhere around 140 units being transfused to patient in a single day. So if all the A positive units are gone, if all the O positive units are gone, we have even transfused B units also to A patients also, and patients have survived without any sequelae, because when these patients are having so severe blood loss, the antibodies that may be present in their plasma may have already gone out also because of the blood loss. So sometimes transfusion may be the first priority rather than anything else. And if patients are going for elective surgeries, then it is always better to be planned, better to do blood grouping than antibody screening. In UK and US, the basic protocol is to do blood grouping and typing and screening also. So all these help us in identifying patients who have some antibodies, so that if they require blood transfusion, we can be sure that we will be having some cross-match compatible units. Otherwise, in the end, if we want suddenly blood units which are compatible, it is difficult. And similarly for Bombay blood group, sometimes there will be patients who have multiple antibodies, like patients with sickle cell disease, thalassemia, maybe sickle cell disease with acute chest syndrome. Getting blood units for them is more difficult. Some of these patients have also been from Ramesh Hospital and all nearby hospitals. So similarly, managing patients who are already having some bleeding disorders or coagulation disorders requiring this is also difficult. Transfusion reactions are also there, and managing these is again, it depends on each center. There can be many possible reasons which can harm the patient, including improper storage, transport, appropriate transfusion. If we are transfusing something else other than normal saline with the blood units, it can also cause hemolysis. Usually we find all these as maybe simple jaundice after the patient has been transfused, maybe in 6 hours, sometimes even after 1 day, 2 days. So it's a tricky thing we have to go through. We have to see through and investigate, and all these have to be reported to Hemovigilance Cell of India. And in addition to this, we can also help in something called cardiac transplantation. We don't do cardiac transplantation, but we can help in HLA typing, high resolution also, low resolution also, donor specific antibody testing we do, finally active antibodies identification, single antigen bead, and other kinds of investigations to rule out the patients are not having antibodies directed to the donor units, especially the cadaveric things. We can do cross-matching also, and if antibodies are there and if we have to do transplantation, we do plasma exchange for these patients. And if you are if you are finding a patient who may require cardiac transplantation, then it is always better to get him transfused if he requires especially only leuko-reduced blood units. It can be packed red cells, it can be platelets. And in addition to this, we also usually have blood centers licensed for stem cells. So we try to collect autologous units most often. I was involved in a study at SWIMS Tirupati, wherein we have done somewhere around 50 to 100 units of autologous stem cells. They were injected into intracoronary actually through angiogram, and there were many patients who were from abroad. They were receiving these and they had significant better ejection fraction after these stem cell injections. I think this is again coming up recently, so this we can help. And similarly now it is also for heart failure patients. The market for this is also growing day by day. This is one place I wanted to show. First bloodless heart transplant in Asia. And in the future, as my previous speakers were telling, AI is on the rise, so medical management may be going slowly towards AI also. This is one doctor, the doctor actually emergency medical hologram. So in future, we may also have to take suggestions from them. Even if we don't take the Gen Z, immediately they take a screenshot of the case sheet which we may be writing. They will just ask AI in Google Lens, it will show. So we have to be prepared for this event also. Thank you all.
Thank you, Dr. Chaitanya. Back to basics. In the last month, when we are having national conference on the anesthesiology, one speaker from France is asked to give talk on blood management. He has given 14 grams as the level at which below which we call it as anemia. Is it true in India, or every country is having its own parameters? Or it is universal?
Normal hemoglobin, sir, you mean to say?
Yes, we call below which we call it as anemia.
There is no such thing as per like hemoglobin based anemia is there, sir, but we try to think of anemia as a deficiency in oxygen carrying capacity. So technically there is sometimes if a patient is on like example carbon monoxide poisoning is there, the patient's hemoglobin may be 15 but still he is technically anemic.
No, that is chemical differentiation between carbon dioxide taking and actually there is no guideline as you said below which we call it as anemia. In the textbooks we are having some number.
Like for example,
is it still valid?
I don't think this number is every year changing, sir. Like for example, for pregnant women it is less than something less than 10.5. For normal women less than 12. For male it is somewhere less than 13. But it does not affect them, so it is okay. We can call them as asymptomatic anemia.
So it may be different from each community and country and also
definitely varied, sir.
And food habits
yes,
and all
sir.
these things.
Similarly, thrombocytopenia is also there. So if we go to maybe the eastern part of India, like Assam, then West Bengal, they usually have platelet count of somewhere around 1 lakh only. Okay. We cannot think that they are having mild thrombocytopenia.
Is there any level at which blood transfusion should be given? It is, it was said 7 grams previously. Is there any alteration or variation in it?
WHO recommends, yes, sir. WHO recommends between 6 to 7 grams, sir. If patients are asymptomatic. If patient has some cardiopulmonary respiratory embarrassing condition, then we can also transfuse blood less than 10 grams also. If for anesthesia actually anything above 8 is okay. And if patients are having maybe sickle cell disease or thalassemia which has how to say dysregulation of oxygen transport, we may have to maintain hemoglobin level somewhere between 9.5 to 10.5.
Time permits, can we rise the HB by iron transfusions there?
Yes, sir.
Prescribing instead
Definitely.
of giving blood.
Always we have to, as long as the patient is asymptomatic, we can always try to go for medical management only. Blood transfusion is only recommended when there is no other option. If patient is going to die without blood transfusion, only then blood has to be transfused. Means the risk of blood transfusion, if it outweighs the benefits, then there is no point in transfusing.
What is about Jehovah's Witness, people who are refusing blood transfusion? How to go ahead with them?
There are some patients, some of those patients actually do come, sir. And for them actually, some of them they accept autologous transfusion, some of them they won't accept autologous transfusions also. So if they accept autologous transfusion, then we can do something called pre-deposit autologous blood collection. There is something called leapfrog technique, and we can go for intra-operative also hemodilution, acute normovolemic hemodilution. Maybe we can also go for cell salvage. It can be intra-op and post-op also. But patients who don't accept their own blood also, for them there is no other option other than medical management.
2 days back in the government setup, I used to do autologous blood transfusion, but is it practiced now? I don't know.
It is practiced itself.
Thank
Many
you.
people do that if they have option. If we take consent from patient will automatically choose autologous blood first.
Yes, sir. Thank you.
Thank you, sir.
Thank you, sir. I
Let
request.
us, you want to, sir? No, please, if you want. Okay.
Thank you.
Now I request Dr. Shilpa ma'am, intensivist of critical care medicine, Aster Ramesh Hospitals, to join the panelists to chair the session. The next speaker is Dr. Niren R., consultant infectious diseases, Aster Ramesh Hospital.
Thank you, ma'am, for the introduction. So I think we are towards the end, the last lecture for today. We have been talking about cardiac patients undergoing non-cardiac surgery and all the rest. So I will be mainly concentrating on the sepsis part, the perioperative period, how you assess patient regarding the risk of sepsis in them, and the initial management of sepsis in them. So to first say sepsis, how is it affecting the perioperative mortality? So if, for instance, the normal perioperative mortality expected is around expected to be less than 5%, sepsis itself can increase it up to 25 to 30%. But when it is superadded with the underlying cardiac conditions, especially when there is heart failure, the mortality can increase up to more than 60%, which is huge considering the burden of sepsis in India and how we are treating it. So the main problem here, when sepsis adds on to the cardiac patients, it acts as a double hit. So already there is a compromised function. The sepsis, the inflammation and the infection adds on to the stress for the cardiac and further compromises the heart function. So that is why it leads to such huge. So especially when the patients are in shock, when they are already having a cardiogenic shock and sepsis adds on to it and forms a bit of a component leading to distributive shock as well, it becomes very difficult to treat these patients and leads to increased mortality and morbidity. Sepsis per se is also a huge dangerous accelerator for atherogenesis and cardiomyopathic remodeling, and this can lead to adverse MACE events later on in their life. So that is why we need to assess the sepsis mortality in the perioperative period and try to minimize its risk. So what we can do in the preoperative period is to look and control the comorbidities like diabetes, obesity, and the nutritional status. Smoking is one of the important risk factors which increases the odds of sepsis by 1.32%. And also sir has now talked about blood transfusions. So blood transfusions itself is also causes increased risk for perioperative sepsis. In post-operative period, there are challenges many to say for even detection of sepsis in these patients with underlying cardiac dysfunction and how to treat sepsis in these patients with cardiac dysfunction. So to first, in assessment of sepsis risk in cardiac patients, the important pre-existing cardiac conditions we have, the common one, ischemic heart disease, increases the odds ratio by around 1.3 to 1.5%, while the presence of any heart failure increases the risk by around 1.8, so it almost doubles the risk of sepsis in these patients. But the most important risk factor which has the highest odds is actually the right ventricular dysfunction. So the presence of a right ventricular dysfunction increased the odds ratio to almost 2.32 times the normal patients. So what are the limitations for the risk model? So normally when you look at the perioperative risk, we have talked about some of the risk factors. We have the RCRA score, which we commonly use. But they lack key variables when it comes to determining the risk of sepsis in the perioperative period. So you need to have at least ejection fraction, lactate, and some of the things to actually improve. There are risk models which are rarely used to assess for the preoperative models. So also we have some of the biomarkers that are now available that can help us in stratifying the risk in these patients. We have procalcitonin, CRP, which are included in some of the risk factors. We also talked about D-dimer, neutrophil lymphocyte ratio as a marker of immune status in the perioperative period, and also the cardiac reserve by using troponin and proBNP. So all this combined with clinical factors can actually give us a multimodal risk stratification with the help. So these two new models are now most appropriate, I would say, to assess the perioperative sepsis risk, classed to be the common, especially when it comes to emergency surgeries. For elective surgeries, AUB-HAS2 also can be used when it comes to assessing the perioperative sepsis risk. When you talk about optimizing the perioperative risk, the pre-op time, most important is also pharmacological and also functional optimization. Nowadays, most of the patients are on SGLT2 inhibitors, and this is becoming an increasing risk factor for the perioperative mortality and perioperative sepsis, especially when they land up in emergency situations. So it is always better if you can stop SGLT2 inhibitors at least 3 to 4 days before an elective surgery. And also, you need to continue statins, beta blockers, especially when they are used chronically. You should also try to improve in the functional status of a cardiac patient whenever you are planning for an elective surgery. Try to increase their inspiratory muscle strength, advise for aerobic exercise wherever possible, and also optimize their hemoglobin and albumin. So let's look a little deeper into the pathophysiology of sepsis in cardiac patients, especially when it comes to sepsis-induced cardiomyopathy. So it forms a vicious cycle. Sepsis affects cardiac and cardiac actually worsens the septic shock. So whenever there is sepsis, there is a release of a lot of cytokines, which actually can lead to mitochondrial dysfunction and microvascular dysfunction, ultimately leading to myocardial dysfunction and leading to sepsis-induced cardiomyopathy is what we see. So this ultimately will lead to a vicious cycle that can go on. But as I said earlier, there is one thing which has the highest odds with perioperative mortality risk of sepsis. That is the right ventricular dysfunction. So it is always important you also assess the right ventricle when it comes to assessing the risk. So for the right ventricle, you need to assess the pulmonary resistance. The direct myocardial, you need to assess the volume status of the patients as well. And this ultimately is directly related with the highest most to perioperative mortality, is an independent predictor of mortality, and ultimately your LV function most of the times in these patients is also dependent on your RV dysfunction. So sepsis and heart failure, as I said, it's always a vicious cycle that goes on. If your heart failure worsens in a septic patients, the patients are going to go down. And if you have sepsis in a patient with decreased cardiac reserve, again the patient's condition is going to go down a lot. So this inflammatory triggers, which leads to endothelial damage, will then exacerbate any cardiac dysfunction which is already present. So how to identify sepsis in these cardiac patients, post-op especially? So what we have classically used is the SOFA scores to identify sepsis. So SOFA, we actually recently have the SOFA 2 score that has been published in JAMA in October and September. So they have made slight changes, especially when it comes to noradrenaline doses and the thresholds when it comes to hemostasis and liver. So this we can use, but this is for the general population. For cardiac patients, main thing is these lacks two important things, which are the blood pressures, lactates, heart rate. So these, when you look at the patients or with cardiac patients going into sepsis, the two main systems that are involved in all these systems are the cardiac and the renal. So we should be more careful in assessing these two systems when it comes to cardiac patients undergoing having sepsis. So the initial hemodynamic management when it comes to sepsis, the important part is always fluid. But that was the most difficult part to do in case of a cardiac patients with reduced function. So we talk about liberal strategy when it comes to sepsis, but for cardiac patients, we tend to be on the restrictive side. To assess the correct fluid responsiveness is the most important part. Speakers have already talked about dynamic fluid response assessments before me. You have bedside equipment, you have bedside ultrasounds now easily available even in intra-op period. So you can use this to assess dynamically, which are much better to correctly assess the preloads and afterloads and determine if the fluid you are going is going to improve the cardiac function or deteriorate it. Vasopressors. So when it comes to sepsis in cardiac patients, along with fluid, you always tends to start vasopressors as well simultaneously, because that will actually decrease your need of fluids at the same time, give some support for your heart which has especially dysfunction. Norepinephrine should always be the first line for the various reasons. The second line drug, that is where the key is, vasopressin is what is recommended, but you can individualize. For severe LV dysfunction, you can use dobutamine. For RV dysfunction, whenever you have it, milrinone is actually a very good drug that can improve your pulmonary resistance. Coming to the initial antibiotic management, I will not talk about the antibiotic choice, but I will tell you about how to give the antibiotics in these patients. So the most important thing is to actually calculate renal clearance in a cardiac patients. So what we use generally, the urine output or the creatinine to measure EGFR are very poor methods to actually calculate renal clearance in cardiac patients. The ideal way is to go back to the basics, calculate the urine, serum creatinine for a short duration, and that keeps changing actually day by day. So that is the best way to actually calculate renal clearance in these patients. Of course, you can use some other adjunctive tools like kinetic GFR and cystatin C if they are available. The pharmacokinetics, so while renal clearance is one part, with the cardiac patients you also have increased volume of distribution. You have the problem of underdosing when you have this increased volume of distribution. While you have sepsis, heart failure and diuretics, difficult to determine the renal clearance, and the renal clearance is also becomes very dynamic. So that is why you have the problem of underdosing, especially in the bolus doses, and maybe overdosing when it comes to maintenance doses. So it is very difficult to correctly identify the creatinine clearance and appropriately dose the antibiotics. But with also advancements coming up, there are also challenges coming up with antibiotics. So we have an increased use of extracorporeal therapies, the support systems that we have. The dosing for these extracorporeal therapies actually has to be standardized, that are becoming now more common. The problem is you also have antibiotic sequestration with these extracorporeal therapies. You will have obviously increased volume of distribution, and you need frequent dosings. So to summarize, what I want to tell is sepsis and heart failure, they definitely form a deadly vicious cycle when they are together. And it will be very good if you preoperatively optimize the risk factors and reduce the risk of sepsis in these patients. You need to adopt a very restrictive, at the same time dynamically marker guided fluid strategies. It is always better if you can use a kinetic renal clearance and find the right dosing for your antibiotics in cardiac patients. So, thank you.
Thank you, sir. I request Dr. Kirti Chigurupati ma'am to accept our token of appreciation and respect. Ma'am, please. I request all the other panelists to join. To do the honors, I invite Dr. Chaya Devi and Dr. Suma ma'am. Now I request Dr. Ramakrishna sir to accept token of our appreciation, and to do the honors, I invite Dr. Karthik Chaudhary sir and Dr. Fani Rajkumar sir onto the stage. I call upon the next presenter, Dr. Padmaja Cherukuri, Consultant Anesthesiologist, Aster Ramesh Hospitals. I invite Dr. Somnath sir, Consultant Cardiologist, to chair the session. Dr. Ramarao sir, Consultant Cardiologist, Aster Ramesh Hospitals. Dr. Fani Rajkumar sir, Surgical Oncologist, Aster Ramesh Hospitals. Dr. Raja Ramesh sir and Dr. Madhukrishna sir, Consultant Interventional Cardiologist, Aster Ramesh Hospitals, to chair the session. I request Dr. Rakesh sir also to join them to chair the session.
Good evening, everyone. This case is a 84-year-old female patient who presented to ER with a history of fall followed by pain in the left hip joint. She's a known diabetic and hypertensive on medication. She doesn't have any history of coronary artery disease, asthma, thyroid, or seizure disorders. There's no past surgical history, no history of drug hypersensitivities, or she's not on any antiplatelet medication. On physical examination, she was of short stature, vitals were stable, airway was good. Investigations, X-ray revealed a trochanteric fracture of left femur. Her hemoglobin was 8.8 gram%. Sugars were on the higher side, GRBS 198 milligram per DL, HbA1c was 7.5. ECG showed T inversions in chest leads V2, V3. 2D echo EF was normal. Grade 1 diastolic dysfunction, aortic valve sclerosis was present. Rest of the reports were within normal limits. A cardiologist opinion was taken for fitness of surgery, who advised to do a CT coronary angio in view of diabetes, age, and ECG changes to rule out any silent CAD. But since the patient attenders were not willing, she was given moderate risk for non-cardiac surgery with heparin backup. Patient is posted for ORIF with proximal femoral nailing of the left femur. Pre-op orders were given, 2 points of Paxil were reserved. Telmisartan, which she was using, was withheld on the morning of surgery. Anesthesia part, under strict aseptic precautions, spinal was given with bupivacaine and dexmedetomidine. Co-loading done with normal saline. The level was T10 after 15 minutes. Patient was comfortable, catheterized, and then positioned. Intraoperatively, PF nailing was done under strict aseptic precautions. The surgical time was 2 hours. Vitals were stable intraoperatively. BP maintained at 110 to 130 mmHg with 10 mg of ephedrine intermittently. Saturation was 100% with 2 liters oxygen. Estimated blood loss in the surgery was 200 to 250 ml. IV fluids given intraoperatively is 1.5 liters. The fourth point of normal saline was on flow. The urine output emptied was 700 ml. In the immediate post-op, patient was shifted to post-op ICU for recovery. When connected to monitor, the ECG showed atrial fibrillation with a heart rate of 156 per minute. On examination, the patient is completely asymptomatic, conscious, coherent, following commands, no complaints of palpitations or dizziness or chest pain. Her pulse was irregularly irregular. BP was 90 on 60. Chest was clear. ABG was done, which showed metabolic acidosis with a bicarb of 18. Sodium and potassium were 137 and 4.2 respectively. 2D echo was done, which showed a fair LV and an IVC of 1.47 centimeters. After confirmation of AF in the 12-lead ECG, the patient is reassured, attenders were counseled, injection noradrenaline infusion was started, blood transfusion was started to compensate for any blood loss intraoperatively. Injection amiodarone 150 mg slow IV was started after the systolic BP increased to 110 mmHg as advised by the cardiologist. After 1 hour, patient was comfortable, still no symptoms. Injection amiodarone was given. Vitals were BP 130 on 90, heart rate 150 per minute, AF is still present. Blood transfusion was on flow. Injection noradrenaline infusion on flow. After 2 hours, patient still asymptomatic, Paxil transfusion completed, noradrenaline was weaned off, spinal anesthesia was wearing off. Vitals were stable and her heart rate was 86 and reverted to normal sinus rhythm. Maintenance fluid was started at 100 ml per hour. On the first post-operative day, patient was comfortable, normovolemic and off IV fluids. Repeat hemoglobin was 8.8 gram per cent. So second point of Paxil transfusion was given. Endocrinologist was on follow-up for diabetes. Prophylactic injection Clexane was started. Patient was discharged in hemodynamically stable condition with a hemoglobin of 10 gram per cent on the third post-operative day. I would like to ask the cardiologist in the panel, are there any ECG changes that we can detect on the monitor before occurrence of AF?
I didn't get your question, ma'am.
Are there any ECG changes that can be detected on the monitor before the occurrence of AF, atrial fibrillation?
No, the rate irregularity only we can detect. Are you specifically asking any markers in the pre-procedure ECG?
Yes, sir, like prolongation of P wave.
No, the risk factors we can make it, or like elderly, female, CKD, history of hypertension. So those are the subset of the patient where there is increased risk of development of atrial fibrillation.
And which is better for thromboembolism prophylaxis, sir? Direct oral anticoagulants or vitamin K antagonists?
No, that depends upon the subset of the patients. If it's a non-valvular atrial fibrillation, we can give either, but if it is in valvular, then we have to use the vitamin K.
Yes, sir. And any role of prophylactic amiodarone that can be given in high-risk patients for elective cardiac and non-cardiac surgeries? Role of prophylactic amiodarone?
There is no role of prophylactic. All the studies done were negative only. There is no prophylactic loading of amiodarone in any patients to prevent the post-operative atrial fibrillation.
Yes, thank you.
AIs can predict, it seems, nowadays. ECG read by AIs, they can predict. And other, maybe if you are watching the monitor, frequent atrial ectopic starts coming, then you can check whether something is going wrong which is causing that. Otherwise, that is maybe a precursor for AF. Otherwise, pre-op ECG means AI. Or otherwise, natural stupidity of the cardiologist.
Thank you, sir.
Thank you, Dr. Padmaja. Thank you. Now I request Dr. Ramesh to present the case on post-operative MI, the best practices, management practices.
Yeah, good evening, everybody. I'll keep it simple in view of that time. So my topic is the combination of talks what they have spoken in the last 3-4 topics. The topic of the Dr. Kirti and Dr. Naren combining the sepsis, myocardial injury in a non-cardiac surgery patient. So the patient is 55 years male, occupation by farmer. Risk factors wise, he's diabetic, and he had a previous history of admission 6 months back with chronic pyelonephritis, and from then on he is in CKD stage 3 with no history of hypertension, CAD or dyslipidemia. This was the previous admitted with the pyelonephritis, sepsis, at that time normal LV function. He was treated with IV antibiotics and insulin and fluids, and he was improved and discharged. The current admission is for the fever for 5 days, abdominal pain, vomiting and hyperglycemia. These are the inflammatory markers with the rise at CRP. Procal obviously is in sepsis, and creatinine mounting up from 2.3 to 5.3. The imaging shows the CTKOB, hydroerythronephrosis and bulky kidneys with infection, emphysematous changes, and the blood grows the E. coli. This is the admission ECG, which is showing some sinus tachycardia. We all think of it is due to the sepsis and fever. And this is the chest X-ray, which is more or less clear. So the urological procedure wise, he underwent left DJ stenting under local anesthesia, the pus drainage and from the PCS. Immediately after the procedure, he developed sudden dyspnea, pulmonary edema, and requiring the NIV support. So we all thought why this sudden increase in sudden onset of pulmonary edema. So in this patient, we can think of multiple causes like sepsis causing the capillary leak and ARDS like picture, or CKD causing the volume overload, or any LV dysfunction or ischemia causing the pulmonary edema. The troponin was 14,000. Just now we have a discussion on means that is myocardial infarction in non-cardiac surgery, and echo is showing new onset RWMA and ECG showing sinus tachycardia. This is the post-operative ECG, and this is the X-ray. Definitely we can see when compared with the first X-ray, there is a pulmonary edema. So we are stuck here, and post-DJ stenting patient developed pulmonary edema with positive cardiac troponin and new onset RWMA. Now we have to do either intervention or medical management. For going an intervention with worsening of creatinine, subjecting the patient for this sin. And if you are thinking of medical management, already the patient developed pulmonary edema and requiring NIV support. So without intervention, for ischemia may further worsen. So after discussing with the nephrologist, we are ready to do the dialysis if requirement, step-ins, and we went ahead with the angiogram. So the angiogram showing a lesion in the LAD and LCX. And we have done an OCT for the LAD in view of the intermediate lesion in the LAD, and to demonstrate exactly where there is any plaque rupture or thrombosis. There is a lipidic plaque with stenosis of 60 to 70%, and we have stented both the LAD and LCX. And the AK worsened after the PCA as expected. Regions may be to the SIN, or it may be a baseline CKD or hyperperfusion or sepsis. So gradually the patient has improved, and we are able to discharge after a week with a creatinine of 3.2. So these are the different learning points that you have taken from this case. So silent CAD can be present and extremely common in these diabetic and CKD patients. The underlying sepsis sometimes can mask the cardiac ischemia. So any new increase in troponin, and if there is any RWMA, treat it as ACS. And if his EKG changes are present, don't hesitate to do an angiogram. Anyway, we are going to do the dialysis in the CKD patients. And regarding the type 1 and type 2 MI, this case with positive troponin and RWMA in pulmonary edema, we consider it as type 2 MI. So we have not delayed the angiogram, and we reviewed the case immediately with the multidisciplinary team to save this patient. Thank you.
Yeah, thank you, Dr. Raja Ramesh. Now I request Dr. Madhukrishna to present the perioperative sepsis induced myocardial dysfunction.
Good evening, one and all. Uh, after all exhaustive discussion, this is a very controversial question, controversial topic and understudied case. Here, a 45-year-old male came to the hospital for calcanean implant removal, which was done outside in January month of this year. So he is a 45-year-old and he had no comorbidities, no significant family history of CAD or non-alcoholic, non-smoker. So whether you want to do any cardiac risk assessment or not is one question. So how routinely will you advise in this age group for cardiac evaluation? This one. And in asymptomatic patient at this age, how will you approach for non-cardiac surgical fitness? So general, if you go by guidelines, there are no, if the patient is asymptomatic, just go with whatever your surgery. So his illness started at the month of the January and underwent surgical correction for his fracture. At that time, no documentary evidence of ECG and echo. After 3 months, he had discharged from the surgical site and advised removal of implant, for which surgeon advised cardiologist opinion for fitness. There, echo suggestive of regional wall motion abnormality in LAD territory with LV apical clot. So the cardiologist advised medication for 3 months and given high risk for surgery, and CAG also differed. So after 3 months of wandering, this is the old report. After 3 months of wandering, so patient came to Yelloor Ramesh Hospital for the fitness for surgery, where the echo suggestive of regional wall motion abnormality in LAD territory with ejection fraction of around 35%. With LV apical aneurysm, referred to main branch for cardiac evaluation. This is a ECG. There are the subtle ST segment depressions in the inferior leads, and investigation suggestive of whatever the previous finding. So this is the echo, which is suggestive of regional wall motion abnormality in LAD territory with their pseudoaneurysm or healed hematoma, like contained ruptured hematoma picture. And we did the angio, which suggestive of triple vessel disease. LCX is LCX and OM are 90% diseases, and LAD proximal lesion 90% disease, and RCA proximal also critical disease. So here the question is, do you want to go with surgery, or do you want to go with cardiac revascularization or implant removal first? So if you go by the guidelines, especially if at this age group, there is guidelines differ any of investigation, like going with ECG also, because patient is asymptomatic, there is no ECG, no echo. But if you go with our practice here in this case, especially in this case, so patient is already in LV dysfunction. So after multidisciplinary team discussion, in view of the age and triple vessel disease with the LV dysfunction, we removed the first infected prosthesis, and we are planning for elective surgical revascularization of coronary artery disease. So in Indian subcontinents, as coronary artery disease is occurring in younger age population, screening for non-cardiac surgery may be considered when compared to the Western people. For high-risk non-cardiac surgery, especially in resource-limiting conditions, better to have cardiac evaluation even in younger patients. That's it.
Both these cases were excellent cases for discussion. Unfortunately, people are not there. Otherwise, we wanted all these surgeon and everybody to be there to discuss some other forum sometime.
Because if you go with the patient, the level of injury, this comes under a low risk patient. But there is a LV dysfunction is there. So because of the LV dysfunction.
Anyway, I know the case. You don't tell me. You tell the audience if anybody is there.
Okay, sir.
Yeah, thank you, Dr. Madhukrishna. Thank you, chairpersons. Thank you, the audience and everyone.